Good morning.
Listening ears, watching eyes, and healing hearts. I welcome thee all to the 5th Annual CME Matters of the Heart 2016, organized by Ace Heart and Vascular Institute, Mohali, in association with Indian Medical Association, Mohali, under the auspices of Punjab Medical Council. Thank you all for accepting our invitation and spending your valuable time to be with us. As rightly quoted by Sir Albert Einstein, intellectual growth should commence at birth and end only by death. The first and most supported goal of this conference is achievement of academic excellence. We at Matters of Heart recognize that sessions of today's conference encapsulates the presentations of unique clinical cases, discussions on most recent trends, innovations, concerns, practical challenges encountered and solutions adopted in the fields of cardiovascular diseases, and provide a state-of-art medical information to all our participants. It is my fervent wish that we all have a fruitful day and leave this hall with much stronger knowledge base, clearing all our dilemmas, questions that we face in our everyday clinical practice. Without delaying much, I would like to call upon stage Dr. Puneet K. Verma, Director, Matters of the Heart Conference. Now I request Dr. Sanjeet Singh Sodhi, President IMA Mohali, to join us on the stage. Now I would request Dr. Puneet and Dr. Sodhi to jointly welcome Dr. Professor R.D. Sabru on stage. Professor R.D. Sabru, please join us on stage. I hereby request Dr. Harpreet Singh to join us on dais. Dr. Harpreet Singh Galofra to join us on dais. I hereby request Dr. Shikha Verma, please join us on stage.
Speed behind the whole function.
I would request Dr. Mandeep Singh, Medical Superintendent, Ace Heart and Vascular Institute, to please join us on dais. Now I would request the organizing committee jointly please invite and honor Dr. Chief Guest Dr. Ranjeet Kaur Guru to please join us on stage. शुभम करोति कल्याणम आरोग्यम धन संपदा शत्रु बुद्धि विनाशया दीप ज्योति नमस्तुते दीप ज्योति नमस्तुते. We hereby salute the lamp of light which will activate the Sankalp Shakti of God and create a protective sheath around the venue and create positivity around this conference. So I invite our Honorable Chief Guest, Dr. Ranjeet Kaur Guru, Professor R.T. Sapur, Dr. Suri, and Dr. Puneet K. Verma to please light the honor of now. Without wasting much of the time, I would start the summit by inviting Dr. Puneet Verma, the course director, to give an inaugural address.
Good morning, everyone. Thank you so much for taking out time on this busy Sunday morning and being with us. We understand it's not easy to spare Sundays, and hence I apologize from my side also for a delay in the start of this conference. It's indeed a privilege and honor to welcome you all to the 5th annual CME of ACE Heart and Vascular Institute Matters of the Heart. We understand that India is in the midst of a cardiovascular epidemic, and needless to say that affordable healthcare in our country is still available to only 1 to 2% of our patient population. But despite that, we feel that all is not lost, and even if high-tech care is not deeply penetrative enough, we still feel that primary preventive strategies, which are more important than tech-based care in our country, have a much greater role to play in the decades to come. Short of that, I don't see this epidemic going off anywhere in the next 3 to 4 decades. The theme of our conference, I mean, when you look at this prevention paradox, where despite India having made progresses in many areas in the field, especially whether it's science and technology, space, education, but somewhere we are lagging behind in the health sector. And the reasons I feel may be political, apolitical, cultural, socio-economic, there are many reasons for that. But the prevention paradox essentially prevails in our country. And today's conference essentially attempts to address this concern. When you look at the lecture layout, which starts from preventive aspects of cardiovascular health and goes on to showcase what technology can do for your better well-being. So I hope you people, all of you, the attendees, respected teachers, senior colleagues, friends, members from the industry, when you listen to these talks, they are designed that even people who do not understand medical science in depth can still take away some carry-home messages. And I strongly feel that one should try to inculcate these things in a day-to-day living. So thank you all for being here and have a very fruitful day. Thank you very much.
Now I would request Dr. Sodhi to please enlighten us with a few words.
Deep.
Honorable Chief Guest, dignitaries on the dais and on the dais, a very good morning to you all. First of all, on behalf of IME Mohali, I would like to congratulate Dr. Punit Verma and his entire team for organizing this wonderful event. He is an accomplished cardiologist, as you all know, and having attended his earlier CMEs, I can vouch for the high academic content of this one also. Cardiology, as you all know, has been advancing very fast, and as bad practitioners, we may not be able to cope up with all the advancements and all the new developments. And attending this kind of CMEs will definitely help us in our bad practice to give our best to the patient. Apart from that, more and more awareness needs to be created because cardiology is taking a huge toll on the lives of the people. And now I think probably we would require some kind of a surgical strike on cardiology or diseases also. Now with these words, I once again congratulate Dr. Punit Verma and I extend all support from IMA to him for his further CMEs, and I hope and pray that we will have many more CMEs every year. Thank you.
Thank you so much, sir. Now I would request Dr. Harpreet to please say a few words.
Good morning everyone, a warm welcome for the conference. I want to congratulate Dr. Punit Verma for organizing this academic event and taking everybody along without any feeling of competitiveness or something. He has taken every cardiologist, every physician along with for his academic endeavor as well and for his hospital also. So I hope that everyone will take good memories and good knowledge from the conference. Good morning to all of you.
Thank you so much, sir. Now, on behalf of the whole of organizing committee, I would request our honorable chief guest of the day, Dr. Ranjit Kaur Guru, to please say a few words.
All dignitaries on the dais and cardiologists from all over the area, delegates, guests and friends. Good morning everyone. It's a great pleasure to be here on this occasion of 5th annual CME Matters of the Heart organized by ACE Heart and Vascular Institute Mohali. I appreciate the efforts of Dr. Punit Verma and his team, director of this institute, in organizing this conference in association with IMA Mohali, headed by Dr. Sanjeev. We celebrated World Heart Day on 29th of September this year, and the theme was how to keep heart healthy and healthy heart environment. As we all know that India is the capital of heart diseases, and we have 4.5 crores of heart patients in our country. And it comes to 60% of all the patients of the world of heart patients. Every fifth adult is suffering from hypertension, and at the same time we have around 6 crore people suffering from diabetes also. We are genetically predisposed to this condition and very vulnerable. We are very vulnerable to these cardiac diseases, and we get this problem 10 to 15 years earlier as compared to other countries, to the developed countries. and it is increasing very fast, and it is increasing fast in number, and the trend is also increasing. And now the situation is that our patients need surgical intervention at very young age, as early as 30 to 40 years, which is 10 to 15 years earlier than the developed countries. And this is a matter of concern for all of us. And if there is a family history, and then this predisposition is doubled if there is a family history in the patient. And the chances are more, the risk of developing heart disease becomes double. And 90% of the risk factors throughout the world are same. All over the globe, the risk factors are same. These are multifactorial, which includes tobacco use, smoke, overweight, obesity, which includes wrong eating habits with extra salt, extra fat, extra sugar. There is lack of exercise, or there is no exercise at all in our agenda. We have a sedentary lifestyle. We are suffering from hypertension, diabetes. Stress is there with urbanization, and there is more and more refined things in our diet. Refined oil, refined flour, more of the processed food, junk food, less of fiber, and this is all starting at a very young age in life. And we are unaware of the fact that the cholesterol start building in our arteries, clogging our arteries at very young age, as early as the first decade of life, at 8 to 9 years of age, and ultimately resulting into stents and surgery in later life. As these are all modifiable risk factors and can be controlled by lifestyle modifications and regular exercise, by yoga, by meditation, and keeping balance between diet and active lifestyle, physical activity, healthy eating habits, healthy working environment, as small as using stairs at workplace, outdoor games, sports for our children. As our children, we see that most of the time they are playing more on a computer games and on mobile. We can inculcate healthy habits in children by modifying their food habits, like making some changes in school canteens and giving them good healthy food. Unfortunately, in 70% of the people, the symptoms of the attack are taken as muscular pain, nausea, vomiting, acidity, gas symptoms, gas problems, and taken as GI symptoms. And when this occur and especially when this is occurring very early in age, as we see nowadays, and so the people, they do not go to hospital, they shy of going to hospital because they don't expect that they may be having the heart ailment, and as a result the diagnosis is delayed and we lose the opportunity of reporting within the golden hour, and for that awareness is very important. Government is running a program, this is included in the national program for the communicable diseases, for control of communicable diseases, in which cancer, cardiac diseases, diabetes and stroke is included. And for this, because people may not be knowing all this, so Government of Punjab has started Sehat Jagrukta Muhim, and this is started from 5th of November to 5th of December. For full 30 days, 100 vehicles are hired, publicity vans are hired, and they will go to all places, every nook and corner of Punjab. They will go to villages, they will go to rural and all the urban areas and bring about the awareness regarding the health programs run by the government. The Department of Health and Family Welfare just recently concluded the Health Summit regarding the universal health coverage and SDGs, which was on 11th of November, and where we have WHO representatives, the WHO head of South Asian countries, Mrs. Poonam Khetrapal, and then we have Dr. Han, we have Union Health Secretary, and 10 health secretaries of principal secretaries of health from 10 states. They all attended this summit, And these CMEs and workshops are great instrument for brushing our knowledge and polishing our skills towards better clinical practice and making our people healthy. As we all know, health is the real wealth and we can only enjoy wealth when we are healthy. As per our saying that Jaan hai, Jahan hai, and there is one another saying that Pehla Sukh Nirogi Kaya, Duja Sukh Thodi Si Maya, Tija Sukh Charitrava Nar aur Nari, Chautha Sukh Agyakari. So in the last, I thank the organizers. I thank Dr. Puri for organizing such a wonderful workshop and for giving me this opportunity of meeting you all. I wish you a successful this scientific feast. Thanking you all. Thank you very much. Jai Hind.
Thank you so much, ma'am. We will take the words of wisdom home today. And now, I would request and have the pleasure to invite Professor R.P. Sapru, former Head of Cardiology, PGI Chandigarh, to please enlighten the audience with his knowledge and bless the young audience of the rise and on the dais.
It's a great pleasure for me to be invited to this particular function today, and I thank Dr. Puneet for that. CMEs, of course, play a very important role in updating information, which is in any case changing so rapidly, particularly with the infusion of technology in the medical world. It's very important that people get the opportunity to exchange ideas more frequently than has been going on in the past. Having been witness to much of the changes or the transformation of medical practice over the years, I can well understand the complexities of modern medical care, and therefore the need for these CMEs, exchange of information. Dr. Verma has been doing this exercise every year for the past few years, and I hope he continues to do this in the future, and it gives an opportunity to all the practitioners of medicine and cardiology to meet together and exchange their ideas. Thank you very much.
Thank you so much, sir. That was so mind-boggling, and we will take your advice home. Now, I would request Dr. Puneet Verma, Course Director, Matters of the Heart, to please honor our Chief Guest, Dr. Ranjit Kaur, with a small token of love. Now I would request Dr. Professor R.P. Sapru to please accept our wishes. Dr. Sanjeev Singh Sodhi to please join us and accept our wishes. Dr. Shikha Verma, Managing Director, A. Sarjan Management Institute, to please accept our wishes.
That is a wonderful moment. Wow, wow, wow. कौन किसको दे रहा है पता नहीं है.
Dr. Said Bhosra, please accept our wishes.
बहुत खूब.
Dr. Manveer, Dr. Manveer Singh, Medical Superintendent, A. Sarjan Vascular Institute, to please accept our wishes. Thank you so much, all of you, for joining us on the dais. Well, ladies and gentlemen, we are beginning with our first session of the day. The session is chaired by Professor R.T. Sappu, former Head of Cardiology PGI Chandigarh, and to co-chair I request Dr. Sachin Verma, Consultant Cardiology, to please join us on stage.
So, good morning friends, ladies, gentlemen, honorable chief guest, members of the faculty, some new invitees this time. As I think has been amply shown and amply lectured by Dr. Guru in the morning during the inauguration ceremony about the growing epidemic and the lifestyle problems which we are going through in India. And not only India, it's basically worldwide, which is actually propagating the epidemic of cardiovascular diseases. We feel it's appropriate to just go back in history and just see what has happened in these last 2 decades and what are the current guidelines as to manage our primary preventive strategies with this very special group of cholesterol-lowering drugs called statins. Almost 4 years back, this presidential advisory from the World Heart Federation, American Health Association came that striking down people, this heart disease and stroke is striking down people in their prime in developing nations. People in their 40s and 50s are getting crippled, and doing nothing about this is essentially going to cost us nearly $47 trillion in the next quarter of a century. And countries like India, where low and middle income people reside, the annual debt on this country comes to nearly $500 billion, and 80% of debts we now know occur in this part of the world because of cardiovascular diseases. So while statistics have shown us that there is a rising trend of coronary artery disease in India, and India has the dubious distinction of being the coronary capital of the world, we see that the rising graphs tend to show us that there is almost a 2.58 million deaths projected in the year 2020. But equally shocking is the fact that if you look at the statistics of 2015, we seem to have surpassed the statistics of 2020, even 5 to 7 years in advance. So India is certainly making progress in acquiring disease, cardiovascular diseases, and you look at the number of Indians with CAD, it's not 4.5 crores any longer, ma'am, it's probably more than 70 million, even this 61 million may be an underestimate. And the number of deaths due to coronary artery disease are probably now touching close to 3 million. And the problem with Indians is not only in India alone, but whether you see Indians as they reside worldwide, Canada, England, Singapore, any part of the world. The problem is that Indians have a much higher CAD mortality compared to people of other ethnicity. And similarly, if you look at Indians residing abroad and getting hospitalized for coronary artery disease, well, they are at least 3 to 6 times they have greater rates of hospitalizations versus their other South Asian colleagues, their South Asian populations, whether it's the Chinese, Japanese, Filipinos, etc. And this obviously, India therefore tops in the healthy life years lost to cardiovascular diseases, which is known as the disability adjusted life years, which you see India is far ahead of China, Africa, Middle East, South America, and other Asian countries. So how preventable is heart disease? We understand just like cancer is preventable in maybe 40% of the population, 80% of premature heart disease, stroke, and type 2 diabetes are preventable. The preventive interventions range right from primordial prevention, where you have to prevent the onset of risk factors, primary prevention, where you have the risk factors but not the disease, secondary prevention, where you have acquired the disease and you want to avoid further events taking place with as a sequelae of the disease, And tertiary prevention, we all understand, is all high-tech care, which is affordable, as I told you in the morning, to just 1 to 2% of our patient population. What Dr. Ranjit Kaur in the morning told us, this is the difference you can make if you can adopt a healthy lifestyle. If you can adopt a healthy lifestyle, you can prevent 90 to 95%, account for decrease in heart disease risk of 90 to 95%. Whether it's by controlling cholesterol, your blood pressure, quitting smoking, controlling your body weight, and having a good physical routine along with a good balanced healthy diet. The secondary preventive strategies have clearly shown that right from the days of aspirin, beta blockers, ACE inhibitors, statins, and finally cessation of smoking, you can get a combined, if you are adopting all these medical strategies in your patients, you can at least hope to reduce heart diseases by about 70%. Tertiary prevention, as I told you, is a privilege which is accorded only to the very few in the country, and this includes a lot of technology-based procedures carried out in tertiary care cardiac hospitals. This is the paradox of prevention in India. What I mentioned in the morning, that the high-tech hospitals in India have their resources purely focused and directed at very few people who can afford it. Whereas the large percentage of patients needing effective primary and secondary preventive medications, which are far more effective and much less expensive, are not receiving it. A simple drug like aspirin, if you give to 1 million patients, over 1 year you can find that at least 1,000 heart attacks can be avoided, and cardiovascular events, also total CME events, can also be reduced by about 1,300. Even though there is a risk of bleeding in total bleeding episodes, but non-trivial and major bleeds in 1 million patients just accounts to about 2,500 patients. So what are the categories of risk factors we are looking at? The Adult Treatment Panel 3 defines them as 3 major independent risk factors: the life habit risk factors and the emerging risk factors. We all understand that if we exclusive of the LDL cholesterol goals, smoking, hypertension, a low good cholesterol of less than 40, a family history of premature coronary artery disease, and age of more than 45 and 55 years in men and women respectively, constitute the major risk factors which are then programmed to modify the LDL goals. The HDL cholesterol, if it's more than 60, which is very rarely seen in our Indian population, counts as a negative risk factor. So if you have any one major risk factor above and an HDL which is more than 60, you can deduct this from one of your above mentioned risk factors to calculate your total risk. The life habit risk factors are well known, as I mentioned, about being overweight, physically inactive, and not having a balanced diet, and a diet which is more prone towards unsaturated, monounsaturated fatty acids rather than being a balance of polyunsaturated fatty acids. It's also important to know that there are certain coronary heart disease risk equivalents which manifest in the form of peripheral vascular disease, diabetes, and multiple risk factors. That means more than 2 risk factors which confer a 10-year risk for coronary artery disease to be more than 20%. So these are 3 additional categories where you may not have frank coronary artery disease, but you could have manifestations of these such conditions which could be a window into your coronary health. So risk assessment, as I said, is very important. For patients who have more than 2 or more risk factors, you must perform a 10-year risk assessment to see where they actually fall. And generally with patients with 0 or 1 risk factors, this assessment is not required because the overall risk is less than 1% per year. We also understand that there is an additive risk as you keep acquiring risk factors in your life. A simple hypertension which carries a mean absolute risk of about 8% amplifies to 27% if that hypertensive patient with age develops high cholesterol and begins to smoke. So accordingly, these are the 3 categories of risk that modify the LDL cholesterol goal. Coronary artery disease, frank CAD and its risk equivalents, the LDL goal should be kept below 100. If you have 2 or more risk factors, the goal should be modified to 130. And if you have none or 1 risk factor, the LDL should be kept below 160. These are the guidelines of the ATP3. They may or may not be applicable to our Indian population. I will tell you why. Of the emerging risk factors, lipoprotein A, homocysteine, various pro-thrombotic factors and pro-inflammatory factors which could be measured, impaired fasting glucose, and subclinical atherosclerosis, which can be either mentioned by coronary calcium scoring or ankle brachial index being less than 0.9, or a carotid intimal medial thickening also are all windows into your coronary health. A few words about lipoprotein A, since this seems to be dominating our Southeast Asian population, especially in India. This is a special lipoprotein which is a mixture of both lipoprotein A and lipoprotein B100, essentially synthesized in the liver, and it is believed to be a predictor of premature coronary disease and is associated to a large extent in India with malignant atherosclerosis. It's a powerful determinant of restenosis following cardiac interventions, and it is believed that it's a risk amplifier in people who have traditional risk factors. So when you don't have traditional risk factors and you still fall prey to coronary artery disease, it's important that you look at certain emerging risk factors of which lipoprotein A in India is the most important. Why? Because if you look at this slide and you look at how lipoprotein A amplifies the risk in smokers, hypercholesterolemia, hypertension, diabetes, and with hyperhomocystinemia, you will understand what is the importance of LPA in promoting premature coronary artery disease. Indians who don't have CAD have a rough average value of mean value of about 14 lipoprotein, 14 milligrams per deciliter. And in frank coronary artery disease, this number just doubles itself. So if you look at the average, the controls and the coronaries on the right side of the screen, the average of this is about 14 and the average of this is about 28. So this is the importance of measuring lipoprotein A in patients with coronary artery disease in India. And even when these Indian patients are residing abroad and they begin to be called as Americans of different ethnic origin, you will see that their lipoprotein A levels are quite high versus their Native American Hispanics, and they only are matched by the black population in the US. So India has been, or Indians have been blessed with this double jeopardy from nature and nurture. Nature, as we believe, is controlling the genetically determined LPA, and nurture being the unhealthy lifestyles associated with affluence, urbanization, and mechanization. And I would now think you can add demonetization in that as well. These are some of the risk factors which I just elucidated, that these are more common in the Asian Indians and they are contributing to the underestimation of CAD risk, whether it's the abnormal lipoprotein constituents of the body, increasing incidence of diabetes and pre-diabetes in India, the metabolic syndrome essentially driven by the abdominal obesity, lack of good diet in even good households, and of course the inflammatory and other pro-thrombotic factors which are all propagating coronary artery disease. Recently, Delhi was in the midst of air pollution, and again, this is also believed to be one of the reasons for coronary artery disease in India. So when you see Indians with conventional risk factors as suggested by the adult treatment panel, all you need to do is multiply that risk by 2 times. So a calculated Framingham score of 10% certainly would become 20%. And this scoring is done based on smoking, history of hypertension, HDL cholesterol, age and gender. So the net result of all this exercise is that you must keep the Indians 10% lower for all risk factors except for total cholesterol, which should be 20% lower than the guidelines. And the HDL, the LDL cholesterol and non-HDL cholesterol, which should be 30 milligrams per deciliter lower. So a waist in males which is regarded as less than 40 inches normal in the Western population has been brought down to 35 inches in Indians, in males, and in females it is 31 inches respectively. The definition of obesity in India starts at a BMI of 25, overweight being more than 23. Hypertension again has been modified based on our premature coronary tendencies, and importantly the sugar values also, Indian goals are revised because we understand that being the diabetic capital of the world and having extensive malignant atherosclerosis, diabetes as well needs to be defined in more stricter terms. The physical activities are believed to not 30 minutes a day, or as we conventionally say 150 minutes a week, but it should at least be 1 hour every day. So the treatment goals for Asian Indians, as I mentioned, should be 30 milligrams for people with frank coronary disease, chronic kidney disease, diabetes, metabolic syndrome, or even with elevated lipoprotein A. Your goals should be less than 30 milligrams versus the Western population. And similarly so for people who do not have all these risk factors, the goals are again kept 30 milligrams higher than the disease goals, but overall 30 milligrams still lower than the Western population. The lipoprotein A levels, as I mentioned, should be kept below 20. Well, I would think they should even be kept lower, maybe below 15 in the Indian population. So statins, from the times that we started our training in cardiology, we were all given these lectures by our seniors, and we were made to write thesis on these kind of drugs as to how cholesterol management changed over from the 1980s to the 1990s, and statins obviously at that time occupied the apex position in controlling cholesterols, and mind you, they still continue to do in the last 25 years. So HMG CoA reductase or statins inhibitors, or statins as we call them, are very potent LDL cholesterol lowering agents. They reduce triglycerides as well, but have poor HDL cholesterol raising properties. Maximum raising HDL is seen to the tune of about 15%. Their major side effects of myopathy and increased liver enzymes are easy to monitor, but they cannot be used in patients with liver disease or if patients are on certain other drugs where interactions are quite common. But over the years, they have shown that statins along the entire spectrum of cardiovascular diseases are very potent drugs to reduce all major coronary events, mortality, stroke, and even the need for procedures of revascularization. These are the big 5 trials. If you look at the first 3, the top 3 being the secondary prevention trials, and the lower 2 being the 2 primary prevention trials based on which our understanding of statins began. And they are known as the big 5. If you look at what the primary prevention trials did, they showed a nearly 37% decline in total CV events and a 25% decline in mortality, versus the secondary prevention trials where because of the disease amplification, the benefits were greater to the tune of 40% and mortality reductions of nearly 35%. The first trial came up only in pure male population, which was the West of Scotland study, and it showed that over a period of nearly 6 years, if you give a statin called pravastatin in a fixed dose of 40 milligrams, you can achieve a 31% relative risk reduction of coronary events of non-fatal MI and deaths. Similarly, the Air Force Texas coronary atherosclerosis program showed that again over a period of 5 years, if you use lovastatin in the dose of 20 to 40 milligrams, mind you, lovastatin and pravastatin are now hardly used, but they were the drugs which actually gave us insight into the genesis of the benefits of statins. And you get a nearly 37% reduction in events over 5 years. But these two trials essentially did not address patients with diabetes, patients with stroke, or patients with peripheral vascular disease. And even as time went by, we started seeing that patients with low cholesterols were also getting heart attacks. So this particular category was never addressed in these two primary prevention trials. And the heart protection study, which was published in 1999 and thereafter with certain modifications in 2002 with further meta-analysis, it showed that if you have patients with or without coronary artery disease, with other vascular diseases and with diabetes, and this was taken as high-risk patients who may or may not have had CHD, you found that a simple drug like simvastatin, or in a fixed dose of 40 milligrams, was the first drug to show that total mortality could be reduced by using statins, not only vascular but total mortality as well, to the tune of almost 13 to 17%. The major vascular events took a good risk reduction of nearly 25%, and the curves of major vascular events over the next 6 years, they continue to diverge. So you could see that the benefits of statins were not transient or temporary, they could be sustained in the long run. Whether patients had prior coronary artery disease or diabetes, they were all benefited to the tune of 25%. It also showed that simvastatin can reduce the impact on revascularization, impact revascularization positively by showing a 24% risk reduction, and similar impact was seen even in patients as far as stroke prevention was concerned. But what this study showed for the first time was that people who have low cholesterols, LDL 100 to 130 or even below 100, could be further benefited by use of statins. So the major medical conclusions which this study gave, this was a mixture of both primary and secondary prevention trial, but it did show that high-risk patients and diabetics with or without prior CHD, regardless of baseline cholesterol, had a significant reduced risk of major events when they were treated with simvastatin over a period of 6 years and onwards. And therefore the recommendations came that all these patients with diabetes, peripheral vascular disease, cerebrovascular disease, regardless of baseline cholesterol levels, should be considered for simvastatin therapy. A year later, the ASCOT trial showed in its lipid-lowering arm that hypertensive patients with 3 or more risk factors with a mean LDL of 132 could, followed up for nearly 3.5 years, used on simple atorvastatin 10 milligrams a day, could reduce all coronary stroke events by 27 to 35%. And this was taken as, this is the reason why we advise atorvastatin 10 milligrams for primary prevention in patients with multiple risk factors. This study did not show any effect on all-cause mortality, as has been shown by simvastatin, and the concern for the first time came on statins that maybe the incidence of heart failure, development of diabetes and renal impairment began to emerge as a concern with use of atorvastatin. But considering the magnitude of benefit the drug accorded, these things have still kind of gone in the background. So it became quite clear that lower the LDL, the better it is for the patient, And log scales actually show that if you decrease 1% decrease in LDL cholesterol can reduce your CHD risk by 1%. And the relative risk for one was set at a LDL cholesterol of 40 milligrams per deciliter, and it was shown that for every 30 milligram rise in LDL, the CHD proportion changes by about 30% from a value beginning at 40 milligrams. So as from 40 to 70 to 100, the LDL keeps rising, so does your risk of acquiring CHD by about 30%. Diabetics in this CARD study also were treated with atorvastatin 10 milligrams per day. Diabetics who did not have any apparent vascular problem but maybe just had retinopathy, albuminuria and hypertension. And this also showed that you could reduce the events in diabetics by 37% by using a simple atorvastatin in a fixed dose of 10 milligrams. The concept of inflammation thereafter came a year later in the year 2003, even though we believe that inflammation as a routine was not recognized, but somewhere inadvertently it had been addressed in the clinical trials. But we believe that inflammation, which is essentially found in the clots where the atherosclerosis builds up, we believe that atherosclerosis is an inflammatory pathology. And it is measured by the levels of high sensitivity CRP in the blood. And if you look at even low normal to high normal CRP levels, starting from less than 0.5 to more than 2 or to more than 2, you find that there is an incremental risk of future myocardial infarctions with rising CRP levels, even if they are not very in the very high range. So could statins be protective in this subset of population, where LDL cholesterol was low, but the CRP was high? So this came out pretty clear that going back nearly a decade ago from that time, they found that people who had high sensitivity CRP actually tended to benefit from statin therapy versus those patients who did not have high CRPs. So this raised this formed the genesis for justifying the use of prevention with use of rosuvastatin in interventional trials. And this was the Jupiter trial, which showed that if you take patients who have high hsCRP of 2 or more, an LDL of less than 130, but they have no prior cardiovascular disease or diabetes, you could get a massive reduction in CV events in this trial, nearly ranging from 44-45% to going up to 65%, especially in people in whom the LDL cholesterols could be brought down to below 50 or below. So this was another trial that showed that lower the better, especially when it was seen that the side effects were hardly there to justify the enormous benefit which this trial showed. And the reason for that was that the maximum reduction of hsCRP was seen in the Jupiter trial, which actually showed that that was the reason why the patients had almost twice the predicted event rate of reduction. And this was also further proven in its analysis that the first 1 year of LDL cholesterol values which you get in any trial or any of your patients when you start them on primary preventive strategies, it is your LDL cholesterol at the first year of measurement after starting therapy which defines what is going to be the risk of your patients. So this is what the Jupiter showed, that in its first year, people who showed an LDL of below 50 in its first year had much greater reduction in coronary events versus the other trials. So statin therapy in primary prevention is essentially the need of the hour. Why? Because atherosclerosis begins in childhood, it progresses silently, it can be mitigated at an early age with reduction in risk factors and can be slowed or reversed with statins. Statins have shown that it not only reduces cardiovascular events, but it also reduces all-cause mortality. and the benefits of statins are far, far superior to that of any other medicine which holds meaning today in cardiovascular practice, whether it is diuretics, beta blockers, aspirin. If you look at the numbers needed to treat for primary prevention of cardiovascular diseases, well, this number is you need just about 35 patients to prevent one event by using rosuvastatin, versus if you have to use a drug like aspirin, where you have to aim at a value of nearly 350 to 400 plus to get one benefit. So whether it's in the primary prevention or in the secondary prevention strategies, when you start lowering LDL cholesterols by these values, your relative risk reduction is essentially the same, whether it is primary or secondary prevention. They start declining, the risks starts declining from 20% to 80%. So it's believed that the earliest age to start statins, of course, is still a debatable issue, but the earlier you start, the better it is, because with declining time and increasing age, the benefits of statins also tend to wane off. So now statins have become the foundation of preventive cardiology in both primary and secondary prevention. But essentially, what we have seen so far is that statins, their use has been seen purely in the white population with increased LDL, with high CRP, with diabetes, with hypertension. What about a country like India? Do we have all these patient subsets in our country? I would think not, but I would also tend to believe that yes, we have a very intermediate risk population in our country, where we have all these parameters of increased waist-hip ratio, dysglycemia, smokers, mild renal dysfunction, low HDL, quite characteristic of a population, and family history of CHD. We may or may not be hypertensive. We may or may not have high LDL cholesterols, as we say that if our LDLs are below 100 or below 130, do we need statins? Well, the answer to that might be yes, we need it. And this is what the HOPE-3 trial just published or just finished and reported lately, a global trial in 228 centers from 21 countries, in which India was one of the participants, has shown that if you use a fixed dose statin, rosuvastatin 10 milligrams a day daily, or you use a drug like candesartan with hydrochlorothiazide in a fixed dose, irrespective of whether the patient has hypertension or not. See, this is the catch here. You are now treating patients who do not have hypertension, but you are using a drug based on a simple premise that ARBs may also be the plaque modifiers or disease modifiers in the times to come. And then you combine both these therapies in patients. So that means it's essentially a 2x2 factorial design trial, where 3,000 odd patients are either on pure rosuvastatin, on a combination, or on candesartan, or on a double placebo. And what do we see? And Indians were at least, maybe Asian population were at least 20%, of which India was prominently figured. You see the mean LDL just about 128, HSCRP median values of just about 2, not very high. And when you look at their follow-up of nearly 6 years with a compliance of 99% and a very high adherence rate to all these things, you find that even in patients who were normotensive, the overall average blood pressure reduction was just 6/3 millimeters of mercury, systolic and diastolic respectively. And when you look at what blood pressure lowering did versus the placebo, it did nothing. It actually did nothing for whether it was your CV deaths, MI or stroke, or extended events of cardiac arrest, revascularization and heart failure. Just a 5% benefit, if at all. But if you looked at that subset where patients were truly hypertensive with a mean pressure of 150 or more, you found that yes, maybe candesartan had a 27% protective property here, a neutral here, and a harm and a tendency to cause harm if your systolic pressure or mean or in the lowest tertile was less than 122. So the similar things emerged when you looked at the extended parameters of major cardiovascular events. And the only side effect which candesartan obviously did was lightheadedness, because when you use blood pressure lowering drugs in the normotensive population, that is a realistic possibility. So the event reduction with candesartan was only acknowledged in the highest third of the systolic blood pressure, where systolic blood pressure was more than 140 or mean was more than 154. And the results thereafter were either neutral or harmful in the low blood pressure group, or normal blood pressure group, I would say. But look at what cholesterol lowering drug does even in people who have normal LDL cholesterols. You are able to reduce LDL by about 35. You are able to reduce CRP by about 0.2 milligrams per liter. And you find that all benefits of rosuvastatin 10 milligrams fixed dose are seen across the entire spectrum of cardiovascular disease, except that CV deaths as an isolated event were not significantly affected by rosuvastatin. But if you look at it comprehensively in a combined MACE, you will find a 25% benefit over a period of 5 to 6 years, with well-defined safety and no major side effects of rhabdomyolysis or myopathy. So the conclusions came that a 10 milligram fixed day rosuvastatin has a potential to reduce events by 25%, irrespective of your cholesterol, blood pressure, your overall risk, your CRP levels, and importantly, ethnicity. Because ethnicity was one thing which had not been studied in the previous trials of statins, especially with respect to the Asian population, especially India. And when you combine the two drugs, rosuvastatin and candesartan, and again studied the patient population, the effects were almost akin to that of rosuvastatin alone. What you need to see here is that a combination resulted in a 28% relative risk reduction versus a candesartan which only provided a 5 to 6% protection. But the benefits of this combination again were seen in the highest systolic blood pressure ranges. Why? Because obviously candesartan worked better there. And in the lower two systolic blood pressure, that means when blood pressure tends to be normal or on the lower side, statins work better. And when blood pressure is on the higher side, statins and the antihypertensive regime works better. Meaning thereby that you can reduce your vascular events by 30 to 40% in a very intermediate risk population, which till now was essentially being neglected. So this was the clinical implication of the HOPE-3 study, that it is a pragmatic strategy. Why? Because you don't need frequent lipid or blood pressure criteria. You don't need lipid or blood pressure criteria. There is no dose titration, and there is no need to frequently monitor the side effects because of the low dose of statins being used. So from the intense statin therapy, we came on to the low dose statin therapy working equally well in our Asian Indian population. And one of the reasons for that is also that in India, the non-HDL cholesterols and then in our Asian population is very, very important parameter. If you look along the horizontal axis, you will find that with increasing LDL cholesterol, the events are not so much amplified as if you look in the other direction. You find that if you go along the z-axis upwards, you find that with each rising non-HDL cholesterol tertiles, your CV risk begins to get amplified. So it's believed that where you cannot get the targets of LDL or LDL cholesterol, you must try to achieve a 50% reduction in your non-HDL cholesterol category and even in LDL cholesterol. So although the risk of diabetes is slightly increased, we would think that statins still in absolute terms are much beneficial for the reduction in coronary events. The absolute benefits from statins increase over time, and therefore the treatment should be continued and then not stopped, especially if you don't have any other serious comorbidities. It is believed that broader and earlier use of potent statins in adequate doses to achieve and maintain a non-HDL of less than 100 to 130 has a huge potential to reduce the burden of cardiovascular diseases than all other interventions combined. So we must begin our preventive strategies at an early age. Our thresholds for intervention and goals for treatment should be defined in our Asian population vis-a-vis the Western. The benefit of statin therapy appears to exceed that of the antihypertensives and anti-diabetics. And lipid-lowering therapy with statins has to be amongst the first line of treatment rather than the last thing we do for our patients. Atorvastatin 10 and simvastatin 40 certainly continue to be our core drugs. In patients with high CRP, we use rosuvastatin 20, and a very relevant 10 milligram dose is very applicable in our Indian population with intermediate risk. I thank you for your attention.
That's been a very illuminating presentation and shows you the evolution of thinking as far as therapy for lipids is concerned. And on the line of vein, as it seems to me what Dr. Puneet is suggesting is that you should have your candidatin and rosuvastatin ready to your morning puri chola or samosa and carry on with
What a
life.
thank you knowledge.
But that's what I like to do. Okay, thank you. It's quite obvious that Indians are the favored nation for heart disease, favored race for heart disease. But it's also interesting, if I go back to 1947 when I was in school, and you look at 2016, the growth in heart disease has been phenomenal. I was wondering as to why this is happening. Our genetics has not changed all that much. What has changed? I do not wish to elaborate on this very much more, except to leave this thought with you, that progress comes at a cost. And heart disease is one of the causes. There are probably simpler ways of reducing heart disease in the community, provided we are really determined to address the issue. And the reason I say this is we know the poison that smoking is, how it kills everybody. Yet we are unable to stop smoking. A simple, straightforward, evidence-based recommendation. Remove tobacco. We're not able to remove tobacco from our society. Likewise in other areas. Another point that I wish to make before I throw this open for discussion is that there continues to be a certain reluctance to continue with medication for a long period of time. Most patients are uncomfortable with the thought that they need to continue with statins for life, as it were. And it's important that we doctors in our clinics or in our workplaces reinforce this message time and over again, that there are certain areas where treatment has to be lifelong. It is not available to us to discontinue this treatment because you lose all the benefit of the treatment. Now, unfortunately, this message is not clearly given to the patients. And I would make this request at this forum. Please make it a point to educate your patient about the need to continue with the treatment almost life. Unless there's a reason for discontinuing, that's a different story. And with that, I'm throwing it open for further comments and discussion.
I think we are 45 minutes ahead of time, so we can allow only a couple of questions from the audience.
So regarding the incidence of cataract in Hawtree increased.
Yes.
And secondly, where would you place treatment of triglycerides? Because recently the VIP trial, 20 years data have been published, which favors the treatment of triglycerides. So what are your comments on that?
Well, it just depends on the guidelines do suggest that if your triglycerides are high and the use of fibrates, the target still remains getting onto non-HDL cholesterols. The issue is that you should still focus on LDL, but try to get your non-HDLs below the recommended levels. So that's the basic thought behind it. Yes, the BIP trial has shown that use with phenofibrates and all, fibrates certainly has, this has been actually, was actually foreseen many years ago also. I mean, if you look at the earlier trials, including this trial where we would present data on triglycerides, we would clearly show that people who had lower HDL cholesterols were the ones who were benefiting the maximum even from fibrate interventions in patients with diabetes and coronary artery disease. So that result doesn't come as a surprise actually. But people, I think, went away from that area and they started pursuing the non-HDL goals, which I think is also very equally important because non-HDL essentially tells you your VLDL burden. And VLDL is, we know, directly or indirectly associated with triglycerides. So I would agree on that front, certainly. It's only that what thresholds of triglycerides would you take to start fibrates would be an area of discussion. At what level, for example, Dr. Murli would agree that even if people come to you with uncontrolled diabetes and high triglycerides, I don't think we really give them triglyceride lowering drugs. We would actually start with better glycemic control and then maybe at a certain defined level of a glycosylated hemoglobin decide to intervene with phenofibrates.
Punitji, while complimenting you for the wonderful lecture and direction to the foreign physicians, one modified factors you said in preventive part of it, the blood pressure 140/70 or on anti-hypertensive drugs. What do you mean by that?
Sorry, I didn't get your question.
Your slide was saying the modified factor that
140/90.
149 or on anti-hypertensive drug. The people are on anti-hypertensive drugs.
Yeah, so they may be 130/80 on antihypertensives. They may be 120/70 on any person who is on antihypertensive drugs. That means he at some time in his life was either 140/90 plus or being a heart failure diabetic could have been 130/80, 85 plus. So he is right now on antihypertensive means the risk is equivalent.
Thank you.
Dr. Puneet, how will you address the issue of laboratory little a, which you said there is a risk factor unique to Indians?
Yes.
How will you reduce it? Because the only drug which reduces is the niacin.
Niacin, yeah.
But it's no longer being used.
No, see, even with elevated LPA, the issues are more directed at LDL. Let me be very clear. LPA helps you to prognosticate, helps you to understand why premature coronary artery disease, if at all. It helps you to identify a high-risk patient population where you may introduce preventive strategies much ahead of their times to come. For example, if you today identify a 20-year-old college student with high LPA with a family history of CAD, and you recognize that you understand that in the years or decades to come, he is an individual who is prone to coronary artery events. So you would like to start the primary preventive strategies, whatever they are, whether they are lifestyle linked, TLC as we call therapeutic lifestyle changes, or they are drug related. They have to be, the families and the population needs to be counseled that there are certain genetic abnormalities in their constitution which unfortunately cannot, they have to only control it with their lifestyle. So certainly LPA is, the levels may not be suppressible, but its effects, the effects can be made suppressible by controlling your LDL and HDL or the non-HDL cholesterols.
But niacin, you should not be using niacin in such.
Well, that's been discussed a number of times. If you frankly ask me, I still feel niacin has a role in people who tolerate the drug. There is nothing, the trials never showed anything adverse in terms of any major events taking place except for the side effects.
Tolerability is a problem.
So maybe the drug, the tolerance of the drug was an issue. The predictive, as you understand, practically came and then disappeared after we used it for a good amount of time in our patients. But then only the trials forced the company to withdraw the drug. Otherwise, given a personal choice, there are still some niacin preparations available in the market in both 375 and 500 milligram preparations combined with statins.
I think the concept is dysfunctional actually.
It's the concept of dysfunction, yes.
Actually, which makes the whole scenario change.
Yes.
Very good.
What is the treatment modality for raised homocysteine? Any specific?
For
Raised homocysteine?
homocysteine.
No.
Homocysteine? No, I don't.
Homocysteine, actually, you say homocysteine.
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 Well, homocysteine is another error of metabolism in the body, where you consider use of B1, B6 usage to reduce the homocysteine levels in mostly medicinal forms only in these patient population. So there are some preparations available, and essentially that's how we practice it. So more than homocysteine, I didn't touch for again being a different area, but certainly in terms of prognosis and all, the lipoprotein A has greater significance than homocysteine.
That was really engaging. Thank you so much, sir. May I request Dr. Puneet Verma to give out the mementos to the chairpersons, Professor R.T. Sapru and Dr. Sachin Verma. Dr. Sachin Verma. Now please may I request Dr. Sapru to present the memento to Dr. Puneet Verma. Dr. Sapru to please present the memento to Dr. Puneet Verma. Let's commence with the next session. Due to some change and urgent commitment that has arisen to Dr. Nair, and respecting the commitment that he has made to give us some knowledge and quench our thirst, we have to reschedule the session. So, may I please call upon Dr. Mohan Nair, Coordinator and Head Cardiac Sciences, Holy Family Hospital, New Delhi. And to co-preside the session, I welcome on dais Dr. Arun Kochar and Dr. Deepi Malik. I request Dr. Puneet Verma to please co-chair the session.
Thank you, and indeed it's a pleasure to have Dr. Mohan Nair back. He is always willing to give time and commitment to this meeting, and I thank him and I appreciate his efforts he takes to come all the way, despite his very very, very heavy personal and professional commitments. So for people who don't know Dr. Mohan Nair, well, he's been my teacher for more than now 20 years. He has over 23 years of experience with his core competencies in interventional cardiology and electrophysiology. And he's undoubtedly one of the top electrophysiologists of the world, I would think. He is a coordinator and head cardiac sciences at Holy Family Hospital and has had the distinction of being the visiting faculty at University of Rouen, France, Punjab Institute of Cardiology at Lahore, Pakistan. He has been in the past honored by the Ceylon College of Physicians for their very highest honor and has been the immediate past president of the Indian Heart Rhythm Society and is on the advisory board of the Asia Pacific Heart Rhythm Society. So I welcome Dr. Mohan Nair to this meeting and look forward to his talk. Dr. Nair, please.
Thank you, Puneet. Good morning, ladies and gentlemen. It's indeed a pleasure to be back in this beautiful city and be amongst friends. And it's also a great feeling to see how Puneet is progressing in his career, in his endeavors to spread knowledge. And I must express my deep sense of gratitude for the fact that he always remembers me whenever he does a CME. Thank you, Puneet, for this wonderful opportunity. And of course to Harpreet, again a good friend, bright young person for the future. It's nice to be called. I believe he's the scientific coordinator for this meeting. Now, I've been told to talk about the management of atrial fibrillation. Atrial fibrillation is an arrhythmia. All of us come to see, whether we are physicians, family practitioners, or even non-physician surgeons do come across patients with atrial fibrillation. What I will do is go through three specific areas. One is non-amiodarone use or non-amiodarone drug therapy, which perhaps is known to most of you, but which I feel is still underutilized. Run you through the interventional procedures that are available now to tackle this arrhythmia. And the end, just give you a bird's eye view of the amazing new world of newer anticoagulants. When you come to pharmacological management of atrial fibrillation, you think about pharmacological cardioversion. Once you've cardioverted, you have to use drugs to prevent recurrence of atrial fibrillation. There are some drugs that are used purely for ventricular rate control, and of course, as I said, a huge role for drugs that can prevent thrombosis risk in atrial fibrillation. What I would like to highlight here is the fact, in this whole game of using amiodarone left, right, and center, we seem to have forgotten the use of flecainide and profefinol, which are class 1C drugs. Remember that both these drugs are easily available in the Indian market, are extremely efficacious, as I will show you, in patients who do not have a structural heart disease. The only place where you have to be a little careful is structural heart disease, particularly patients who have a left ventricular dysfunction or severe coronary artery disease. Unfortunately, again, as I said, amiodarone or cordarone is considered the panacea, and flecainide and propofenol continue to be extremely underutilized in the Indian population. Just see this, just oral loading with propofenol or flecainide at the right doses, that is 300 milligrams for flecainide and 600 milligrams for propofenol. You have a conversion rate of 50 to 60% at 3 hours and up to 80% at 8 hours, which is equivalent to what you can get by intravenous use of drugs, which means that you can actually use these drugs in the clinics, and going forward, you will also even train the patient to take it at home. The traditional fear is that flecainide or propofenol could convert atrial fibrillation to atrial flutter, and therefore you need to be careful about teaching the patient or the physician or your junior doctors that they should give these drugs along with beta blockers or calcium channel blockers. However, if you actually see in a resting patient, the chance of this occurring is less than 0.5%, and therefore all you need to do is not to give beta blocker or calcium channel blocker, but be sure that these patients who are loaded with these high-dose flecainide or procainamide should be resting for at least 4 hours after this episode. Such simple precaution, and you can use this effective drug at wherever you want. So again, highlighting that resting condition is for at least 4 hours is the only precaution you need to take, apart from seeing that the patient does not have serious structural heart disease. What is this pill in pocket concept? Again, very rarely used in India, extensively used in the West. The fact that if you have very infrequent episodes of atrial fibrillation, ill-defined but generally seen as less than 1 episode in 6 months, the patient need not be on taking pills every day. He can just be told that if he has some symptomatic episode of atrial fibrillation, and if you've been dealing with patients with atrial fibrillation, they all know when they get switch from sinus rhythm to atrial fibrillation, then they could take these drugs at home and just see. The dose is the same, 300 milligrams of flecainamide or 600 milligrams of propofenone, and the need to go to emergencies decreased tremendously. And therefore, as I said, not only can you use this in your clinic, but you could even train the patients to take it at home. The other new drug that is now available in the Indian market, and we are still trying to learn with this, is very good that for the first time we have an effective drug that has been seen in the West to convert atrial fibrillation into sinus rhythm, that is ebutalide. It's available, commercially available in India. We are actually learning to deal with this, but hopefully it should convert 50 to 55% of all your acute atrial fibrillations and up to 80% of your atrial flutters. The only problem is the polymorphic ventricular tachycardia because of long QT, and that just actually requires a defibrillator and careful monitoring. We use this in some patients, and I'm hoping that the Indian Heart Rhythm Society will come up with a registry of Indian use or Indian experience with ebutalide soon. Now, coming to prevention of recurrence, you have a whole lot of drugs. But again, what is not understood is that propofenone and flecainide, I'm concentrating on these 2 drugs because these are easily available in the Indian market, are almost as effective in prevention of recurrences as amiodarone. Amiodarone is something which is taken very seriously in the West. Unfortunately, we seem to use it almost like a aspirin or water. When you get into side effects with amiodarone, they can be serious. And I really don't see why in a patient where you should start thinking that you have alternatives. I'm not saying that all patients on amiodarone can be put on propofenone and flecainide, but a lot of them would be with no fear of harmful side effects. Remember that the effectiveness of current antiarrhythmic drugs to prevent recurrences is 50% at 1 year, and then that's why we are looking at non-pharmacological treatments like catheter ablation. Maintenance of sinus rhythm is something else. That's in a persistent of chronic atrial fibrillation, you're cardioverted either with flecainide, amiodarone, ebutalide, or DC cardioversion. Then if you have to maintain sinus rhythm, that's the case, that's the patient in whom amiodarone seems to have a clear advantage, and if you are able to monitor for side effects, certainly that's the patient where I would use amiodarone. Now coming back to the theme of today, this morning I've been hearing this prevention, and clearly there was a lot of, if you go through literature, you can go mad trying to find out whether lifestyle modification and risk factor reduction as for cardiac disease or coronary artery disease has any impact on this lifestyle disease or aging disease of atrial fibrillation. The good thing is that certainly the more you concentrate on risk factor reduction like weight management, hyperlipidemia, glucose, hypertension, sleep apnea, etc., the better that you will have sinus rhythm at the end or less episode of atrial fibrillation. And that's a good thing. And remember, this is a study that came in 2013, and this is what really again brings into the limelight it started in 2014, but Raj Sanders is going on with it even now. The fact that a multi-center trial in Australia has shown that these are patients who are extremely well monitored by cardiac rhythm specialists. Post-cardiac catheter ablation also, it makes sense to concentrate on lifestyle modification and risk factor management as you would do for patients with coronary artery disease to prevent recurrences of atrial fibrillation. So it all comes to the same stage that we have to focus on prevention rather than using drugs and high-tech stuff like ablation. So that's very, very gratifying. And I feel a little sad that I know this Raj Sanders is actually a Sri Lankan person who is now in Australia. It's so sad that in India we have so much of atrial fibrillation, so much of data, and something such simple as this has not come out of India. But that's another story. Now, coming to the other important area of prevention of stroke. Now remember, one of the most feared things, there are only two things which are feared in atrial fibrillation apart from symptomatic atrial fibrillation, which of course you have to listen to the patient if he is symptomatic. Atrial fibrillation is the most common sustained arrhythmia, and the biggest thing that you fear in a patient with atrial fibrillation is stroke or systemic embolism. Stroke, because in a patient who has non-valvular atrial fibrillation, the stroke risk is at least 6 times that of age-matched control. And the stroke that comes in atrial fibrillation is far more devastating. So, when you see a patient of atrial fibrillation, the first thing that should come to your mind is to try and see how you can prevent strokes and systemic embolism in these patients. And remember again, a misconception that the more persistent or more chronic the atrial fibrillation, the more the risk of stroke. That's not true. What is true is that intermittent or paroxysmal atrial fibrillation is as likely to cause a stroke as persistent atrial fibrillation. What changes the risk of stroke is the milieu of the patient, whether the patient is diabetic, there's a risk score I will come to, but that decides. So don't let a patient who has one odd episode of paroxysmal atrial fibrillation go without appropriate anticoagulation therapy. Now in June 1939, warfarin, that's as for actually Wisconsin Aluminum Research Foundation, they found this wonderful drug called warfarin, and it was put into clinical use in the early 50s. The good thing about warfarin was study after study showed that warfarin did prevent strokes much better than whatever you had. And there are also, to the Indian physicians, very clear message that aspirin and clopidogrel is not equivalent to anticoagulation with warfarin because they cause more strokes and more bleeding. And also from learning from trials that has gone across the Indian physician prescription habits, we tend to think that a little bit of both would be better than a good targeted or scientific use of one drug. Very clearly, aspirin and low-dose warfarin is not equivalent to adequate dose warfarin. The bad news with warfarin was that it came, I always say it's like saying that I have the best wife in the world. If only she didn't shout at me, if only she talked a little less, if only she didn't ask me questions. It was the same. It worked beautifully. It was the best drug you could have. It was cheap, it worked. But then it came with a lot of questions. It got unpredictable response, like a good wife. Narrow therapeutic window, again like a good wife. Routine monitoring need to be done, again like a good wife. So it was a good wife. It came with a lot of question marks. And the biggest worry was the drug and the food interaction. You had to teach the patient that don't eat this, don't eat this, don't eat this, and it seemed to be an unending list. The same way, an unending list of drugs could not be given to these patients, apart from, of course, at least monthly monitoring of INR. And this, remember, are drugs which are in the West. We don't even know what Indian food and Indian non-allopathic drugs could do. So it came as no surprise, and I was telling you, it was at times very embarrassing in these international meetings to sit down and see that India fared the worst in terms of adequate use of anticoagulation. But the fear was right. India fared the worst, but the good thing was all surveys, whether it was done at the Asia Pacific level, independent pharmacological or industry-driven, or Indian Heart Rhythm Society surveys, showed that about 30 to 40% were on anticoagulation and only about 30 to 40% of these patients were on target adequate doses. But the good thing was when they were asked whether they knew about the new drugs, the Indians fared the best. So the physicians were well educated, but they were a little reluctant because of these possible bleeding risks. And it is a very real risk because if the patient does not have a stroke, that's a he has to have a stroke to realize that he may not have had it if he had a drug. So it's a preventive thing. But if he has a bleeding, that's your baby. So all physicians and cardiologists were scared that they should not cause a bleed. So that comes on to you, it's a drug side effect. Prevention is something hypothetical that you are telling the patient. So in that scenario actually, it came as a big relief that you have this new anticoagulants. The main difference is that while warfarin was a carpet bombing drug, these new anticoagulants have targeted anticoagulants and therefore come with a lot of advantages. And the other thing is that we have started closely looking at the substrate, that is the risk score. And the risk is not determined by whether the atrial fibrillation has been long-standing, paroxysmal or permanent, but the milieu in which atrial fibrillation occurs. And it is worse when you have congestive heart failure, hypertension, the age is more, diabetes, etc., etc. So this is one of the scores which is more useful, but I'm sure in the next 1 or 2 years, these scores will be replaced by even better scores. So when you see a patient, immediately, I think that all physicians, and of course, the junior doctors who are being trained, must be trained to write the SHAT-VAS score in the first prescription that they see of a patient with atrial fibrillation. That should become a habit. The same way we also know the patients who are at higher risk. There are several scores, but these are the ones which are standard, used across the world as of now. As I said, I know that several others are under investigation. Now the new anticoagulants are the ones which I said are more targeted, and landmark trials have shown that they are either non-inferior, that is as good as warfarin, without the associated bleeding risk, without the need for constant monitoring, without drug and food interactions that came with warfarin. So it was a new bride. And if you think it was only atrial fibrillation and you can sleep off in terms of oral anticoagulation use, remember that regardless of your specialty, you're going to use this as you in the next few years. So it's high time that you read as much as you can about new anticoagulants because they are used for DVT prophylaxis, they can be used for pulmonary embolism, and of course they came in because of stroke prevention and atrial fibrillation. Now suddenly you have 3 prospective drugs. Which one do you choose? Till now you are saying that you give me one drug which acts as well as warfarin, doesn't have this funny thing of monitoring, funny drug effects, etc., etc. And now suddenly you have 3. Which one will you use? There will never be a head-to-head clinical trial. There will always be indirect comparisons. I don't want to spend too much of time. This is a crowded slide. But remember that dabigatran 150 mg morning and evening is the only one which has a superiority in terms of thrombotic risk reduction. And therefore, if you have a patient whom you think thrombosis is more problem than bleeding risk, dabigatran is a drug to go. So far, the clinical trials seem to show that if bleeding is a problem, then apixaban, which reduces bleeding at all doses, is the drug to go. Other small things, again, just to show this crowded slide to say that you need to be conversant with the niche positions of all these 3 drugs so that you can use it in an individualized fashion. Now suddenly the concerns about NOACs, the same reasons why we invented them or we had them in the market, there's lack of monitoring. So how do we know compliance? How do we know when a patient comes with a patient with on NOACs has a bleed, has to go for surgery? So what are the simple checks for need to know patients? How do we manage major bleeding? And of course the question of valvular atrial fibrillation. Valvular atrial fibrillation is a concern for all of us, and the Indian Heart Rhythm Society registry, which was done in 2014, showed that despite whatever you may say, about 50% of our AFibs are valvular related. So all this data coming from the West is for non-valvular atrial fibrillation. None of these NOACs have been tried or tested in valvular atrial fibrillation. Unfortunately, the only trial that looked at these anticoagulation in that is dabigatran in valvular atrial fibrillation was in patients with mechanical heart valves that had to be stopped because of more deaths in patients who were on these NOACs. And as of now, we cannot use. The European Cardiology Society, the European Heart Rhythm Society is coming out with new guidelines for valvular atrial fibrillation. I would be on the writing committee for that, and hopefully we would have some guidelines as to when and where we can use this newer anticoagulation in patients with rheumatic valve disease. The ones whom I have concern for is a patient with mitral stenosis, whose mitral stenosis has been opened up with balloon mitral valvotomy. Then could we use this patient in these patients newer anticoagulants? I do use them, but I always write that as an off-label use. Now, drug-drug interaction, again, this is something which was considered the plus point. The more we use it, we need to know that it's not that any drug, no drug has any interaction with these drugs. The red marks, I'll just reiterate that across the board, these drugs have to be carefully used in patients who are on antiretroviral therapy, anti-tubercular therapy, and of course, antifungal therapy. Simple. Don't have to remember all this chart. The good thing is that now we have commercially available specific reversal agents. We thought that we were protected by vitamin K in patients who had bleeding on warfarin, but you know how well it acted. But for dabigatran and for factor 10, we have specific antidotes now available. Just to say that most of the concerns that were coming up as we use these newer oral anticoagulants have been by and large at risk. And therefore, once we know these developments, we should be able to use it to the betterment of our patients. And again, the good thing is that these drugs were introduced here, and the Indian market seems to have taken it in a big way, which is very positive and which is what is expected. They were just waiting for these drugs, and the market share of these drugs is increased in terms of value of sale and in the number of days that the patients have been on these drugs. Now, finally, coming to catheter-based ablation or curative ablation for atrial fibrillation, we have come to live with the idea that most patients with WPW syndrome, most patients with supraventricular tachycardia can be permanently cured for life with just few seconds of radiofrequency energy, which is one of the most dramatic and gratifying things you can do in cardiology. However, it's been not the same story with ablation of atrial fibrillation because the arrhythmia circuit is complex, and just when we thought it was impossible to ablate atrial fibrillation was this landmark article in New England Journal of Medicine by Michel Hasseguer from Bordeaux, which said that although he could not take care of atrial fibrillation, he looked at how atrial fibrillation was initiated and found that almost 90% of paroxysmal atrial fibrillation was initiated outside the heart in the pulmonary veins, and you could easily ablate these foci and get rid of atrial fibrillation. This is how we do it. We did it initially, have a catheter here in the pulmonary vein, map the activity. You see this is rapid activity in the pulmonary vein which starts off atrial fibrillation, and you take the ablation catheter here and start ablating, and you see the pulmonary vein activity totally disappears, and if you are lucky, the atrial fibrillation converts on-table to sinuses, and about 70% of them would never have a paroxysmal atrial fibrillation again. You must also remember that, especially in young patients, atrial fibrillation is triggered not from pulmonary veins, but atrial tachycardia from anywhere, by SVT and typical flutter, where the ablation success rates are more than 90%, and therefore, we're increasingly able to offer non-pharmacological or lifelong pharmacological therapy can be replaced by some of these ablation procedures. And life is better with these three-dimensional mapping systems which give you a real-time view of what the pulmonary veins look like, what the left atrium look like, and increasingly we have improved our technique for ablation or isolation of electrical isolation of pulmonary veins. What about chronic atrial fibrillation? That's another story, and that's what seems to affect Indian patients more. And while Michelle Heisegerer was working on paroxysmal atrial fibrillation, we started at GV Pant Hospital at that time. I think Puneet was just a child trying to learn cardiology, and that's the time when we started this multi-pointer mapping. And we mapped traumatic atrial fibrillation. Most people laughed at us, we didn't care. And this was finally published in Circulation. Again, perhaps when Puneet was just a child. And what we found was that just as paroxysmal atrial fibrillation was triggered from pulmonary veins, there was organized activity that was seen at the beginning of traumatic atrial fibrillation, which could be ablated, and at least reinducibility in the lab decreased. However, its problem was that at 2 years, only 50% of these patients were in sinus rhythm. As we went more into three-dimensional mapping, we were able to even map these areas which possibly acted as rotors or maintained this atrial fibrillation. We ablated these, and you find this atrial fibrillation getting into organized rhythm, and of course this is all technology. Once this get organized, you could map these flutters into areas, spot areas, and you could get rid of this organized activity and have a reasonable chance of getting into sinus rhythm, even in the bad chronic atrial fibrillation. This again was published in the American Journal of Cardiology sometime in 2009, yes. Our odyssey with chronic atrial fibrillation ablation continues, and hopefully, right now, honestly, the chronic 2-year, 5-year atrial fibrillation free intervals are just about 50%. We hope to improve it further. What is again underutilized in India is surgical. The same kind of lesion given during surgery is far easier, takes just 10 minutes more, with far better success rates at 5 years. 5-year success rates of close to 80%, which is standard of care in a lot of Asian countries, but not yet in India. Again, that's a problem. Looking at the future, there are people who are looking at body surface mapping to see, get more idea about chronic atrial fibrillation, and we are investing a lot on cardiac MRI and trying to see if the nature of left atrial enlargement can give a clue as to whether the patient should be taken up for catheter ablation, and you can tell the patient that you're likely to benefit or not. These are all for future, but that's a atrial fibrillation is a very, very vibrant topic, and it's a wonderfully evolving topic. It's not something that you're carrying on things 2 decades back. Every day things are changing. And I think that physicians, medical students, everybody needs to be aware of the changing scenario on atrial fibrillation management. Thank you very much, and thank you for addressing my talk.
Thank you, Dr. Nair, for taking us through beyond amiodarone and vitamin K antagonists, the newer drugs, which are not so new to maybe the cardiologists, but still I think majority of us don't use propofenone, flecainide, and the like. And of course, you are an expert in RF ablations of this very, very morbid condition, and therefore you have that experience and expertise to even tell us now on what are the true indications of using flecainide and propofenone. Are they applicable in patients with or without CAD with LV dysfunction?
Clearly, as I said, LV dysfunction is a big no for the 1C drugs, because these are the patients who can go into TOSAR. That's why I said, apart from severe LV dysfunction, the so-called structural heart disease finally comes down to severe coronary artery disease or LV dysfunction. Other patients, young patients...
Stable CAD, normal LVs?
I would think that that's, you can use them with some monitoring of the QT.
So Dronidron is out? Will that?
Dronidron is full-time out.
Even for paroxysmal or single episode?
Yes, because it came in as a drug which looked at not the ECG but the cardiovascular outcomes. And just like this niacin story, you sell a drug for something, and on real world use, it fell flat. It actually increased cardiovascular mortality. So I don't think there's any, it's there in one of my slides, that's unfortunate, but I don't think you will not get it anyway, even if you want to use it.
So what are the indications to use anticoagulation in paroxysmal AF? When do you decide to start?
It's very clear that whether paroxysmal persistent or permanent atrial fibrillation, anticoagulation use is defined by, as of now, by Shatz-VAS score. Shatz-VAS score of more than or equal to 2, you are bound to discuss anticoagulation with the patients. And then it is a question of trying to discuss with the patient the advantage of warfarin. It is more easily available, as we said. More than 50 years of experience, whereas NOACs, as you see, every day you are learning more. But the downsides are, and I know that patients are hugely happy when they are on warfarin, saying that you can, from now on with this drug, you can go back to your palak paneer. They say, okay, fine, we don't care how much it costs, we just want to be eating. They go for dinners or in weddings, they are forced to eat what they want, and next day they are with, I know doctors who have been admitted, very senior doctors, I don't want to name them, but they have been died because of intracerebral hemorrhage while on warfarin. So that's something you discuss and start. I mean, 70% of my patients are on NOACs.
So does Holter has any, do you need to calculate the AF burden, say in a 24-hour Holter where you think anticoagulation may need, or it's purely on Shatz-VAS, you simply do that, even if you're seeing patients in sinusitis?
Yes. You have to understand that all these scoring systems come with their plus and minus points. Shatz-VAS is the best that we have now. The NICE, that is the equivalent of the National Institute of Clinical Excellence in the UK is looking at what is called the best score, which looks at pro-BNP and things like that. So you could look, I think one thing that is missing in the Shatz-VAS score is the LSIs. And, but this is the score that will be tested maximum. And as of now, it's Shatz-VAS that you look at. And that does not include Holter monitoring.
Regarding the Vilutide, you said you are new with the drug.
That's right.
How do you think the future for this?
I wish I could tell you. I have very little experience, a few patients. And, well, I don't want to really comment on it with few patients. But if you look at the studies, Europe and all the studies are very positive. But if you talk one-to-one with electrophysiologists in Europe and US, they're a little scared. They always say that be very careful. But one odd patient will get into incessant TOSAD or have a hemodynamic compromise while on ebutalide. So it's early days. We use it now because we have got this. All patients who are admitted for cardioversion, electrical cardioversion, will get ebutalide trial before they get. So maybe, and I've asked the IHRs honestly to pull the data and so that we are able to tell you. As of now, early days.
Incidence of heart failure with retinal.
Pardon?
Incidence of heart failure with retinal.
Incidence of heart failure.
Yeah, you cannot precipitate heart failure if you are starting with a normal LV and if you do, yeah, I don't think you can precipitate heart failure. The problem of LV dysfunction, especially or a sudden hemodynamic collapse, is with patients who have moderate to severe LV dysfunction. I think this fear of heart failure is not there if the LV function is reasonable.
Thank you so much, sir, for the knowledge. Now I would request Dr. Kamil to please present Dr. Nair with a moment. Continuous learning is the minimum requirement for success in any field. Keeping that motto in mind, we move on to the next session. I take the privilege to call upon Dr. R. Muralidharan, Senior Consultant Endocrinology and Diabetology, Fortis Hospital, Mohali, Dr. B.S. Bhatia and Dr. Ashwini Kansu as chairpersons to join us on that.
This particular aspect, any time before, though I read a little before, very little I would say. And the role of, gut microbes, in diabetes or metabolic syndrome, obesity has been a new thing happening. Dr. Murali would like us, happening just for the last maybe less than a decade, all the research. And we are going to see a lot of more research going into it. And therapeutic strategies are also coming up. to intervene from that angle. Dr. Mohali talks the gut microbe and obesity and metabolic syndrome.
Thank you, Chairperson Dr. Bhatia. I must thank Dr. Puneet again for having me over here. I've been privileged to be part of this very wonderful exercise every year, and I've always been impressed by the keen audience and the brilliant academic content. So when he asked me what I wanted to speak this year, I thought we should speak on something which has not been covered earlier, and I must confess that this topic we haven't even discussed very often in diabetic forums. I was stimulated to speak on this topic because I had to do some research on this particular area when I had to speak in one forum in Kerala last year in the RSSDI Kerala chapter. And at that time it struck me that it is one emerging area, even though riddled with a lot of controversies. And coming to think of it, to the cardiologist, microbes and coronary artery disease, it's not something new. Even maybe 3-4 decades ago, you've been talking about chlamydia and atherosclerosis, periodontal infection or any chronic low-grade inflammation contributing to coronary artery disease is very well known to you, and to this extent that even spoke of antimicrobial agents as modifiers of atherosclerosis. And coming to think about this particular area, it has pervaded even the lay press and newspapers, and Scientific American even brought out one issue where it was, the cover story was your inner ecosystem, where they say in your body bacteria constitute another organism inside you. So much so, the gut microbiota constitute 100 trillion organisms within your gastrointestinal tract, weighing 1.5 kilograms in total. So it's got a microbial organ performing key functions of your body. They include 3 major phyla: bacteria, archaea and eukarya, and their viruses. There are 1,000 species, but 3 are very predominant. They are called firmicutes, bacteroids, and actinobacteria. And firmicutes comprise your Clostridium and Bacillus species. In bacteroids, you have the Bacteroides species, and actinobacteria, we have what is called the Bifidobacterium species, which most of you must be coming across as a probiotic capsule which you are dispensing to patients. One disclaimer, you please need not remember all these bacteria names. It may be confusing. You have to just take home the philosophy behind this new thinking. The term gut microbiota means the collection of microorganisms, whole microorganisms, predominantly bacteria, living in your gut. And when we name it microbiome, we refer to the collection of genes which are encoded by this gut microbiota. So this is just a nomenclatural introduction. And coming to look at it, right from the upper GI, coming down to the lower GI, you have these various bacteria and performing different roles. The lactobacilli and streptococcus in the duodenum, enterobacteriaceae in the jejunum, and when it comes down to the ileum and the colon, you have bacteroids, bifidobacterium, clostridium, eubacterium, etc. And at different parts of the bowel, they have different roles to play. In the duodenum, it is basically the digestion of foods, the short-chain fatty acid modulation, the immunomodulation, whereas in the jejunum, it's mainly the free fatty acid modification, calcium and vitamin D, as well as the synthesis of fat-soluble vitamins, especially the vitamin K, about which the previous speaker so elegantly alluded to. Ileum, again B12 synthesis and bile acid modification, and at the level of colon, the water modification as well as the short-chain fatty acid metabolism. So you can place the bacteria or the microbiota as an essential component of the intestinal barrier, where they play several roles. Earlier there were roles were mainly thought to be training the immune system, immune cells recruitment, modifying the inflammation, immune response activation and orientation, pathogen recognition, and also they are very, very important for the integrity of the intestinal epithelium. So we all thought that probably it plays a role at the local level as well as in training the new organism which has come out into the world to respond to the invading pathogens. But now we know they do much more than this, and it's a versatile microbiome that is sitting inside you, where it's responsible for nutrient availability modification, vitamin synthesis, bile acid metabolism, immune regulation, intraneural axis activation, endocrine axis activation, and the mucosal integrity as well as modifying inflammation. So there are two major areas, the intraneural axis and endocrine axis, where the microbes are playing an important role, and that will be the focus of my talk today. And so much so that there is a new branch of endocrinology called microbial endocrinology. So you must be remembering this fact that how fast the area is progressing. But the problem is, the study of microbiota is not possible in any simple lab, and mostly it is now limited to research labs, because cultures will be erroneous, most of them are anaerobic, plus you have contamination with the other pathogens. Culture independent methods should be largely used to a study of microbial DNA from fecal samples by what is called next generation sequencing, where the 16S rRNA gene sequencing, finding out the abundance of different bacteria and their phylogenetic relationships, as well as the whole genome shotgun sequencing. This is the future of what is called the metagenomic sequencing, where you can have a comprehensive depiction of the overall collective genome. Rather than just studying the human genome, now people are studying the bacterial genome inside your intestines, and this is going to play a big role in how to find out the interactions with the organism. So there are several studies going on. I've just shown this to see how much this field is progressing. So based on this metagenomic sequencing of mainly European, Chinese and American samples, a comprehensive microbial gene catalog has already been found with so many genes, roughly turning to 10 million, compared with 23,000 human genes. 23,000 human genes has been recently published. Looking at the human genes versus this, you can find out how much complex it is in comparison to the Human Genome Project. But at the same time, we should understand that all of us are not born with microbes in our intestines. Our intestines in the fetal life are almost sterile, and the mode of birth, how the mother feeds you, whether it is breastfeeding or formula feeding, other medications which are exposed to right from early childhood, the host genotype, that is your family history, the physical activity, smoking, other concomitant diseases, alcohol, and other drugs that you are taking, all of them are going to modify your microbes. And when you look at the interactions with type 2 diabetes and the microbes, it can be a two-way relationship. Diabetes itself may alter your microbial population. All you know that Helicobacter pylori or even your periodontal flora are different in diabetics when compared to non-diabetics. So whether what you are studying is a cause of diabetes or an effect, that is one important controversial area that has to be addressed. So I'll just take you over to this interesting area by looking at this busy slide, how the microbes are going to interact with your system. They interact basically by three major mechanisms. One is directly through the bacterial lipopolysaccharide, what is called LPS, which acts on these receptors called the toll-like receptor 4 and directly causing inflammation. And as you all know, metabolic syndrome, obesity, atherosclerosis, non-alcoholic fatty liver disease, all of them are partly or mainly contributed to by inflammation. And so that may be one role how they are playing. The second important role they play is their modification of short-chain fatty acid. The dietary fibers which you take are broken down by these microbes to three major short-chain fatty acids, namely butyrate, acetate, and propionate. And they in turn have effects on the liver by causing increase in fat synthesis, gluconeogenesis, at the level of the intestinal cell by acting on what is called GPR41, they again cause inflammation. And at the level of the L cells of the intestine, these particular fatty acids stimulate GLP-1 and neuropeptide peptide YY. There is another molecule which is responsible for decreasing food intake and increasing energy homeostasis. The third way by which they will act is by breaking down the primary bile acids in the intestine to what are called secondary bile acids, which in turn will act on a receptor called TGR5, and it will act on the skeletal muscle to cause energy expenditure and act on the intestinal L cells to stimulate GLP-1 production. That is the incretin pathway. So by a host of mechanisms, the bacteria is interacting through your intestine on all pervading parts of the gut endocrine neural axis. This cartoon again shows several bacteria which are coming down in their concentration and several bacteria which are going up in their concentration. Conceptually, in a patient who is becoming from non-obese to obese, this leads to an altered tone, what is called the endocannabinoid tone in the intestine. As you all know, endocannabinoids are major molecules which are the endogenous equivalents of what we commonly call cannabis sativa or bhang, which you all must have once in a while had experience to during your Holi celebration. These are responsible for increased food intake and decreased energy expenditure. So theoretically, targeting endocannabinoids will lead to various targeting of pathways in the metabolic syndrome, and that is how the gut microbes act. The lipopolysaccharide causing increase in gut permeability either directly or through the altered endocannabinoid tone, causing inflammation both in the adipose tissue and in the liver, contributing to the phenotype of obesity and non-alcoholic fatty liver disease and other components of metabolic syndrome. So this is to summarize what I already told you. The dietary fiber which you take is broken down to short chain fatty acids, butyrate, propionate and acetate. Butyrate is the one which is beneficial to the host. Now there are studies available in gastroenterology where butyrate is used as an oral treatment or as enema for inflammatory bowel disease. This is responsible for nutrition of colonic epithelium. It also increases GLP and PYY. It increases the intestinal transit time, increases the intestinal gluconeogenesis, and also had anti-inflammatory role. Propionate causes increased intestinal gluconeogenesis, hepatic gluconeogenesis, and hepatic lipogenesis. And acetate again causes the same mechanisms as propionate. So coming to think of it, if there is an imbalance between butyrate and propionate acetate, you will have increased gluconeogenesis, increased lipogenesis, and decreased activity of GLP-1 leading to metabolic syndrome. That is exactly what happens in metabolic syndrome, where the bacteria in the gut which are predominantly butyrate producing are altered, and if the bacteria which produce predominantly propionate and acetate gain upper hand, then it leads to metabolic syndrome. This is a very attractive concept that is shown here, where on the left panel, the lean phenotype, where there is a proper balance of butyrate, propionate and acetate. So there is increased insulin sensitivity, increased fatty oxidation. Whereas on the right panel, when butyrate is absent, only propionate and acetate are there. Because the bacterial flora has altered, you have decreased insulin sensitivity, decreased fatty acid oxidation, causing inflammation as well as obesity and other components of metabolic syndrome. Coming to bile acid modification, as I already told you, when primary bile acids are broken down by microbiota to what are called secondary bile acids, they act on a receptor called TGR5, which is a G protein coupled receptor, which improves insulin sensitivity at the level of skeletal muscle. So it has favorable metabolic effects. So many of these favorable bacteria actually improve insulin sensitivity, and once this bacterial flora changes by mechanism which I will allude to later, your body becomes insulin resistant. This is what is summarized here. Short chain fatty acids causing decreased intestinal transit rate, increased energy harvest, increased hepatic lipogenesis, contributing to obesity and fatty liver. On the other hand, the secondary bile acids, increasing insulin secretion, increasing satiety, and decreasing gastric emptying, causing the loss of weight and acting against obesity and metabolic syndrome. So the delicate balance between these two has to be there. If there is an imbalance, what you call dysbiosis or modification of the bacterial flora, theoretically you can lead to metabolic syndrome. There is another factor in the intestine which is altered by this bacteria, which is called angiopoietin-like peptide. This also acts on normally the adipose tissue and the skeletal muscle to decrease fat synthesis in the adipose tissue and increase insulin sensitivity in the skeletal muscle. But once the lipopolysaccharide of bacteria is predominating, then it suppresses this angiopoietin-like peptide and it causes exactly opposite, the increase in adipogenesis and decrease in insulin sensitivity at the level of skeletal muscle. So what are the clinical implications? There have been studies, even though short term, which have shown that vancomycin inhibits generation of secondary bile acids by inhibiting favorable microbes, what is called Faecalibacterium prazoonsi, and this is a probable mechanism of decreased insulin sensitivity which has been studied even after short-term use of vancomycin over 1 week. Beneficial effects of gastric bypass in mouse model is again mediated through change in bile acid composition. So there are already applied aspects available. So now I will come to these applied aspects, how we got this information from animal studies and whether we can extrapolate it to human data before I finish my lecture. Several animal studies have already shown that germ-free mice, what are called notobiotic mice, which are born germ-free and continue to be reared germ-free in a very sterile environment, they are resistant to diet-induced obesity. You keep on feeding them, they will not put on weight because they don't have bacteria inside them. Once these germ-free mice were kept in the same cage along with what are called conventionalized mice or conventionally raised mice, mice are coprophagic. They eat the feces of the other mice. So their intestines will now be colonized with the bacteria from the normal mice and they start putting on weight. And now you start feeding them more, they can start putting on weight. Even if you don't feed them increased food, if they are cohabiting with obese mice, they will start becoming obese. So this is the first study which showed that you can transfer obesity from one mouse to the other by just transfer of bacteria from the intestine of one mouse to the other. That gave the concept that probably there is something in these bacteria which is making these mice obese. Now all of us can blame our bacteria for putting on weight. So this is the model. So they started proposing that there is an imbalance in the gut microbiota where the bacteroids and firmicutes are imbalanced. The firmicutes become more and bacteroids become less, and that can be causing obesity and diabetes. But it became very controversial because there are several studies which have shown conflicting findings. But this cartoon depicts at least that what happens in obesity can be summarized here, that gut microbiota, by altering the composition, altered fermentation and increased energy harvest lead to increased adipose tissue storage, decreased fatty acid oxidation, increased permeability of the intestinal epithelium to several molecules, the lipopolysaccharide especially, at the level of liver, the inflammation and fat deposition, and at the level of brain, decrease in satiety and increased food intake. So much so it has been now seen that even the cortisol response from the hypothalamic pituitary axis is modulated by one specific flora of gut bacteria. That people who are having this flora, they mount a higher stress response. So it means that your bacteria are cross-talking with your hypothalamus through chemical mediators. So there are several studies which have looked at this. I will not go over this. I have to only tell you that the findings are very controversial. In some studies, one particular bacteria predominated. In some other studies, other particular bacteria predominated. So largely what has been shown now is, even though many studies have shown that the ratio of bacteroids to firmicutes is altered and some species of bacteria grow more in diabetes and obesity rather than other species, like less butyrate producing bacteria, these two bacteria which are shown here in Chinese and Swedish studies, An altered ratio between firmicutes, bacteroids has not been confirmed across the globe in most of the studies. And lower gut bacteria diversity is associated with obesity and comorbidities in non-diabetic humans. And protobacteria in Danish subjects increased the type 2 diabetes, and abundance of E. coli in the gut in Chinese type 2 diabetes. So in each study you have found different findings. So largely what is found is increased fecal concentrations of lactobacillus, streptococcus mutans as well as E. coli are predictive of development of insulin resistance in postmenopausal obese Caucasian female. This was a Swedish study. So rather than telling one particular bacteria is more than the other, what is found is that the richness of the bacterial flora is altered and probably one species may be predominating than all other species when you convert from normal glucose tolerance to impaired glucose tolerance or normal BMI to obese BMI. And this is one review which has shown that these are the bacteria which are increased in type 2 diabetes, that is firmicutes, whereas bacteroids are decreased, and these are the species which are decreased in type 2 diabetes. These are the three major species which produce butyrate, that is Roseburia, Eubacterium halide and Faecalibacterium protsinae. So why this is important is whether our therapeutic modifications or your diet is going to have any influence on that. Let's look at this in the last part of the talk. Low fat, high fiber diet leads to a better diverse microbiota versus high fat, low fiber diet. This is again another argument in favor of going back to a traditional diet of high fiber, low fat. Rapid plasticity. Even within 2-3 days, the diet change can change the microbial flora, that is from plant-based to animal-based diet and vice versa. They can change in 2 to 4 days. Western diet is depleting the richness of microbiota. More of fast foods, more of energy-dense, condensed foods, they are depleting your microbial flora, which is the favorable microbial flora, and this may be one reason why metabolic syndrome is rising in developing economies like India. As Professor Sapru rightly pointed out, our genes have not changed in the last 70 years. Probably our environment has changed. Not only our external environment, but the internal environment inside our gut has changed. So dietary fat has been directly correlated with inflammation, whether it is CRP or other markers of inflammation. It is directly correlated to dietary fat, and it has been correlated within hours. Once you feed, immediately you see the circulating lipoprotein, the bacterial polysaccharide concentrations immediately increase, thereby meaning that the increased fat in the diet increases the intestinal permeability and causes the lipopolysaccharide of the bacteria going into the system and causing inflammation. So again, this is a very attractive concept, and this is called metabolic infection or metabolic endotoxemia. That is, a metabolic stimulus is making you manifest features of infection or inflammation. This is not sepsis. Here the endotoxin is going into your system because of just your feeding. So food is one of the important provocative agents for inflammation, and it has been shown that LPS absorption through chylomicrons or through altered microbiota is increased by high fat diet. And more importantly, look at the right panel where there are many food dependent effects by the microbiota. 3 major foods are implicated. One is choline, the other is cholesterol, the third is polysaccharide. Polysaccharide and cholesterol I already mentioned through your short chain fatty acid and the bile acid metabolism. We'll concentrate on choline now, how important it is. And here comes the role of microbiota in coronary artery disease, which as cardiologists you all will be interested in. It's a very attractive and interesting concept that what you eat in the food as L-carnitine or phosphatidylcholine or choline, mainly from red meat and egg, especially egg yolk, is converted by your microbiota to an agent called TMAO, that is trimethylamine N-oxide, and this is directly linked to cardiovascular disease. As shown in this cartoon, once you eat red meat or processed cheese or egg with rich yolk, the dietary phosphatidylcholine goes inside, where bacteria converted to choline and also by the gut flora to trimethylamine, which goes to the liver and by an agent called fatty acid monooxidase in the liver, they are converted to trimethylamine N-oxide, which is directly toxic to your endothelial cells and causes atherosclerosis by increasing oxidant stress. So there are elegant studies available which have shown that rather than being just an indirect association, intestinal microbiota by causing obesity, dyslipidemia and diabetes, they can have a direct association with atherosclerosis by altering the metabolism of choline, phosphatidylcholine and L-carnitine. So red meat and CV risk probably, compared to vegans and vegetarians, patients whose diets included red meat which is rich in L-carnitine produce more trimethylamine N-oxide, TMAO, and this is produced in the gut by intestinal microbiota, as I already told you. And there are angiographic studies as well as cardiac evaluation studies which have shown that patients who ate high levels of L-carnitine in their diet, as well as people who have high circulating levels of TMAO, have a very higher atherosclerotic burden compared to the control population. And this is one elegant study which was published in New England Journal, which clearly showed that the highest quartile of TMAO had the highest coronary atherosclerosis risk, thereby implicating gut microbiota indirectly causing the atherosclerosis by acting on the dietary nutrients. Same is with NASH. As I told you, the metabolic inflammation plays a role in the liver also, where acting on the toll-like receptor, it increases TNF alpha and causes the non-alcoholic fatty liver disease. So gut microbiota play a role in the other component of metabolic syndrome, which is NASH or non-alcoholic fatty liver disease. So there are a web of interactions. Diet, by directly altering the body composition and causing obesity and adipokine signaling and leading to inflammation, because obesity itself is a pro-inflammatory disease. Through intestinal microbiota, causing increased intestinal permeability as well as modifying the short-chain fatty acids and also the circulating lipopolysaccharide and the TLR signaling causes inflammation, immune alteration and causes all the components of obesity and metabolic syndrome. So how do we treat it? As I already told you, dietary modification with high fiber, low fat. We should also discuss about the role antibiotics play in this causation. Whether there is any role of prebiotics. I'll tell you what prebiotics are in this next slide. Any role of probiotics, the effect of anti-diabetic medications and the effect of bariatric surgery. I'll have one slide each for this. This is the most elegant study in this particular area, which looked at early postnatal exposure to antibiotics. These were mice whose mothers were given penicillin, low dose, and these mice were feeding on the milk of these mothers, and so they were also exposed to this penicillin. So their gut microbiota got altered, and these mice became obese. Now the interesting thing is, the feces from these mice were transferred to microbiota of germ-free mice, and those mice also became obese. So again they showed that mice who as pups were exposed to low-dose penicillin because of their mother taking penicillin became obese and transferred this obesity to the other mice through microbiota which are transferred from their intestine. So this particular concept came in a very big way, and even newspaper headlines you must have read that early life antibiotic exposure leads to obesity. So antibiotic use is not only related to resistance, and the WHO is time and again advising you not to overuse antibiotics, but there are several studies available here. I am not going over each of them for want of time, but most of them have shown that early life antibiotic use within the first few weeks or few months leads to future onset of obesity, the risk ranging anywhere between 1.2 to 1.5 fold. And this is the concept, that mother normally will transmit her bacteria from the birth canal and through nursing, skin and oral contact to the child. And so the child has a normal microbiota maturation. But at this point of time, if the child is exposed either prenatally or because of cesarean section delivery, the child is not at all exposed to the vaginal bacteria, and antibiotics during nursing or for neonatal sepsis or some other infection, you have given antibiotics to the child in the neonatal period, potentiating the risk A child who is heavily affected with antibiotics, all the gut flora is totally knocked off, will be turning underweight. Whereas a child who has limited antibiotic perturbation with sufficient recovery will continue to be healthy weight. Well, mild antibiotic disruption in early life, on top of that, a good feeding, these children become obese. So it's two ends of the spectrum are there, both underweight as well as overweight have been described due to early life antibiotic exposure. If it is a very heavy antibiotic exposure, killing all the bacteria, the child becomes underweight in future. And if it's a mild antibiotic exposure, just altering the gut flora in favor of the bacteria which are producing obesity, the child later gains weight. It's a very, very attractive and provocative concept, but it has to be proven in long-term studies because the adult data are also coming up now where decreased insulin sensitivity following 1 week of vancomycin treatment, I've already told you that, and a retrospective study where increased adiposity following antibiotic treatment with vancomycin for infective endocarditis. Many times patients tell you he was normal till the age of 12, was admitted for some pneumonia, they gave a lot of antibiotics and fluids, and then only all this weight has been put on. We usually tell the parent this is all a joke, but now probably there will be some truth in what the mother is telling. In addition to the excessive feeding after convalescence, probably antibiotics have altered the gut flora and that may have precipitated obesity in these adolescents. We have to look at this. There are discordant results also which say that probably not all antibiotic exposure is like this. Some antibiotics have even shown favorable effects in improving insulin sensitivity in animals. So the last word has not been said on this particular matter. So I have just come to the last part. What are the therapeutic implications? Whether you can use probiotics or prebiotics. Probiotics are live microorganisms which when consumed in adequate amounts confer a health benefit on the host, which all of you are using. Prebiotic is an agent, it is a selectively fermented ingredient that allows specific changes both in composition and or activity of the gastrointestinal microbiota that confers benefits upon host well-being and health. So these are foods which are artificially enriched with non-digestible but fermentable fiber like inulin, fructo-oligosaccharides and galacto-oligosaccharides. These galacto-oligosaccharides are coming up in a big way because the bifidobacteria and lactobacilli, they increase in the gut once you feed them with galacto-oligosaccharide. When prebiotic oligofructose was fed to mice on high-fat diet, endotoxemia decreased and glucose intolerance improved, thereby meaning that there was an anti-inflammatory effect by giving prebiotics. And there is a human study where 45 overweight adults were given B-GOS, which is a galacto-oligosaccharide, a prebiotic. It increased the favorable bifidobacterium, decreased CRP, decreased insulin and triglyceride and total cholesterol level, thereby altering almost all the components of metabolic syndrome by this nutrient modification. Whereas with probiotics, we still have very disappointing results. Lactobacilli have been used and not much finding. A pilot study of 30 humans with metabolic syndrome, they used one particular strain of lactobacilli, Lactobacilli casei shirota, didn't have any effect on insulin sensitivity or beta cell function. So we require proper long-term randomized double-blind controlled studies to obviate the placebo effect. But there is one interesting story that artificial sweeteners, especially it has been shown with saccharin, alter the gut microbiota and cause obesity in mice. So now we have to be careful even using artificial sweeteners. Whether sucralose has the same side effect or not, we really do not know. But what is found is that these chemical agents also have the potential to alter the gut microbiota, and at least we have evidence for saccharin that obesity is caused by saccharin even though it doesn't have any calories by just altering the gut microbiota. Metformin favorably affects gut microbiota. There are several studies available which shows that it increases some species like Akkermansia in high-fat fed mice beneficial effects on glucose metabolism, and that's why there is one very provocative article published where they even gave the headline that novel gut-based pharmacology of metformin in patients with type 2 diabetes. In addition to causing the hepatic glucose output decrease and increased insulin sensitivity at the peripheral level, probably the other beneficial effect of metformin now seems to be altering favorably the gut microbiota. In the same way, bariatric surgery, as I already told you, there is very interesting finding available from mice where they underwent gastric bypass. The microbiota which were transferred from these mice to the obese mice, it actually decreased the weight of obese mice. They were meaning that again gastric bypass affects microbiota in a positive way. Fecal transplantation, I already told you that mice who were transplanted with feces from human twin donors discovered for obesity showed first that the obesity phenotype was transmissible, and I already told you that if you co-house mice who are lean along with obese, the lean mice put on weight. The most interesting thing is now these experiments are being done in humans. Fecal transplantation in humans, where through the rice tube, processed fecal matter from donors is given into the donor, into the recipient. Already the gastroenterologist here, Dr. Narpal, must have read this in the New England Journal of Medicine, where they used this revolutionary and slightly repulsive treatment in management of Clostridium difficile colitis, and it was a very, very landmark paper which was published in New England Journal of Medicine. Now they are looking at this in treatment of inflammatory bowel disease, ulcerative colitis and Crohn's disease, and what is found is it will be useful for metabolic syndrome also. When you give feces from lean persons to an obese person, their insulin sensitivity improves, insulin resistance comes down. Maybe we'll modify the feces in such a way that it will not be repulsive, or only take out those bacteria and give it in the capsule form, but it is a very, very important and big area which is coming up, which will throw open many ethical and other questions also in the future. So summarizing, ladies and gentlemen, microbiota and metabolic syndrome, whether has generated hope or it is just a hype, we have to admit that it's a very, very exciting area. There are several conflicting observations due to confounders like ethnicity, diet, concomitant medications, etc. There are difficulties obviously in extrapolating animal data to humans. It's technically demanding. You need standardized sample collection, preservation, processing, DNA extraction, etc. Always the question is whether it is the cause or the effect. But the last three lines are very, very important. That's why I put them in bold. Dietary factors adversely affecting cardiovascular disease may be mediated through microbiota, and because the theme of this whole session seemed to be on preventive cardiology, I think this is one area where we can look at very, very carefully. Especially red meat, egg yolk consumption should be decreased, and go for your traditional diet of high fiber, low fat, which will favorably alter your microbiota. Therapeutic options seem to be promising, but most important is the argument against injudicious antibiotic use has been strengthened further by these very, very interesting data on newborns who are exposed to antibiotics developing obesity in future. Now if you are asked what are the disadvantages of antibiotic use, you can add one more, probably obesity and metabolic syndrome in future with early life antibiotic exposure. Thank you one and all for the patient.
So I think it was very enlightening. Not only enlightening, it's absolutely new concept, and which perhaps will gain a lot of momentum over the years. I just quote a study published in Diabetes Care in which lactobacillus reuteri was given, and that was shown to increase the incretin response and reduce the insulin resistance. This was last year, 2015, Diabetes Care. The practical implications you saw, you could see why red meat with TMAO chemically formed and causing all the problems. So basically three things: lipopolysaccharides, increased permeability, and short chain fatty acids, basically starting the process and leading to a lot of things. The house is open, and I think there will be a lot of questions.
It is a wonderful talk, and it leads to new concepts in the treatment part also. And now it will raise so many questions from the audience. Please continue with the questions.
Just to add to what Murali has elegantly said, I think the mode of delivery also matters. The newborn born through normal delivery have lesser chances of having metabolic syndrome and diabetes, 50%, 20% lesser chances as compared to born through cesarean section.
Yeah, there are some data available, but still it has not been said in those words that cesarean section babies will become more obese in future. But this is a very attractive concept that if you go through the natural way of delivery, probably the housing of the gut with the normal bacterial flora will be facilitated rather than preventing this right from the beginning, and on top of that adding antibiotics.
There was an article in BMJ on that.
Yeah, but again, in this area, if you have two publications saying one thing, there are 5 publications saying the opposite. So that's why we cannot still say, most of these are interesting, but still no consensus on any of these areas.
So I think you must be very impressed with the bypass here, or a wide bypass concept. We would often be tended to believe that it is the calorie restriction, it would be the loss of all, but the concept says when you do gastric bypass, and particularly they have done, as Dr. Mohali showed, data in R and Y bypass, the microbes tend to change, and they perhaps are benefiting, and they are going, there's a lot of work being done.
So that is very important, because earlier it was thought it is just a mechanical thing you are doing, or you are doing a malabsorptive thing. In gastric sleeve resection, they thought it is only mechanical. The stomach is small, so they will eat less. But now we know that there is much more involved rather than just mechanical, like the gut endocrine axis, the ghrelin levels which are reduced from the. So that is why even before the weight falls, the insulin sensitivity improves within a few days. Even they have not lost even 1 pound of weight, but the insulin sensitivity has started improving, thereby meaning that there is something beyond weight, something which is going weight independent effect of the bypass.
Thank you indeed, Dr. Mohali. It was really fascinating. Thank you.
Thank you so much, sir. I would like you to please stay on the dais and receive the moment. I would like Dr. Puneet to please present the mementos to the chair to us. Dr. Ashwini Kansal and Dr. B.S. Bhatia. Thank you so much, sir, for giving us a reason to live with from now on. And we can play with media for those extra bumps. Moving ahead, I wish to invite Dr. Rahul Jindal, Director Vascular Surgeries, Fortis Hospital, Mohali, to enrich the audience with his knowledge and to chair the session. I request Dr. Harpreet Silhotra and Dr. V.K. Menon.
Good afternoon, everybody. Speaker is Dr. Rahul Jindal. Happy to be very well. Dr. Rahul Jindal is present working as Director Vascular and Endovascular Surgery at Fortis Hospital, Mohali. He is working in this field for the last 21 years and is with Fortis Hospital for the last 10 years. His area of expertise includes peripheral artery and venous intervention. He completed his FRCS from Royal College of Surgeons, Edinburgh. He is the President-elect of Venous Association of India. He has popularized the treatment of diabetic foot, endovascular treatment of aortic aneurysm, and laser ablation of varicose veins in this part of the world. So I would like him to speak.
Thank you, sir. Thank you, Dr. Puneet, for inviting. It's slightly different topic from all the medical lectures we have been listening since morning. So it will be slightly on the surgical point. But the basic concept is that all the metabolic things, all the diabetic patients, they are prone to one of these very major complications, what we see a diabetic foot. We used to think that it doesn't happen. So you can imagine we get around 4 new patients every day in our OPD. And so we treat approximately more than 200 patients per month with diabetic foot. and few of them, they lost their life because of diabetic foot, and few of them, they lost their limb. And others, they require a huge amount of interventions from our side and from them to save their foot. So it's not a very good disease to have, and that's why prevention is of course better. So if you have a very good metabolic control, then chances of these complications becomes quite less. We have been treating diabetic foot for the last 16 years, and so whatever we have learned from the treatment, I'm just going to go through that. We know we've got a huge number of diabetics, and as we have already mentioned, we are going to be one of the largest number of patients we are going to treat. And if we think that whatever the data we have from our country, from South India, around 20% of the patients with diabetes are going to have foot ulceration. Now, which is a very problematic. So if you look at the number, and if you look 20% people will have a diabetic foot, so that's a very huge number, because if you look at the number of physicians who can treat diabetic foot, they are in hundreds. So prevention is the most important thing, and sugar control is one of the most important thing in these patients. But you also have to remember this slide, because if the patient has one limb problem, then 70 to 80% of these patients will have the other leg affected in the due course of time. Now this is a very big issue. What that means is that all the patients in our OPD, we are going to keep on having an increase in the patients, because all the patients which we treated 5 years, 6 years back, they are all coming back again now, because they stopped taking the treatment, they don't care, they are lost to follow-up, and then suddenly within 2 to 3 years they come back again with a very bad diabetic foot, either on the same leg or on the other leg. So that's why we cannot discharge these patients from our clinic lifelong. And long-term outcome, you all physicians, so you all know that if we follow up like approximately 100 patients, and in 10 years time, around 50% of these patients, they will lose their life. And this is because of various other arterial issues what they have. So what we feel is that the most common reason for amputation is unable to understand what exactly is diabetic foot. So this is what is all diabetic foot is. So basically we got 3 different types of diabetic foot. So one is where the nerves are affected. You get a sensory motor autonomic neuropathy, and you get a callus because of the pressure, source because of the bad footwear or because of the motor neuropathy, and this callus is not treated properly, and then you get a very bad diabetic foot and you lose the limb or the life actually. This is because of arterial thing. Just like you get acute heart attack, so you get an acute occlusion of the vessel in the leg, and you get an acute gangrene. And in diabetes, most of the time it will be a wet gangrene. It will not be a dry. So that's why it will be associated with cellulitis, very bad features of sepsis in the body. And these patients are already metabolically not stable, so they will present very badly. And here we can't save the limb. The limb is gone. Now this is a very important foot, where you get both neuropathy and vasculopathy. So you got nerve occlusion. So the patient starts with the callus, but you cannot control the infection with antibiotics. And the reason for that is because you get poor blood supply to the foot. So which is a very big problem, because the moment you get a poor blood supply to the foot, so the antibiotics will not reach. So the infection will keep on spreading even if you keep on treating with antibiotics. So here the treatment has to be very aggressive. So you can't treat the patient with simple antibiotic like augmentin or something like that, because the patient will not respond to oral antibiotics. So you need to be very aggressive in this group. So let's see how to evaluate such a patient. So of course you take up the whole medical history, which is very important, all the risk factors. All our patients with diabetic foot, they are evaluated by 3 physicians mainly: endocrinologist, cardiologist, and an ophthalmologist. All patients. Irrespective they have a problem or not, their sugars are controlled or not, because these 3 different group of people, they actually help us in stabilizing the patients metabolically. And ophthalmology is very important because of the retinopathy, cardiology and endocrinology, as you know, they are very important part. And all these patients, they should be evaluated by this group of people. Then we do a very simple test in the outpatient clinic. We make the patient lie down, we examine the pulses, Then we do either a tuning fork or a light test, or you can just use a 10 gram monofilament test, which is very easy to use by the nurses, and so that at least we get a gross evaluation that the patient has got a neuropathy or not. In our clinic, we don't use this much because most of the patients who are referred to us, they are already in the advanced stages of neuropathy. So they already come with an ulcer or a gangrene, then only people are referred to us. They don't come for preventive treatment to us. So the most of these things should be done by the physicians where the patients belong to. So you can also buy this machine in your clinic, and I recommend that all of you guys, you should buy this. So it's a very simple machine, it costs around 30,000-35,000 rupees, and that gives you an objective measurement of what amount of neuropathy this patient has. Now what we have found is that patients are convinced with this a lot. Let's say if they have a moderate neuropathy, and we tell them, you see, आपका पैर इतना खराब है, and आपको अब sugar control नहीं है, उनको लगता है बहुत sugar control है, but sugar is not controlled. You need to work on this, and we do repeat the test after 6 months again and see does your neuropathy improves or not. So that makes the thing, because people need to understand that neuropathy needs to at least stabilize at that point and should not deteriorate further. Then this patient needs to be evaluated for peripheral vascular disease. Now this is a very big problem in diabetic patients because the vessels are calcified and you may not feel the pulses. Now which is a big issue because calcified vessels, dorsal posterior tibial you can't feel, and patient may have an edema because of the neuropathy in the foot, so you can't see the pulses very well. So that's why Doppler is a very good investigation. And luckily we got so easily, so many centers are doing that in our city. So we should, if you're in doubt, please get a Doppler done, arterial Doppler. And angiograms, we in diabetic foot patients, we avoid. And we have to be very careful what sort of an angiogram we need to do. Because, and that depends upon clinical examination. So please, if you see a patient with a toe gangrene, just don't order CT angiograms. The reason for that is because all these patients has got nephropathy, mild nephropathy. Patients, we have to be a bit careful of giving contrast and in all these patients. So if you clinically examine and you find that patient has got a palpable femoral and popliteal pulse, then both CT and MR angio will not help you. And Doppler will show you, Doppler will be the best investigation because it will show you the velocities in the foot, which we want. And if the patient has got critical limb ischemia in the foot, that patient requires an intervention. So then we don't do CT or MR angio, we directly go for DSA and intervention at the same time. So that really helps these patients by avoiding the contrast, money, and of course the danger to the kidneys. Now, what is the best treatment for this group of patients? This is a very big debate. Do we do surgery or should we do an endovascular intervention? As a lot of cardiologists are there, so I will put in a neutral picture. So rather than just going for an endovascular, because unfortunately, like even in our vascular surgery group, when we have national meetings, most of the people will present only endovascular. So now people present only one lecture, maybe they are in the whole conference on open surgery. So which is not right thing to do, and because whenever I give a lecture, I will give a sort of what is the right treatment for the patient. There are no randomized trials which has been conducted. Should we do an open or should we do an endovascular? So everything what we have learned is with some publications and personal experiences. Surgical bypass has got advantages, definitely. You know, they are durable, they last long. But they got a lot of disadvantages. Makes a big cuts in the legs. These wounds, they very reluctant to heal. Patient gets infections. Patient has got morbidity, and it associated with 3 to 5% mortality in the patients. So imagine an 88 years male coming with a critical limb, and you do a major bypass. And bypass takes around 5 to 6 hours. So it's not like half an hour job. So they are big surgeries. So they actually take more time than the coronary artery bypass surgery if you do it properly. So that's why things need to be think about it. Catheter wave based interventions are fantastic. They can be done under local. You don't require anesthetic checkups. You don't have to stop clopidogrel, aspirins, and you know they can be repeated. It's non-invasive, but they got a disadvantage. Most of these endovascular interventions they will block within 6 months to 1 year's time. If you do it in the diabetic foot we are talking now, and most of the diabetic foot interventions are below the knee. So that's what we are talking. So the long-term patency is a problem, and cost issue is an issue, because if you have to do it repeatedly, it's a big of a problem. Now let's look at the anatomical factors, what we look at. So location where the blockage is very important, morphology of the lesion, and what are the guidelines, what we say. So this is just 2 slides, don't want to go in detail. Basically, it shows that if you have A, B, C and D, a classification, minor blockages are in grade A and bigger blockages are in grade B, grade D. So that's what the classification is. If you have smaller blockages, they go up. So we all know, when we have a smaller blockage, single vessel block in the heart, we say, oh, cardiologists can put in the stents. And if you have a triple vessel disease, we refer it to the cardiac surgeons to do the bypass. So similar thing in the peripheral arteries. So if you have a smaller blockages, we can put in stents and do an endovascular. If you have a long blockages, we can do a bypass surgeries. So similarly in the legs, we have a small blockages and total blockage of the vessels. So similarly, according to that, what is we intervene. But this is not that forward and that simple, because only morphology of the lesion does not decide should we do an endovascular or should we do an open. I'll just give you an example, then you will understand. So let's see this patient. So if this is a CT angiogram, aortic block. So from here to here is a total block, and patient has got critical ischemia. Okay, so now if you just send me this picture on WhatsApp, I'll say, oh, do the bypass, because that gives the best result in this group of patients. So similarly, I'll say, oh, he is 78, he has got a coronary artery disease, he has got mild renal failure, he has got uncontrolled sugars, blah blah blah, and you put in a lot of ifs and buts, then I'll change my situation immediately, and endovascular intervention will be the best for him. So that's why only morphological pictures will not help you in deciding what will be the best for this patient. So this patient actually talking about a lot of comorbidities, and we did it. This is a task D. So if you look at the guidelines, it should be done open surgery. But if this risk patient, I would have done open surgery, 25% mortality, which is huge, like every 4th patient will die. And if I do an endovascular intervention, the risk in the experience has is less than 1%. So it's nearly 0. So it's a big difference. So what we did, and so we put in the stents in this group of patients. So it's not that I want to do an endovascular. It's because what is the patient's condition that will decide. I know these stents are very long. They will not last more than 2 to 3 years, but the patient may not last for 3 to 4 years. So if these stents they block, I can go up and open them again. So the patient will have the legs up to the time he is alive. So that's what the principle is. So let's see another patient. You got another 77 years old lady and got a total blockade. So all these patients are critical limb. So I'm not talking about claudication at all. So because most of the peripheral vascular disease, for claudications, we don't do interventions, most of them. So these are all critical limbs. So here the blockage is from here up to the anterior tibial artery, and there is only small anterior tibial artery runoff. Now in Australia, America, and especially in Europe, they started doing an endovascular intervention in this group of patients aggressively 8 years back. Aggressively means aggressively. Putting in like 5 stents and this and that, and the patient could go home on the same day and all this. All these patients used to come back within 2 months and 3 months. They used to check angios every 3 monthly. And 6 years down the line, then they learned in 2015 that we should not do it. Okay, so now most of the people in such a long block will do a surgical bypass because that gives the best results. But if this patient is very sick and very frail, maybe around 88 or 90 years, and the patient really want to save the limb or because of the pain, so then endovascular intervention is an option in this patient. So we did a bypass from here to here, and you can see from there to there, and this is a long bypass, but patient can sustain very well. So similarly, you can look at another patient. This is another patient who has got total blockage on both the legs. So this is the thigh area, and this is the total blockage on the SFA. Now both these lesions are task D, means the bypass should be done. So that is what is the guideline shows. But most of the advanced vascular center will not do a bypass in these patients. So most of the people will do an endovascular intervention. And even if the guideline shows that open surgery should be performed. And the reason for that is because it is in such an area where endovascular intervention is very straightforward, it is without any risk, done under local, and there are advanced intervention mechanisms which are available now, which gives us a very good result. So even if this patient has blockage of this vessel 2 to 3 years down the line, I can still reopen it. So I will prefer an endovascular intervention rather than going for an open. So another patient who has got a critical limb, you can look into the gangrene part, and if you look at the angiogram, so this is below the knee vessels. So you can see there is no vessel, all triple vessel disease patient has, and look at the foot angiogram in the Delays face. There is no vessel in the foot. So most of these patients, people used to do an angio, say no vessel runoff, leave the patient alone, we can't do anything, patient for below knee amputation. So this used to be the norm in 2008. And 2009, when we started doing this intervention, we thought, okay, there is no harm in trying. So because nobody knew, because this case is not fit for bypass also, because where will you bypass? There is no vessel there. So people used to land up advise amputation. So then, over a period of time, people started playing with these vessels, and then they realized that these vessels, they don't appear on an angiogram, and you can open up the vessels up to the metatarsal arteries with the smaller balloons. And then people started doing an intervention with a very, very small balloons up to the ankle, and you can look at these vessels, what you can open up. So both the posterior tibial artery open up into the vessels, you can open up the peroneal artery, and once you have opened up these vessels up, then you can do a debridement and wound management. There are a lot of things into that, and you can save this patient's foot. So there is a huge development which has happened in this field. Just 1 or 2 examples more maybe. Another critical limb ischemia. Now think what we don't like in this patient is somebody has done an amputation of the toe. Now which we don't like, because you should not do an amputation before evaluation for the vascular system. So somebody has not even examined the pulses, because if it would have, so you can imagine the amount of blockage this patient had. There's a big blockage in the popliteal artery and the SFA. So patient, was an issue, so somebody has done the thing, amputation, and that has made the situation more worse for us, because it's an open wound. So in this patient, now this is a problem. Now this area is a very big issue, and if you do an endovascular intervention, the chances are this artery will block within 3 to 6 months. Popliteal artery is behind the knee, and this artery doesn't remain patent for very long. So we will do the bypass if the patient is fit for surgery. So we did a bypass, long bypass from here, SFA to the posterior tibial artery, and once you do the bypass, these wounds can heal up very nicely after that. This is another patient which we saw in the first case, how to evaluate that, and when we saw this is an ankle here. So there is a total occlusion of anterior tibial artery and the posterior tibial artery here, and so you can easily open this up with the balloons. You don't have to put in the stents here. So we hardly put in the stents. In last 10 years, we have put in 1 stent. And so you can imagine the amount of stents what we need to use is very little. And so we open this up, and once we have it up, then we do the debridement. So opening of vessels is only one part. Then the wound care starts after that, which is also a very big chapter, and unless you have a very good wound care management, you will lose the foot, even after doing the blood supply. There's another case, got total popliteal artery occlusion here. You can see all triple vessels are gone in popliteal area. So we tried an endovascular intervention. If you get a very good result, it's fantastic. If you don't, then we have to do the bypass. This is another very good example where you get a proximal arterial occlusion on the left, total common iliac occlusion. This is there, patient has got a critical limb ischemia on the left, and this patient was very unfit for an open intervention. So the best treatment for this patient will be do a bypass from here to here. But we could not do it because patient was not fit enough, and the colloquial and all those things could not be stopped. So then you can do a hybrid operations. So you can combine an open and an endovascular intervention, and the whole procedure can be done under local anesthesia. So this is what you can do it. Basically, you can put in the stent on this side. So that's this narrowing is occluded, treated, and then you can do the bypass from here to here. So this can be done under local anesthesia. So this is what we did, and once we have done the bypass, the patient can be discharged home actually next day. So this is quite straightforward. Now this is another patient who has got a critical limb ischemia on the heel, total popliteal occlusion with a very small anterior tibial. Why I put in this patient is that most of the people, if you do show the CT angio, so they will say nothing can be done because it's a very small vessel with no distal runoff into the artery, so just do an amputation because there's no point doing a bypass also. But it's not like that, as I showed you the angioplasty. So once you put in the blood into this small vessel, it really vascularizes the whole foot. And if you do the very good medical management and the wound management, most of these patients can be survived. So you can imagine this patient, we did the bypass and this wound heals automatically. Just another case, very extensive diabetic foot. Now this has happened within 24 hours. So you can imagine. So diabetic foots are not to be treated lightly. So within 24 hours, if you have got anaerobic organisms, they will spread like anything. So within 24 hours, patient can reach ICU. So that's why we need to do extensive debridements of all these patients, and once we're done, they can heal up. Now this picture I put in because this patient had total calcaneum exposed. See, 7 years down the line, before, all calcaneum exposed patients, we used to do a below-knee amputation without even doing an intervention. So then we started treating them, and we had one patient, and we presented in a national meeting. Total calcaneum was exposed, so we revascularized it, started treating it, the wound healed up, and patient was walking up to 4 months. And after that, we have started treating all calcaneum exposed patients now routinely. So we got more than 50 patients who had total calcaneum exposed, so we done a partial calcanectomy, and these patients are walking now. So over a period of time. So once we have done the revascularization, these wounds they heal up, the whole calcaneum gets covered up with the granulation tissue. Then we put in a small skin graft and this wound healed up. Now you can imagine this is the father of a surgeon, okay? And he is a general surgeon, was treating the diabetic foot at home and did a multiple debridements at outside and didn't examine the pulses at all. Now this is another very good example where just a simple pulses examination would have really saved the foot. Patient was very critical and he was in ICU here. And this patient had a blockage here, one here and then total blockage here. So this patient requires a hybrid procedure. So what we did, we under local anesthesia and a femoral nerve block because patient could not even given a spinal also. So we did an iliac stenting and femoropopliteal bypass PTFE under local. So under local anesthesia you can do all these procedures, and once you have improved the blood supply, then these wounds they start healing up very nicely, and then you can get a very good results. Okay, I think it's the last case. Another patient with a diabetic foot here. On the heel, you can see once you do the debridement, you get the calcaneum exposed, and then still it heals up. And this patient was there. You can see more than 60% of the foot is gone. So what I put in this picture is that even if up to the metatarsal joints, they have gone, the foot is amputated. So we opened up the anterior tibial and the posterior tibial artery in this patient and then started treating the wound, and still you can save the foot, and patient was walking on the foot. So that's why major amputations is a very big thing and they can be avoided if you are very aggressive. So this is the graph in the world, if you can look into this. So endovascular interventions have gone up and open surgery has gone down, and this is the same in our unit. Now we do not more than one bypass a month. We initially used to do around 10 to 12, so it has totally open surgeries have gone down. But the choice of intervention will depend on a lot of things. It depends upon the patient, what is the condition, how is the wound, what are the vessels, and how much patient can afford, and all those things matter. So it's not about doing an open and endovascular, it depends on patient to patient. Thank you.
Thank you, Rahul, for a very excellent talk. So now the house is open for discussion. Just a few questions I wanted to, for setting the ball rolling. In a patient who requires revascularization as well as amputation because of gangrene, what is your sequence of procedure? Revascularization first or amputation first? And what antiplatelet regime you continue during these amputations?
So first of all, in our, we do all hybrids. So what that means is, the patient comes with a diabetic foot to our clinic. So we will evaluate that day, putting on antibiotic, get all the consultations done, next day posted in the theatre list. So once we in the theatre list, we can do everything in one go. So we will open the vessels up in the same sitting. We give normally the femoral nerve block or ischiatic nerve blocks at the same sitting. So we do either the angioplasty or the bypass, whatever the patient requires, depending upon that. The moment we done it, we do the debridement or the application at the same sitting, on the same day. Continue. So we continue heparin, aspirin, clopidogrel, everything. So patients are on all the three, and so we don't have a problem in doing actually any vascular surgery on any drugs. So we continue that.
If we see our European counterparts, once we are considering the diagnosis part, they use plethysmography extensively and use CT angiography in very selective patients because maybe the healthcare is centralized.
Yeah.
So in India we are using extensive use of CT scans but not using plethysmography. Any comment on that?
Yeah. See, plethysmography is totally out. Plethysmography is totally only for research purpose. We don't only for if you want to document it. So we don't in a routine format. Hardly any center I know in the Europe, every country.
Zeller, who is doing peripheral angioplasty courses, they are using peripheral this plethysmography extensively in all the patients.
That's what I'm saying. So it's like one center may be there, but nearly every center in the world now has stopped using that drug because it's very cumbersome, it takes a lot of time. Secondly, as I told you, if we are talking about only diabetic foot, peripheral vascular is very vast. So if you are just talking about diabetic foot, most of the patients will have infrapopulated disease. So we avoid doing even the CT angios or MR angios in these patients because MR angio will have venous contamination, so you will not see any vessels below the knee. CT angio, because of the calcified disease, they will not be able to tell you it's really blocked or it's not really blocked. So it doesn't make a difference. So if you have a femoral and popliteal pulse palpable, then just do a Doppler. And if the Doppler shows overflow, then we do an accelerator puncture on the same side, and the DSA is still the gold standard for diabetic foot. For diabetic foot, I'm talking about. So that's the best. Yes, sir.
Thanks, Rahul, for a very illustrative talk. And I agree with you, peripheral vascular disease is a very, very difficult disease and to tackle as well as to have, it requires a lot of patience to deal with this kind of patients. My only question is, endovascular of course is picking up because of the low risks and low mortalities and morbidities, and it's same as in coronary artery disease. But they have more chances of early blockages.
Yeah.
So if you have done a wide graft or what we call as typical pajama graft in aorta and villi, and it blocks and you require open surgery, how difficult it is possible, and how you tackle it?
Sir, because the talk was only on diabetic, that's why I didn't elaborate it on the aortoiliac disease too much. Aortoiliac is in diabetic foot patients is very rare. And so for task A, B and C we do all endovascular. For task B we all do aortobiphasic. And aortobiphasic is such a bypass which will not block unless it's a technical error. So that will go for years to go. And so that's the best treatment for that if you have a major blockage. And if you get, I understand your question, once it's blocked, once you reopen it. So once it blocks, so normally if the patients are careful, they can come early because normally one limb blocks. And normally one limb blocks is because of its anastomotic narrowing, normally. So what we do a hybrid. So we take the patient inside, we open the graft under local anesthesia only, we don't even do spinal because at the groin level, we do an embolectomy from the top, so the blood flow comes in that area, then we remove the clot from the below, and then we balloon the anastomosis. Because you have to do, because there has to be a reason for the graft blockage. So any artery will be blocked because of narrowing. So what we have seen is either an SFA block or an anastomotic block. So we do the balloon angioplasty in the same setting. So the inflow is increased from the top, outflow is right, then we close the graft. So that gives a very good results.
Thank you so much, sir, for that extremely educational session. Now I would request Dr. Puneet to please give away the mementos to respected speaker, Dr. Jindal.
Deep.
Our co-chair, Dr. Vilotra.
Or you?
I would request Dr. V.K. Mani to please accept our good wishes. Now moving ahead, I may call upon Dr. Keval Krishnan, Program in Charge, Heart Transplant, VAD, Senior Consultant, CTVS, Max Super Speciality Hospital, Saket, New Delhi. And to chair the session, I would request Dr. Virinder Sarwar and Dr. S.S. Sodi to chair the session.
So I am Keval. I am going to speak on heart transplant and ventricular assist devices. So advanced heart failure is a significant cardiac dysfunction as with the dyspnea, fatigue and organ hyperperfusion or with minimal exertion despite maximal medical therapy, or it stays AHA stage D, or refractory symptoms requiring specialized intervention to manage symptoms or prolong life. Heart failure is basically when you have a problem of the coronary arteries, you go for stenting or bypass surgery. When the problem is in the valve, you go for repair or replacement. When the problem is in the muscle mass, then your ejection fraction is low, the function of the heart is poor, then you either need to go for heart transplant or ventricular assist devices. All the surgeons and cardiologists, they are aware of this balloon pump. The balloon pump supports only 50% of the circulatory support. Tandem heart and impeller 2.5, they supports 30 to 60% of the cardiac output. These devices, they support 100% of the cardiac output. And if the patient, also lung support is required, then you can put the patient on ECMO. But the ECMO is an extracorporeal device, works only for a few days to a few weeks. At Max Hospital Saket, we did 9 ventricular assist devices in last 1.5 years, 5 HeartMate 2s, HeartMate 2s 5, HeartMate 2, HeartMate 3 2, and Heart Transplant 3, and ECMO 48 so far. This is how the device looks like. When you put its inflow cannula, the outflow, the pump, and the outflow graft. These are few devices which are available in the market, and these are third generation centrifugal pumps. One is HeartWare, another is HeartMate 3. This is the fully magnetically levitated pump. It's the most advanced pump so far. And another is MVAT, it's even smaller, but it's still under the clinical trial. The another device which is called Circulite, it support partial support 2 to 4 liters of flow, and this was withdrawn from the market because of its thrombosis rate. Whichever device you put in, the basic picture is going to be like this: the device, the driveline which comes out of the body, the controller and the batteries. These are batteries, controller and the display monitor. With the display monitor usually remains with the treating physician, and we can make out what is happening inside because we get a lot of parameters so that you can make out what is happening to the patient, and when the patient comes for follow-up, you connect to this, and whatever the patient say, you can make out whether he is lying or he is saying the truth, and you can get 240 last events with this monitor. And this is how the pump works. When you connect it to the ventricular apex, the impeller rotates almost 5 to 7 liters of flow, which is a normal cardiac output, is given to the ascending aorta. So that is how it helps the left ventricle, so it's called left ventricular assist devices. And this is how the device works. When the patient is in end-stage cardiomyopathy, the heart is like a balloon shape, ejection fraction is low, back pressure changes are high CVP, high PCWP. That's why patient is symptomatic. When you put the device in, the heart gets relaxed, your CVP, PCWP, they come down, your forward flow increases, back pressure changes are less, forward flow increases, and your ischemic liver, ischemic kidney, they starts getting more blood, and patients feels more, the patient clinically looks better. The first patient 1.5 years ago we did was 38-year-old gentleman, known case of cardiomyopathy with AICD for 2 years. Admitted to another hospital, he was on ventilator with pulmonary edema and multi-organ failure. He was told that he would die in the next 2 hours, then we received call to put an extracorporeal bed. He was transferred to our hospital. We put a balloon pump, inotrope swan, and tried to optimize it. At 2 o'clock in the morning, we transferred the patient to our hospital. At that time, the labs were like TLC 24,000, creatinine was 7.8, urea 272, SCOTP days in 8,000s. And his neurological status wasn't known. We started on CRRT to reduce the creatinine. After 2 days, the patient woke up. He was on ECMO infusion for ventricular tachycardia. He was recovering, and then we discussed, because he was a young guy, dilated cardiomyopathy with ejection fraction of 15%. We discussed with 2 options. One is heart transplant, another is ventricular assist device. Because of paucity of organ donation, LVAD looked to us more appropriate. And this was his ventricle on echo. Before optimization it was 8.2, and after optimization it was 7.8. So this ventricle is never going to go normal. So the patient agreed to go for ventricular assist device placement, but because of a lot of money involved in this, they had to take some time to collect money. So meanwhile, we thought that now we are going to put the ventricular assist device. So what we did was we tried to avoid the center line. So we removed the balloon pump also, because patient was looking clinically normal and he crashed. He was reintubated. And then he got better. But I mean to say that this patient could not tolerate even 3 hours of removal of balloon. You cannot send such kind of patient home without any mechanical support. So we put the device on in February 16, 2015, and balloon pump and everything was removed. He was discharged after 3 weeks. This is how the monitor looked like. This is 5.6 liters of cardiac output and the other parameters. With all these parameters, with permutation and combinations, we come to know what is happening inside the patient. Hypovolemia, tamponada, anything, whatever, and with the other clinical parameters. This is how the drive line which comes out of the body, and we fix this with a holster that it should not move, the exit side should not move, because this is going to stay for next 15-20 years. And we don't want any movement at the exit side to increase the hole so that it causes driveline infection. And once we discharge the patient, we usually do the CT scan of patients to see that this outflow graph, there is no inking of the outflow graph, otherwise it will cause increased requirement of the increased work of the device. And another is this driveline should not be, there shouldn't be any kinking of the driveline. While putting, you have to be very careful, because this is an if there is any damage in the coverage of the driveline, because I thought this is going to stay for many years, it can cause the electrical malfunction and that lead to malfunction of the pump. And this is the same volume rendering image of the same patient. You can see how the pump is going inside the body. And this is a patient after, just before the discharge. When you put the device in a patient and you ask him to, it's time to go home, they get scared. So what we do is, before surgery, before the discharge, we send the patient to cafeteria without any nurse or doctors for 3 days, so that they become comfortable with the device. And device is like your mobile. In the first 3 days, you see what you've done, where should I find things, and within 3 days you become master of this. Same thing happens in the device. Within 3-4 days, the patient becomes master of how to deal with this device. And after 6 months of device, because he is an education counselor for the student, the NCL University gave him some prize at 6 months. And the next patient, I asked him to walk, and I asked him to walk in the corridor, and he started dancing in the corridor. It's the 9th day after the surgery. It's not like the LVAD patients, they will be like sick forever. Another device which we put was hardware. There are 2 different kind of devices, hardware, 3 hardware. There are different ways of putting it. So first we put the ring at the LV apex, and then put a glue around that to avoid any bleeding, and then core this, and then this is how it looks like once you core. You take out the chunk of myocardium from that, and then you put up this pump into that, and then you have to screw it. So and then once you have done the inflow cannula, then you put the outflow cannula like you do the right coronary anastomosis. And this is a 4th day of surgery. Before going, the patient was shifted to the ICU, from ICU to the room. So this patient's story is he had 4 factories, and then he stopped working, and he thought that he's going to die in the next 5-6 months, and when we put a device in, now he's opened. He's inaugurated another 5th factory because now he thinks that he's going to survive for the next 15-20 years. Another device which we did was HeartMate 3. This was the first in this country and second in Asia. This is a fully magnetic, levitated and most advanced pump so far with least complications. And this is how, before putting the device in, we de-air the pump. And this patient also had LV clot and aortic valve regurgitation, so we removed the LV clot and repaired the aortic valve before putting the device in. This is a different kind of ring, and then we put it and then we fix it, and this is the outflow graft. And once the patient comes to the ICU, this is a picture of just after the patient came to the ICU. It's very intensive monitoring of these patients. You can see it's the left-sided monitoring is done by the monitor, the LVAD monitoring, and then a lot of swing pumps, and then right-sided monitoring is done with the SWAN, and then with RV, stroke volume index, and a lot of things, and then the normal regular monitor in the ICU, and nitric oxide, ventilator. Because these patients before surgery, their cardiac output was 2 liters. So right ventricle was giving 2 liters and the left ventricle was also giving 2 liters. Now you have put a device in and your left ventricle is giving 5 liters or 4.5 liters. So right ventricle has to give 4.5 liters. That should reach into the left side. So you have to optimize between native ventricle and the mechanical ventricle, and they don't talk to each other. So you have to have you should be very careful in doing all these things, otherwise your right ventricle may fail and then lead to right ventricular assist device placement. This is our picture at the while operating. And this is another lady, it's a 49-year-old lady, admitted 9 times, and then she agreed to go for LVAD. Because we didn't offer her heart transplant because her panel reactive antibody was 85%, and that more than likely she's going to reject, so LVAD is more appropriate in such kind of patient. The only thing you need to care of after putting an LVAD is INR, keep the INR around 2.5, and that's the only drug. It's not, unless heart transplant, like you have to give 7 different drugs. Another thing which we do is a short-term extracorporeal device, that when the patient comes in acute failure and you don't know what's going to happen to this patient, you put this patient on at this extracorporeal bed because it's very cheap itself, and then you decide what to do. This also gives 5 to 7 liters of flow, but the patient cannot leave the hospital. So you can use this device as a bridge to recovery. Then once the patient gets acute failure, gets better, you send the patient home, or as a bridge to decision if the patient survives or the patient dies. Or you can use it as a bridge to another implantable device, like you can put a HeartMate 3 or HeartWare. Or you can use it as a bridge to transplant if your heart is available. The advantages of ventricular assist device over heart transplant is, after the age of 65, we usually don't do heart transplant, but ventricular assist device can be put at the age of 90 or so. And these pumps are made of titanium, so we call it as, after the age of 65, treat every heart failure patient as titanium deficiency. So high PVR, when the pulmonary vascular resistance is more than 6, the heart transplant is contraindicated. You can put this device. Another indication of putting this device is bridge to candidacy. Those patients who have high PVR, you put the device, within 2 years the PVR comes down and then you can do heart transplant. They become eligible for heart transplant. High susceptibility to infection and rejection. Those patients who are more likely to get rejected, or in India, like tuberculosis is very common. If you transplant the patient and the patient already had tuberculosis, it gets reactivated. For those patients also, it's one of the measures we use it. And overweight patient of above 140 kg, we usually don't avoid heart transplant, and you usually don't get donor also. So this is, and it's readily available. You don't have to be on the waiting list for transplant. The day you admit it, within 3 days we can do LVAD. The heart transplant indications are same as, most likely same as mechanical circulatory support, like and life-threatening ventricular arrhythmia, severe symptomatic cardiomyopathy, progressive symptoms despite maximal medical therapy. So this is how we take, when we go to get the heart, it's a donor where the liver team, kidney team and the heart team, they are working together. And once we put the cross clamp on the aorta, after that the 4 hours we count, that from taking out the heart, taking to your hospital and putting over there and restarting the circulation. This is called ischemic time. That is why we do the green corridor, to avoid the ischemic time, because the heart has the least ischemic time, 4 hours. The liver and kidneys, they have more ischemic times. So once you take this cross clamp it, just decompress the heart and put a lot of ice on this to reduce the metabolism of the organs, the liver and this. You can see the liver, kidney and heart are, all the surgeons are there, but taking out heart takes only 5 minutes, so we usually request the liver and kidney people, because they have 12-14 hours. So we request them to just take us and let the heart take out. It's the first organ to take out from the body. And meanwhile we give cardioplegia. It takes almost 2 to 3 minutes to give cardioplegia. And once we have cardioplegia is given, so remove the ice and then cut the heart. So I'll show the next picture once at green corridor picture. So this is a movie of 2 minutes. Will show how the heart transplant is done. Sound. So this is a patient after third, fourth day of surgery, and the half-life of these patients is 11 years, conditional half-life is 14. Conditional half-life means those who have lived for 1 year after heart transplant, they're more than likely they would survive for more than 14 years. So the functional status of these patients is It's 95% of the patient, if you see there is no activity limitation, they can do the normal activities which a normal person can do. Only 4% of the patient they perform with some assistance, and only 1% of the patient they require total assistance after heart transplant. We use cyclosporine or tacrolimus, mycophenolate, prednisolone and statins for as immunosuppression, and these are the method to diagnose. One is blood test, that is called ALOMAP. Another is the biopsy, which is a gold standard so far, but the number of biopsies we have reduced using it. And the third is graft dysfunction, to know that with the echo or clinically or with the right heart cath. The another thing which we do at our center, I would like to mention, is we are doing the maximum number of ECMOs in this country. As this is an extracorporeal device, and when your patient is on ventilator and cannot maintain oxygen saturation despite 100% for 6 hours, and the X-ray looks like this, we put the patient on the ECMO after heparin anticoagulation, and this is how we take out 5 liters of blood and put oxygenated blood back 5 liters. And within a minute, the saturation comes up to 96, your ional probes, they go down, the pulse and blood pressure, they get better. And once the X-ray gets better, we shift, we remove the ECMO, we retrieve the patients, and the first surface retrieval and first air retrieval we did at Max Hospital, Sakir. This is how we bring the patient. And if you have more questions regarding LVAD, ECMO or heart transplant, you can go to my website, kkrishnan.com. Thank you very much.
Thank you, Dr. Cable.
Thank you, Dr. Cable, for an excellent talk on very challenging procedure and subject. 2 questions. I just want to, for my knowledge, that what is the criteria of going for heart transplant, end-stage ischemic cardiomyopathy, in presence of today's technology-wise like PET available and off-pump surgery? And the second question is that what kind of challenges you face in looking for the donor hearts, and what will be your advice or guidance to the audience to promote this more and more?
So answering to the first question is, when your patient is ischemic cardiomyopathy, and if the vessels are amenable to either intervention, the stenting or bypass surgery, we should give try to that, because heart transplant is a major undertaking. If the patient like 15% ejection fraction or 20% ejection fraction and the vessels are graftable or the stenting can be done, one should try first those conventional treatment before going for heart transplant. Because then after heart transplant you have to use immunosuppressions and another issues are also related with that. But if they are not amenable to, vessels are not amenable either to stenting or bypass, then you can go for heart transplant. And despite this CME or stenting, if the patient is still symptomatic, one should go for heart transplant. Shouldn't be waiting for the patient to go in arrhythmia. The next is, I would request all you, if whichever the NGOs and stuff you are being a leader of those, you should encourage and aware the organ donation for the sake of those patients, those who are dying. So I would advise, rather I can only request these people that whichever hospital you are working or whichever group you are associated, you should increase this organ donation awareness, because in North India the problem is you don't get heart and these patients they die. Believe me, when I came 3 years ago, I worked up 9 patients, only 1 could be transplanted and 8 they died waiting for heart transplant. And same thing happened. Those patients, those were sent to us, we work up them, and meanwhile if they don't get heart within 8 to 9 months, these patients usually die. So, and with one patient, one donor, we can save 8 lives. Heart, kidney, 2 kidneys, liver, intestine, pancreas, lungs. So, it's my humble request to all of these guys, doctors and associates. Please increase awareness in northern part of this country. Thank you.
I will agree with Dr. Peter. You are right, because I have got 3 patients on the regular follow-up for echo and all cardiac transplants. All have got it in south. So north, I don't know donation.
So because you don't get heart, so you people don't wait for that.
Thank you so much.
Thank you so much, sir, for that illustrative session. I would like to request Dr. Puneet to please present the mementos to our esteemed speaker, Dr. Keval Krishnan, who has spared time to travel all the way from New Delhi to join us.
Thanks. It's a real pleasure to have you.
I would request Dr. Virinder Sarwan to please accept our gratitude for chairing the session.
The organization of my conference to you. Just look at the color coordinated sarees and
I would now request our esteemed faculty to please join us on stage and have a group photograph with our honorable chief guest, Dr. Ranjit Mohali. And we reassemble back for Dr. Neeraj Nagpal's session at 4:30. Neeraj Nagpal, Director, Hope Gastrointestinal Clinic, Chandigarh, to share his insights on for the worthy audience. And to co-chair this session, I would request Dr. S.S. Sodhi and Dr. M.S. Trehan to join us on the dais.
I'm sure after lunch you would all be very energized and looking forward to the further sessions. Dr. Neeraj Nagpal is well known and I am sure he needs no introduction, but for the very few or unlikely people who don't know him, he is Director of Hope Gastrointestinal Clinic, Chandigarh, ex-President IMA Chandigarh. He is well known for being convener of the group, Medico's Legal Action Group, which has done a yeoman's job to protect the interests of doctors. I would request him to kindly present a talk on the activities of the group as well as on this topic. Thank you.
Well, thank you, Dr. Sodhi. At the outset, I must congratulate Dr. Shikha. I don't think Puneet needs any congratulations for excellent organization of this CME, which has the aesthetic touch, which I'm sure Puneet doesn't have. So, congratulations, Shikha. I'll start my talk today. Can we have this on screen? I'll just play a small video before I... Please notice the guy in the scooter who has had this accident. The guy with him helps him up. He drives off on the scooter again and goes and bangs into the car. The car driver comes out to have an altercation with him. He drives off again, goes and bangs into another scooter. And running from that, he bangs into a bus. But this is not the end. Why I am showing this video, I'll come to later. But suffice to say, we all make mistakes, but trying to compound the mistake is worse than making a mistake. Sometimes we end up compounding our mistakes. So to start with the lecture today, the topic given to me was mistakes by doctors which get them caught in a legal whirlpool. The question which I would first like to ask is leaving your OPD patients and cath labs to come for this talk a waste of time and loss of money? Whenever medical legal issues I've been discussing with people, there is sometimes a reluctance or a resistance to attend sessions or to discuss these issues, and the arguments given to me are, I've been in practice for 20 years and have never been sued, so why bother? I'm working in PGI, these problems do not occur to us in PGI, so why bother? I keep aside 50,000 to 1 lakh a year to pay 2 to 3 lakhs compensation every 2 to 3 years if somebody does ask, so why bother? My replies to these arguments are, we take life insurance even though we have never died earlier. We don't wait for ourselves to die before we decide to buy the life insurance. The process of going through litigation and prosecution for alleged medical negligence, in my opinion, is worse than actual penalty on conviction. PGI, AIMS, Civil Hospital, ESI, all are covered under Consumer Protection Act. Also, mind you, there is no limit on what compensation can be asked for. The interest on compensation which may be awarded may be actually more than the compensation itself. And definitely the award of compensation can be more than what the person, the complainant has actually asked for. There are cases where the complainant has asked for refund of his 3,200 rupees, which he had to spend in a private sector because the civil hospital did not cater to his need. And he simply wanted that 3,200 back. The hospital and the doctor decided to pursue the case to the National Commission. They were penalized 5 lakhs. So please do not be under this impression that the person has filed a case for recovery of maybe 2 lakhs or has demanded maybe 10 lakhs. If the court or the consumer fora decides so, they can award an amount much larger than that. Coming to the mistakes actual which doctors make which lead to legal trouble, the first of course is appearing in the NEET exam, completing MBBS thereafter, remaining in medical profession, deciding to remain in India, doing post-graduation, doing super specialization, not retiring by 35 years, and sometimes I think not, and getting married also should be part of the mistakes.
Getting married to the doctor.
Either way. So on a serious note, when we talk of mistakes, I divide them into 5 different categories. These are before treatment, during treatment, after an adverse event, after receiving notice, and the mistakes doctors commit in court actually. When we talk of before treatment to this audience, let me quote what the Supreme Court has ordered in Dr. Kunal Saha's case. That if representation is made by a doctor that he is a specialist and ultimately it turns out that he is not, deficiency in medical services would be presumed. This is a very important line which has come up there. Prior to this judgment, Goyal Super Speciality Hospital versus Krishan Gopal Shukla, National Consumer Dispute Redressal Commission, had made a statement in one of the judgments that this doctor properly got printed consultant physician and also cardiologist on his letterhead. This issue I have raised in an article which was published in Journal of Association of Physicians of India in February this year regarding MD medicine doctors writing physician cardiologist, physician gastroenterologist, physician neurologist. And this was come down, the court has come down very heavily on this, and unfortunately API has not thought it right to appeal this judgment. Indian Medical Council Professional Conduct, Etiquettes and Ethics Regulations 2002 also mentioned that a physician shall not claim to be a specialist unless he has special qualification in that branch. This is 2002 regulation. However, a lot of hue and cry was raised after this came in, and in November they held a meeting of the ethics committee which was ratified by the general body, which said that a doctor can practice in the specialty he is trained for without claiming to be a specialist. I don't know what the distinction is. Meaning to say you can practice cardiology but you cannot have a nameplate saying you are a cardiologist. This is something which needs to be settled at the association levels, but our associations unfortunately are very much interested in who's president and who's secretary. These are issues which somehow do not cross our mind. Among other mistakes which doctors do during treatment especially is consent. They do not take consent at all, taking consent from a relative instead of from an adult, conscious, competent patient. The legal term for that is compos mentis. Not taking an informed consent, taking partial consent, doing something more than what the consent has been taken for. If you have taken consent for diagnostic angiography, You cannot proceed unless it is a life-saving procedure to doing an angioplasty and stent placement. Please be 110% sure on this. And this is true even if you are doing the procedure under some anesthesia. Prabha Manjanda case, Supreme Courts, this is a very landmark judgment. And I'll recommend all of you to please go through this judgment. This is the law of the land today as far as consent is concerned. Other mistakes which doctors make during treatment is documentation. Either there is no documentation, incomplete documentation, documentation but records were not stored properly, delay in documentation. What happened in Kunal Saha case? The lady died in Bombay Breach Candy Hospital. Where was she treated? She was treated also in AMRI hospital. How many days she stayed in AMRI? Only 5 days. Majority of the time she stayed where she died was in Breach Candy. Which was the hospital which was penalized? It was AMRI Calcutta, not Breach Candy. The question arises why? Initially when Dr. Kunal Saha had pursued this case, he had filed the case against both Breach Candy Hospital as well as AMRI Hospital. But Breach Candy Hospital brought up records in court which showed things that were very damaging to his case. It was recorded, he has claimed that the patient was not hydrated. They have brought records which show patient was planned to be given 4 liters till morning, but it was not transfused at the collective request of the patient as well as her husband. The doctor has documented in the file have had great problems with the husband and brother-in-law. It is with great difficulty that I have controlled myself when presented with his arrogance, merely for the patient's sake. These are medical records of Breach Candy Hospital. He was asked to give 3 injections. One he said, fine, I don't think it can do any harm, we will give. The other he said, I don't think there is any use, so we will not give. All these things which were difficulties which the doctors at Breach Candy faced with Dr. Kunal Saha, these were documented in the file. And when National Commission first heard the case, they said there is no negligence whatsoever. He went to Supreme Court said, okay fine, there is no criminal negligence, but there is a case made out for civil negligence. So you go back to National Commission for award of compensation. Second time National Commission, because it had been ordered by the Supreme Court that there is some negligence, they said, okay, 1.72 or 73 lakh crores compensation, but 10% is contributory negligence of Dr. Kunal Saha and he has to pay for it. Now all this was very damaging for him. So when he took the case to Supreme Court again, he dropped Breach Candy Hospital from his array of parties. The final judgment is only against AMRI Hospital and the doctors there. Breach Candy was not sued in Supreme Court. Even when she became breathless, this was recorded, no need to inform the hospital doctors, patient's own relatives. This is all part of the medical record. So the thing is, it was the medical records of Breach Candy Hospital which saved them in this most exorbitant judgment ever given in Indian medical and judicial history. Another very landmark case, Hindu Sharma versus Indraprastha Apollo Hospitals. This case is from Apollo Hospitals. There was a lady who was induced and she was induced for nearly 27 hours. The baby was born finally out with cesarean and had birth asphyxia. The doctor said that they have operated at 2 a.m. at night because there was failure to progress of the labor despite symptoms. But when the records, nurses' records and all were checked, it clearly showed that the patient had fetal bradycardia, the patient had other features of fetal distress and should have been operated earlier. But because the records mismatched, they were penalized 1 crore and 10 lakhs more was penalized because Apollo Hospital said that we have already given all our records, we don't have any more records. And then 7 years down the line, they came up and showed those records also in court. Also, the medical records which were produced in court by Apollo Hospital They have been tampered to the extent to show erasing marks, pinholes. All these things in medical records are not acceptable to our courts, and they are major mistakes. A lot of times doctors come and ask me, Dr. Sahab, ye ho gaya, file bata do, kaise karni hai. The thing is, the file has to be completed there and then. Any advice you need, you have to take there and then, not 15 days later when the one staff nurse has gone on leave, the other staff nurse has left your hospital, when you can't get their signatures on the file. Similarly, this gentleman, he claimed, I have been operated in Nabi Prasad Institute and I have developed eye infection. The hospital, they brought the list of all the patients who had been operated, they brought the list of CSSD documents of that day, and they showed no other patient has had infection, only this guy has had infection. So it is his post-operative lack of care which has led to the infection, and the courts agreed. Another case where this gentleman brought his young son to the hospital and he had AML, 2 doses of chemotherapy were given. He was asked why he has to have bone marrow transplantation. The guy takes him home, goes to some Vaid, Hakim, whatever. 6 months later, he brings him in a precarious condition. Finally, bone marrow transplantation also was done, but the child died. And he claimed he was never told that bone marrow transplantation was to be done. Whereas the documents, the discharge summary, everything which he himself had provided clearly mentioned that he was to report for bone marrow transplantation 2 weeks after discharge. Medical records that are written after discharge or hours after death do not have any legal sanctity. Erasing entries not permitted, questionable in court, event of alteration, entire line or word should be scored off and rewritten with date, time and signature. In this particular case, ERCP was being performed under propofol. Patient had arrest, went into coma, had to be shifted to ICU. 9 months or so, the patient was retained in hospital. Hospital tried discharging. They went to Human Rights Commission. Human Rights Commission forced the hospital to treat the patient for 8 or 9 months. When 2.5 years later, the patient died. But what did the court say? Monitoring and recording of patients' vital signs before and during procedure should have been done. They may have been monitored, but there were no records of patients' vital signs during the procedure. So it is not only necessary that you have checked the vital signs, it is important that you have recorded it. And those records should be reproducible in court. What does the court go ahead and say? The vital signs should be carefully documented and the process should be done virtually in a minute-to-minute basis. Somebody somewhere will have to go and tell the courts that when we are trying to resuscitate, as our professors have taught us, our focus is on resuscitating, our focus is not on filling the file. But somehow, as of today, I think filling the file and completing the documents is more important than actually giving oxygen or CPR to the patient. In some hospitals, the judgment says anesthetists read books during surgery. They are allowed to wear headphones and listen to music. The unconscious patient is unable to appreciate the lack of attention. All this they have come down very strictly on. This is a cartoon I found, a juggler with a sword stuck in the head, and the medical officer is sitting asking what is the spelling of juggling, because that is what it is coming down to. National Commission in this particular case has awarded 47 lakhs. Another case, this was recent in Panchkula, Alchemist Hospital only. Colonoscopy was being done, patient had a cardiac event, had to be shifted, and finally died. Though colonoscopy was being done without sedation, I also do all my colonoscopies without sedation, but the court, this was debated very furiously in this particular case, and the courts agreed, fine, colonoscopy can be done with sedation, without sedation, that is not an issue. But you have done the procedure taking consent of the relatives, not from the patient, hence this is negligence. Similarly, another colonoscopy with daughter's consent, perforation, the hospital went ahead with laparoscopic repair, everything all right, patient survived. criminal case was filed, and in Kerala High Court, this matter was taken up. Consent had been taken from daughter, not from the patient. No documentation that the consent was taken before colonoscopy as per case sheets. Meaning to say, the judges had it in their mind, the consent also was got signed in a haste after the event had occurred, after they realized there is a complication. So in their records, they have not mentioned that consent has been taken before the procedure notes were there. Even BP record before colonoscopy is not mentioned in the case sheet. And they said that normally carbon dioxide should be pumped into the colon, but no record that this had been done. For these things and some other issues, including the doctors giving a conflicting kind of a statement on the reason why the colonoscopy was discontinued. Actually, the consultant was sitting in the same room and the resident was the one who was doing the colonoscopy when this thing had happened. But that part, because the resident also was a qualified super specialist, so that was not the issue. But the issue was that the consent was not taken and all these. And the criminal case against the two has been continued by the Kerala High Court. The civil is still going on. Another very interesting judgment, ERCP is the most dangerous endoscopic procedure. I think in place of ERCP, we can put angioplasty, angiography, any cardiac procedure. But look at the wordings, which deserves detailed discussion with thorough informed consent before the procedure. And the doctors should use their own complication data. In the legal concept of informed consent requires an open and honest discussion of the risk. It is not sufficient that you are giving data which American Heart Association has given. It is not important that you are giving data which American Gastrointestinal Endoscopy Society is giving. You have to give, or what the Indian Society is giving, you have to give your own complication data. This is something I thought is unique and deserves to be challenged, but then who will be the president and who's secretary? Medical records, in this case, the gentleman came with a roadside accident in intraperitoneal field, and the allegation was there was a lot of delay in doing a lot of things. The patient was not shifted straight to the OT to be operated. But the records showed that they had arranged 19 units of blood. Neurosurgical opinion was taken, multiple x-rays were done, IV fluid was administered, catheterization was done, NG tube placement was done, and all this was recorded. So 2 hours or so taken in this process could not be held as delay and complaint was dismissed. The patient had died. Separate consent is also necessary for giving a blood transfusion. This is something we tend to ignore. Patient admitted, we have taken one blanket consent, on the other basis we are working. This is the case. The surgeon took a plea in court that it was an emergency need for blood transfusion, hence consent could not be taken. Fine. The court said, but you have written in the medical records and the nurse's notes clearly had directions to keep 2 units of blood ready before the surgery. If you have already kept it in mind that this is going to be needed, what was the emergency? You already knew blood was needed, so you could have taken consent for blood transfusion and everything beforehand. And in case the doctor unfortunately dies or for whatever reason commits suicide, his estate still has to fight the case. And if your medical records are incomplete, you may know your case very well, you may know how to defend your case. But in case of your death, if your family has to fight, they will be able to fight only on the basis of the medical records which you have created. Sometimes in a hurry we write in the medical records but don't sign. Please remember, an unsigned medical record has no legal validity. We all know the ethics regulations say within 72 hours of a patient asking in writing for medical records, we have to provide those records. But in that ethics regulation, the issue was they have given an annexure as to what is the example of the medical records. That is simply a performa which writes name and very limited information. It does not mention complete operation notes, it does not mention complete post-operative notes. So far, we were getting away only with providing limited information. Like a discharge summary, if has been given, it used to contain mostly all the information which was relevant. But some courts have come up with that CPG records, monitoring records, operation notes, post-operative care notes, all these form endoscopy pictures, videos of surgery, all these form part of medical records, and not providing them to the patient constitutes negligence. Under RTI, even from a government institution, the patient or the relatives can ask for their medical records. This is the Central Information Commission judgment. Very interesting. So far we are talking only of hospital records. Let us see on OPD what happens. Patient of pterygium was operated by an ophthalmologist. Mitomycin was advised to be put in eye drops. The guy did not write into 10 days, 15 days, 30 days. The patient goes to the chemist, keeps buying and keeps putting the mitomycin. Unfortunately, due to mitomycin, some complication occurs. The doctor was penalized. But the court said there is only limited negligence because the patient also should have approached the doctor before purchasing the medicine from the chemist time and time again. But simply because it was not mentioned how many days the mitomycin was to be taken, he was penalized. Similar case, Christian Medical College, Vellore. And this is a criminal case which was filed. Patient of SLE. She was being treated with cyclophosphamide and bisolone. Developed menopause, referred to OB/GYN people. They did her FSH, which was found to be increased. They started her on hormone replacement therapy. This is on OPD basis. 2 years down the line, she develops infiltrating duct carcinoma breast. And now she says, I was never told, no prescription of mine, never was I counseled, that I need to have a mammogram every 1 to 2 years to check for possibility of infiltrating duct carcinoma. Thankfully, the High Court dismissed the criminal petition, though the civil petition is still on. And the statement we make in courts and our medical records, they should not be contradictory. In this particular case of missed abortion, 2 previous LSCs, DNC was done, patient had BP fall. Detailed treatment records were produced by the doctors in court, giving the justification that it was a case of air embolism. But our courts have also been educated by our number of cases coming there. So what do they ask? Sir, if it was, or madam, if it was a case of air embolism, what was the need of transfusing 4 units of blood? You have transfused 4 units of blood. If you say this was a case of air embolism, then what was the need of transfusing 4 units of blood? And how long to preserve the medical records? This gentleman took a plea that MCI guidelines require records to be maintained for 3 years and that he destroyed and the records after 3 years. But unfortunately, his case was filed 1 year after the incident and after the cause of action, and the court said, how can you destroy records of an ongoing case? Any sane person would not do that. PGI was penalized for not maintaining record of the make and type of the plastic stent used to, in a case of obstructive jaundice, they had placed a plastic stent. The extrapolation of this for cardiologists is obvious. Not only do you need to maintain your record, you also need to maintain what type of stent or what type of implant you are using. You maintain your records, but you don't file your records or your reply in court within 45 days. You forfeit your right to file a reply and any arguments and any records after that. All India Institute of Medical Sciences thought they were above everybody else and they did not file their reply in the State Consumer Dispute Redressal Commission. When they were asked to fine, the case will proceed, you cannot file your defense. You can come for arguments from for whatever the patient party has brought, but you can't bring in your own defense after 45 days. Records claim to be destroyed. Again, same thing. The courts felt that that elimination of record appears to be an attempt to suppress certain facts likely to be recovered from the history sheet. Another thing we forget sometimes is there is something called discovery rule. Doctors feel in consumer courts the case has to be filed within 2 years. Well, the Hindu Sharma case, they have quoted Williams' textbook of obstetrics, which says CTG records should be maintained for minimum 25 years. What does this mean? And they are quoting that to justify, okay, our consumer courts, according to CPA, the case has to be filed within 2 years. But this discovery rule and all these cases, it says 2 years from the time you have discovered that an error has been done. You have left a mop inside while operating. The patient discovers the mop was left inside 12 years later. So his 2 years are starting 12 plus 2, 14. So the question again arises, how long are you going to maintain your medical records? So the practical advice I give to most people is, every 5 years give an advertisement in a nondescript newspaper which nobody reads, that your hospital is going to destroy all previous medical records more than 5 years old. Anyone with any objection may approach you within 1 month of the publication, failing which you will destroy all the records. After 1 month, do not destroy the records. Later, when you get a notice or a case is filed against you, take legal opinion. Whether producing those non-destroyed records or taking shelter behind the notice you have published is to your advantage. And then proceed accordingly. Anyway, medical legal cases, 10 years you have to maintain your records. And even though there is dispute on this, I personally feel all maternity case records have to be preserved indefinitely, minimum for 21 years. In diagnosis, we at times make mistakes in reaching a diagnosis because of many reasons. All fever today are dengue unless proven otherwise. We all have a tendency to think we can exploit the residents and it doesn't matter. There is a question of vicarious liability. The hospital, the medical superintendent, the civil surgeon, all are responsible for any error done by the resident. And this attitude of ours, we have done work continuously for 72 hours in our residency days and the residents also today should do it, ideally is a problem. Because residents and interns, they leave the hospital after short duration, whereas cases of medical negligence carry on for decades. And it is the seniors, it is the permanent employees, it is the medical superintendents, it is the civil surgeons who will carry on fighting the cases. Unless it is a criminal case named against the resident, then whether he is from Chennai or from Kerala, he will have to keep coming back to Chandigarh to fight this case. And these were some government instructions also on how long duties residents can do. The Kunal Saha judgment also made a very critical comment that junior doctors and residents cannot act as second fiddle to treatment and fail to apply their mind if they think consultant is giving wrong treatment. I would have loved to see Anurag contradict Dr. Bali when he was in PGI and tell him, no, Dr. Bali, you are wrong. He would have been given a boot and he would never have finished his DM. That is the way medical profession and the training is. But our Supreme Court, unfortunately, seems to think that a junior resident should refute the senior in case he thinks something is wrong. And mind you, the junior resident there was penalized 5 lakhs. Resident doctors, 2 classical cases, all of you are well aware of these cases. Amit Sarkar versus PGI, this girl had her leg amputated in PGI after lying on a stretcher for 3 days. And Suman versus Government Multi-Speciality Hospital, this was a case of wrong blood transfusion. There were 2 Sumans and the blood bank gave the wrong Suman's blood brought by the relative of the patient. The intern was ordered by the house surgeon to go and transfuse blood. Blood was lying on the patient's bedside. She transfused, there was a reaction, and hell broke loose thereafter. Another error that we constantly do is something I call jousting. Anything done by me is God's will, but anything which the other person has done before me is absolute garbage. There could be no other word. This tendency among doctors, this ego, this me and mine and I, needs to go if we have to survive today in today's litigious environment. And mind you, these are some actual medical records. I am quoting, Dr. so-and-so called repeatedly but ignored as usual. This is a corporate hospital's medical record. Horrible scar of previous surgery done outside. This is a PGI record. As usual, no nurses available for help. This is a junior resident writing in Government Medical College, Chandigarh. These are things which are bound to cause problems. If these records come in the court, how do you expect to save anybody? In teaching hospitals, sometimes even without intending to sound critical or being critical, when we are teaching students, sometimes we say certain things and the patient is listening. We sometimes fail to realize that when he goes back, he is going to catch hold of his treating doctor. They were discussing this in my ward rounds. Among other mistakes, no indemnity insurance, only personal indemnity insurance, only hospital errors and omissions policy, indemnity insurance in 1:4, inadequate indemnity insurance. There are innumerable examples. Here what happened, when you fill the proposal form, the doctor had mentioned, I operate in Hope Clinic Maternity Center. But he was called in some other hospital and he operated there. The problem occurred there. Insurance company says, sir, we have covered you for doing the surgery in your hospital, which you have mentioned in the proposal form. Mind you, even if you write list of 10 hospitals or 100 hospitals in the proposal form, there is no change in your premium. Your premium remains the same. But it is simply you have to devote that much time or write one line and to other hospitals in Tri-City if called. But we are too busy. We simply tell the guy, 10,000 kithe sign karna to kar le yahan pe. This is our attitude. Creates a problem. Error and omission policy versus professional indemnity insurance. The one doctor who is running the nursing home is insured, but others are coming and operating. Error and omission policy has not been taken. Obviously, there is going to be a problem. Now, recently in Bangalore, this Karnataka High Court has given a judgment where an elective cesarean was going to be done. The doctors claimed immediately after giving anesthesia, the patient collapsed and they could not resuscitate, the patient died. Everything was prepared accordingly. Postmortem was done. Postmortem shows the patient had fractured hip and there was intraperitoneal bleed. Now the medical records nowhere have shown how the patient had that fractured hip and intraperitoneal bleed causing death. The postmortem report says the cause of death is the bleed. And medical records don't show that. Criminal case to continue. What must have happened? Patient is being shifted from the bed to the trolley or from the trolley to the bed and has fallen down. Who is shifting? Is the consultant shifting? No. Is the resident shifting? No. It is the class 4. You haven't taken any insurance for because it costs 7.5% extra. So unless and until you cover your unqualified attendants, this has happened in an MRI center also. Similarly, anesthesia for MRI causing death. No establishment policy has been taken. Individual doctor has taken his policy, not enough. 1:4 insurance, again not recommended. Now this doctor was working in civil hospital, Samrala. And this case came up in under Consumer Protection Act in State Commission dismissed it, went to National Commission again sent back to State Commission, shuttled 2-3 times. Finally, the doctors approached Supreme Court. They said nothing doing, the State Commission will decide. So State Commission gave a verdict of 3 lakhs compensation. The doctor, surprisingly, for a government doctor, had taken professional indemnity insurance, but he had taken insurance in 1:2. So the company said, we will pay only 1.5 lakhs, 1.5 you have to pay from your pocket. I have already covered this. Insurance has to be in the name of hospital as well as doctors. A lot of corporate hospitals have something called surcharge. I have personally also never understood the logic of this. But there is a 10%, 15% surcharge. Well, here, the Bombay hospital has been sued on this surcharge. Fortis Hospital has also been penalized for forcing the patient. This was Guillain-Barré syndrome and some immunoglobulins were to be injected. The patient's relatives said, okay, we'll get the immunoglobulins from outside. They said, no, you have to be given from here. And there was a cost difference of nearly 50%. So they approached the commission and they were awarded. Following adverse event, we tried to cover up premature declaration, release of death body, in case of OT unexplained death, never release, do a postmortem first, discarding used syringes, sometimes you give an injection, death occurs, used syringes and ampules need to be secured, have a copy of Prevention of Violence Against Medicare Service Personnel Act, especially in Punjab, still not applicable in Chandigarh, have a copy of Jacob Maxwell judgment. In case there is documentation lacking, even insurance company will refuse to pay the indemnity. What happens after you receive a legal notice? You send unnecessarily elaborate replies. Please never do that to the lawyer. When you get a notice from consumer court, you have to be very specific, very detailed, everything is alright. But when a lawyer sends you a legal notice, please simply reply, denied. Point number 1 denied, point number 2 denied, point number 3 denied. Do not send unnecessarily detailed response to a lawyer's notice. Never try to do a compassionate settlement out of court. Affidavits of colleagues. Problem with Dr. Soti, if Dr. Bali has given an affidavit, will always help in court. Records not being produced, Indu Sharma case, I just mentioned that. Blame game. The anesthetist blames the surgeon, one doctor blaming the other, definitely there is going to be compensation awarded. Both the senior doctors in Kunal Saha case wanted the junior doctor to take the rap. The junior doctor blamed the senior doctors. Obviously problem was going to be there. If you give conflicting statements in court, problem is going to be there. Kerala High Court, I just mentioned this particular case. The colonoscopy case also, where doctor was doing and the consultant who was sitting gave different reasons why the colonoscopy was abandoned, and on this the courts felt that they were trying to cover up. Select a proper advocate, do not go from the top, always select an advocate of the court. If your case is in district court, use an advocate who routinely appears in that district court. Do not take a Supreme Court advocate to a district court. Best defense ultimately is going to be prepared by you, not by your advocate. Use reasonably competent lawyer. No idea hiring Kapil Sibal. Biggest mistake, of course, is overconfidence. We are too expert to learn any legal issues. These things cannot happen to me. I am very well connected and can handle any situation. And of course, not being member of Medico's legal action group also is negligence. I invite you all to our third annual AMLAC annual conference. This is going to be held on 11th December, and I hope you will have many more queries answered there than what I can do in this short span of time. Thank you so very much.
Thank you very much, Dr. Neeraj. We know this topic is unending, and the questions and the issues are also, because this is the beginning of this subject in our community, and maybe problems are just
beginning to come. So any questions, Dr. Neeraj will pick up.
Yes. Hoping that there is no press here. Achha. Now, Dr. Neeraj, you have illustratively summarized the whole malady what we are suffering. I think in your forum, we are attending your meeting left and right. But the root cause, where it is, I'm an old timer of doctor, I have 50 years of my practice now. No, I don't practice now. Now the courts, they are not the doctors. As you rightly said, in oblique reference to that, the courts are being fed by my own people. And what I said, no fun blaming each other like that, and that you have already said you want to become president and he wants to become secretary, and the root cause for which you are going on Satyagraha, you will see on 16th what happens. I'll remind you the Honorable Health Minister was there and the committee was there and all these 6 problems were assured to be rooted out or assured to be. But after that committee, certain people said, "Hame MCI ka member bana dijiye." Now, problem is that now we find something. Dr. D.C. Gupta is always he is the member secretary National Commission. He is crying horse के आगे मुझे बता दो कि मैं क्या बताऊं जज को. ऐसा कुछ करना पड़ेगा. Otherwise things are going to be for my younger people. We have played our evening wonderfully or something like that. We'll have to get up in that way. Trade union we can't make it. That is my wish and was wish. So ये हमें कहीं ना कहीं जाके उस कमीशन में कोई ऐसे लोग बैठाने पड़ेंगे, चाहे पे दे, कुछ दे, ताकि उस वगैरह वाले बताते थे. You were there in that meeting when Dr. Gupta came. कि मुझे बताओ तो सही यार मैं क्या लिखूं इसके ऊपर. कहीं वो देखिए रूट काज पे जाइए, वरना तो ये सारे क्लिनिक ऐसे ही बंद हो जाएंगे.
I think the time has come when we have to put our heads together to develop SOPs for every single kind of event or whatever you like to say. These SOPs, it may take time. It's not going to happen overnight. If you have already developed some, I don't know. These standard operating procedures must be made available. It is then the responsibility of the individual doctor whether he uses those SOPs or not. At least the MLAC group or the IMA or whatever group takes up this responsibility has done its job. It is providing the SOPs that must be followed by everyone. The second thing is that please, what I notice is your OPD prescription slips are simply gone. They carry no information whatsoever. It's not even worth the paper it's written on. They're so perfunctory. We have to get out of this habit. We have to provide information. If you're providing advice, you have to provide information on what basis you have given that advice and what basis you are prescribing the treatment. I'm afraid this is a reality of today's world, and you have to do it. Please don't forget we talk about hospitals and clinics, but what are you talking about OPD? Prescriptions that come up time and over. Thank you.
Thank you so much, Dr. Neeraj, for sharing your views on medical legal issues. I would request Dr. S.S. Sodhi to please felicitate Dr. Neeraj Nagpal. I would request Dr. S.S. Sodhi to please stay back and present our memento to Dr. M.S. Trehan. Thank you so much. Curiosity is one of the permanent and certain characteristics of a vigorous intellect. So to satisfy this curiosity of our delegates, I would like to invite our next esteemed speaker, Dr. H.K. Bali, Director Cardiology, Fortis Hospital, Mohali. And to co-chair this session, I would request Dr. Sudhir Saxena, Dr. Sachin Pandal, and Dr. Anurag Sharma to please join us on time.
Good afternoon, friends. Dr. Mohali needs no introduction, an esteemed teacher and a very fine cardiologist, teacher to all of us from the point of time. And needs no introduction, as we all know, he is director of cardiology and is doing fabulous work in this region, and he is known all over the country as well as internationally. So, without wasting any further time, I think I will invite Dr. Mohali to deliver his lecture on acute coronary syndromes.
Good afternoon, everybody, and thank you very much, Sudhir, for kind words. At the outset, I would like to thank Dr. Puneet for inviting me to this August meeting. And I would also like to say that every time I listen to Dr. Neeraj Nalkar, I get extremely educated and get humbled that we're living in a time when we need to take care of our documentation as much as we do of our procedures. So my job today is to talk about conservative or early invasive approach, which is the better approach in patients with acute coronary syndrome. This topic has been with us for almost 30 years now, and a lot of data has accumulated over a period of time. In fact, some data has come up very recently, as late as 1 month ago, and I would like to look at that data as well. But this problem is more acute because when we talk of ST segment elevation myocardial infarction, we understand that earlier we intervene, immediately, without wasting 1 minute. That is what is best for these patients. Is it true for acute coronary syndrome also? Because there's so many cath labs mushrooming all over, it sometimes appears that when a patient with acute coronary syndrome comes, some of the cardiologists tend to shift the patient to the cath lab for an immediate angiography and procedure. So let's look at what is the data for acute coronary syndrome. We all know worldwide acute coronary syndrome is a major problem. In the West, ST segment elevation myocardial infarction is almost 1/4 or 1/5 of acute coronary syndrome as far as presentation is concerned. Although data from Indian hospital data, like the studies which have come from India, which are hospital-based studies, have shown that in India, acute coronary syndrome presentation is more common than ST segment elevation, but we need more data before we can conclude on that part. The question is, when a patient comes with acute coronary syndrome, should we intervene immediately or wait for a period of time? And we have been stratifying these patients with acute coronary syndrome for a long period of time, and we do so because, as we'll see over a period of time, that there is a limited benefit from revascularization on some subsets of patients, and we also know that across the country and world over, access to early angiography is limited. We do not have enough cath labs in world and in India certainly. And hospital admissions are enormous, so we cannot rush patients with acute coronary syndrome unless there is telling evidence to show that there is benefit of early or immediate coronary angiography. We have been stratifying these patients. I am not going to detail. We all know that low risk patients, intermediate risk patients, high risk patients, and now we have very high risk patients also. And data has shown that as compared to low risk patient where mortality is less than 3%, in very high risk patient it may be more than 15%. We have some scores available, TIMI score, which shows that age, elderly people, more than 3 coronary risk factors, prior coronary stenosis, aspirin used in the previous 7 days, more than 2 angina attacks in less than 24 hours, ST segment deviation on ECG, and elevated cardiac markers are important features. And as the number of these risk factors increases, the mortality keeps on increasing. If there is only one risk factor, one TIMI score 1, the mortality is less than 5%, but if all 7 are present, it is to the tune of almost 43%. We also have a grace risk score, which shows that as the risk score keeps on increasing, the mortality keeps on increasing. So what are the advantages of doing an early angiography? The benefits are, it defines the anatomy, we know what type of coronary we're dealing with. We can plan treatment, medical treatment, angioplasty or bypass. We can do an angioplasty at the same time, and we can also shorten the hospital stay. But there are definite risks with early angiography because we do not know comorbid conditions, investigations are not available, so complications are a little higher than when we have to wait. That can be in the form of myocardial infarction, stroke, vascular complications, sometimes contrast-induced renal failure and allergic reactions. And cost and facilities required obviously remain limitation. The first trial, which came in very early, it was a VA trial, VA non-Q-wall intervention trial. It was a negative trial. It showed that as compared to conservative treatment, when we undertake an early invasive treatment, the results are worse. This was of course very early. Then the subsequent trial showed, a TIMI 3B trial, showed that as the risk score increased, the benefit of invasive treatment became that much more important. When the risk score was higher, the benefit of early invasive was much better. Then we had an ICER pool trial, which showed that the hospital stay was decreased, mortality and myocardial infarction was much less in early invasive treatment, and particularly those group of patients who had ST segment deviation, who had elevated enzymes, whether it be a CME or troponin, or who had elevated or more TIMI score, had better benefit by early invasive treatment. Then a large trial was planned to answer all these questions, which was the ICTUS trial, but it again was a negative trial. It showed that early invasive treatment had no benefit over a conservative treatment. But what it showed, whereas the mortality was more in the early invasive group, myocardial infarction or readmission with acute coronary syndrome was lesser with early invasive treatment. So there was a contradictory evidence from this particular trial. So it actually is considered as a negative trial. Then a FRIS-2 trial was done, which showed that invasive treatment, early invasive, was superior to a non-invasive as far as myocardial infarction are concerned, death or myocardial infarction combination is concerned. And then we had a 5-year follow-up of this FRIS-2 trial, which showed that whereas there was no mortality benefit of early intervention, there was definite benefit of early intervention as far as myocardial infarction was concerned. So lesser myocardial infarction in patients who had early intervention. FRIS-2 trial, again, same in a graphic form, shows that no mortality benefit, but lesser myocardial infarction over a period of time. So it showed that early invasive strategy was associated with lesser mortality, and this benefit persisted for 5 years. But it was predominantly in myocardial infarction and not in death. Then we had a British trial, BETA 3 trial, which as compared to other invasive trials had a lesser incidence of early intervention. Only 49% at 1 month had intervention as compared to the trial which we see in subsequent trials. But what did it show? It showed that there was a mortality benefit with early intervention, and there was a cumulative death, myocardial infarction, and refractory angina benefit with early intervention. So primary outcome, death or non-fatal myocardial infarction, much better in early intervention trial, death much better with early intervention trials, and this is what it showed, that cumulative data, both death and myocardial infarction were lesser in early intervention trial. The conclusion of this trial was that early intervention results in fewer death and fewer non-fatal myocardial infarction, decreases the incidence of subsequent angina and revascularization, but the major part of benefit is seen in patients who have higher baseline risk factors. And in low risk factors, there is no great benefit seen. Then we have a Timex trial, and Timex trial again showed that early intervention had a benefit, and the benefit was predominantly in decreasing refractory ischemia. And those patients who have higher Gray score, higher than 140, had much more benefit than those who are low risk, as indicated by low Gray score. So then should we do an intervention immediately? The patient comes to the hospital, you take him to the cath lab straight away, and what does the data show? It was looked up in the abort trial, and it showed that immediate catheterization was not very greatly superior to waiting for a period of time. The only benefit was that it decreased the hospital stay. So a broad conclusion was a primary PCA strategy is feasible but does not reduce the risk of myocardial infarction or death, is not associated with significant difference in any other efficacy or safety evidence, and does not benefit any subgroup of patients, but certainly shortens the hospital stay. We recently, last year, had another trial, reader trial, showing again superiority of the immediate invasive treatment. Again, another trial which has come up last month, which is called the overrated study, confirmed that not only early invasive treatment is superior in younger individuals, it is superior in elderly patients as well. So the overwhelming data shows that early invasive treatment is superior to a conservative treatment in patients with acute coronary syndrome. But we have differences in trial, and why are there differences? The differences are because the baseline characteristics of these recruits in these trials are different. There's different timing when these interventions are carried out, and as we have evolved over a period of time, adjunctive treatment has also changed. But if you look at meta-analysis of all these trials, small, moderate size and large trial, it shows early invasive treatment is superior to early conservative treatment. So, 3 large trials, ICTUS trial, FRIX2 trial and RITA3 trials. RITA3 trial showed benefit at 2 years and benefit at 5 years. FRIX trial showed benefit at 2 years, no benefit at 5 years, mortality I am talking about. And ICTUS trial showed no benefit at 2 years, no benefit at 5 years as far as mortality was concerned. So what have we got? What is the evidence show? Does early intervention prevent death? Certainly not in low-risk patients. In high-risk patients, probably yes. It prevents remyocardial infarction, surely. It reduces hospital stay. It improves angina. It prevents rehospitalization. It reassures the patient. It reassures the referring physician, and it reduces cost. So let's look at the data is conflicting, and therefore a large meta-analysis was carried out consisting of these 3 trials, which are large trials and had a longer follow-up. And it showed, if we compare these 3 trials, we find that the people who were introduced in routine invasive as well as conservative arm were different. Whereas in the RITA3 trial, in routine invasive only 57 patients were present. In the ICTUS trial, in the selective invasive, that is the conservative treatment arm, 54% were enrolled. So obviously the enrollment was different. So what did meta-analysis of these 3 trials show? It showed that it improves, it has a mortality benefit, it prevents cardiovascular death, and it prevents cardiovascular death and myocardial infarction. So meta-analysis surely shows that early invasive is superior to a conservative treatment in this group of patients. Now let's look at mortality benefit. Cardiovascular death or myocardial infarction, superior. Univariate analysis was done up, and then they devised an integral score to find out who are the patients who benefit extensively by early intervention trial. And these integral score, which included age, diabetes, prior myocardial infarction, ST segment depression, hypertension, and BMI of this patient, showed that as the risk factor kept on increasing, the mortality benefit, the myocardial infarction risk factor was much better than the conservative trial. But even in the low risk group, there was a benefit with the early invasive treatment. So cumulative risk myocardial infarction risk spectrum, across the board there is benefit, but more the risk, more is the benefit. So as the risk factor keeps on increasing, the mortality benefit increases in this group of patients with early invasive treatment. Now we have a 10-year data of Theta-3 trials, which has been published in 2015, and it showed that the same trial, which had shown benefit at 5 years, over 10 years the mortality benefit has been lost. The conservative treatment is as good as marker infarction. There is slight advantage of as far as cardiovascular mortality is concerned, but again, the advantage seems to be getting lost. But again, as the risk factor is higher, the benefit in higher group of patients is seen. When we divide these patients by a gray score, higher the risk, moderate risk and low risk, the mortality benefit over 10 years is lost. Last month, we had a 15-year follow-up of FRISC-3 trial, FRISC-2 trial. And what does it show? It showed that there was no mortality benefit, and it continues to be so, but there is a definite benefit of lesser marker infarction over a period of 15 years in this group of patients. And ischemic readmissions and combination of ischemic admissions and death is lesser. What it showed was that patients who were non-smokers, patients who had tropoid elevations, and patients who had inflammatory marker GDF15 increased. These group of patients were the group of patients who benefited maximally by early intervention trials. So what does it do? Early intervention, it decreases readmissions, postpones death marker infarction by 18 months, ischemic events are lower, and there is a 37 months postponement of death or readmission for any cardiac event. So how do we treat these patients of acute coronary syndrome? Ongoing chest pain, hemodynamic or rhythm instability, if these features are present, these patients need to be taken for early, immediate care, urgent care. If they are not present, we look for risk factors. High-risk patients, they should have early, non-urgent care. And that would mean a care or an intervention within 24 hours. And if these features are not present, then these patients can be managed by conservative treatment. So how do we go about immediate invasive treatment? That is less than 2 hours. These are the recommendations of AHA-ACC 2014. In refractory angina, patients who have signs or symptoms of heart failure or new worsening mitral regurgitation or have hemodynamic instability or recurrent angina or rest, VT-VF, they should have an immediate, within 2 hours, an angiography. Early invasive, if the dropout is getting elevated, if there is a new or presumably new acid depression, if the patient is diabetic, if the patient has renal failure or has reduced LV function, these patients should have angiography within 24 hours. Those patients who have early post-infarction angina, PCI within the preceding 6 months, prior CABG or a gray score within 109 to 140, that is moderate gray score, should have a delayed invasive treatment. Sorry for the inconvenience. Thank you. So what we need to do is risk stratify this patient. High risk patients should have other interventions, other kind of weight. Thank you.
Thank you, Dr. Mohali, for the presentation. Just a couple of things for the mission of the audience. So we all know that we generally deal with non-STEMI patients or vascular angina patients who are high risk. Most of the patients that we get in India are high risk in the sense that they have multiple risk factors when they come to the hospital. So the message is very clear that most of these high risk patients, they have to be taken sooner than later. Just a couple of things. Do you still use upstream 2B3A inhibitors, which were plentifully used in the last 10 years? Especially when the patient or the attendants are not willing for a procedure immediately. Question number one. I'm asking. I'll ask you.
See, I think if we look at my practice, the use of 2B3 receptor blocker upstream has decreased very significantly. And that has happened precisely for the reason that we now have a stronger antiplatelet drugs, whether they are pressable or ticagrelor. And in the last couple of years, if I see, I rarely have used a 2B3 receptor blocker. But in those patients, occasional patients who suddenly says that I don't want an intervention. In that group of patients, probably you can use a 2B3 receptor blocker. And one needs to remember that we need to use a smaller molecule 2B3 receptor blocker. Abciximab has not been shown to be beneficial. In fact, it's harmful as used upstream. So tiraputam can be used, but I think it is extremely rare to use it nowadays.
Secondly, there would be a subgroup of patients in which you will have ECG changes, but troponin is negative. So what do you do with these kind of patients? Are you ready to wait and watch for some time with the patient attendants take time to decide? Or would you push for an angiography for these patients?
I think it's extremely important that if we can procure a previous ECG, which in the hustle of our daily practice sometimes we forget. But if we are sure that there are new ECG changes, then we need to take it as a high risk patient and take for early cancellation. But sometimes you can have persistent ST changes in patients who have previous acute coronary syndrome or some other reason. In those patients, obviously, you need to discount that. So comparison of ECG would be extremely important, and this is one of the high-risk features. And if TROPA is negative, I would say that this risk score would be around 3 or 4. So it will give a mortality of about 8 to 10%. So this is a high-risk patient and should be treated as a
And the third thing is, we still get calls from physicians from the periphery especially, who would like to give a thrombolytic therapy to these kind of patients. They still believe that thrombolytic therapy would probably work for unstable angina and cases or non-stable cases. So do we have the data today, any recent data where newer thrombolytic agents such as amylase has been used in these kind of cases? We all know that the previous generations like streptokinase, it was shown that it causes high mortality in these patients. It was given up totally. So do we have any data as of today that metalized can be used in some of these high-risk patients, especially if the patient is say 200 kilometers away, having ST regulations, having recurrent chest pain, having troponin positive, probably unwilling immediately to come over to Chandigarh?
I think the data is very strong on not using thrombolytic treatment in acute coronary syndrome. That's what I'm saying. I have not had an opportunity to review the thrombolytic treatment in the recent past, but I am of the opinion that in acute coronary syndrome, non-ST segment elevation marker infarction, despite the fact of TROPA elevation or whatever ST segment changes you might have, thrombolytic treatment has no role, and in fact it's contraindicated. I would like to be enlightened if there has been a recent change on this guideline or experience. I also seen, and I heard it in one of the conferences in Shimla, that in cardiogenic shock you can use thrombolytic treatment. So I think these two group of patients, acute coronary syndrome and cardiogenic shock, are contraindication. The only exception is that if you have a true posterior wall marker infarction, where there will be a ST segment depression in the anterior leads, in those cases you have missed the true posterior wall, or you diagnose true posterior wall, but there is a segment depression. So that is a group of patients probably where you would be. I would be recommending treatment. None of the other groups.
We are talking about evidence which is at least 10-15 years old. Do we have anything new? Because you see pharmacology in 15 years has changed. And do you think that there is need for some new trials now? Because we have better thrombolytic agents now, we have better antiplatelet agents to be used as a conjunction with thrombolytic therapy in these kind of patients. I'm talking about specifically.
I think if you look at the pathophysiology of acute coronary syndrome, you have a ruptured plaque and you have thrombin formation there and recurrent small embolization from their artery to artery embolization going downstream and causing acute coronary syndrome, TROPA elevation. I don't see a role of thrombolytic in that population. We use it because there's a large thrombus which is occluding in coronary artery, and that would get recanalized when used in ST segmentation marker infarction. So I don't think we are likely to get more enlightened on that. But we are all here, we live here for surprises. So I will not completely rule out, but as far as my understanding is concerned.
One of the interesting trials, and I think you must also be part of, probably, I don't know, is that is dual antiplatelet therapy really required these days? Because we have prasugrel, which is so strong agent, we have Linda, which is so strong. Do we really need an aspirin along with this? And I believe that at least 2 trials are addressing this issue, and we may find a different answer after. years. So I'm just talking out of box that is it a time that we should be thinking again about thrombolytic therapy in these patients?
See, the rationale behind using dual antiplatelet drug is not only they are stronger, we would use twice comfortably also. The rationale is we are blocking multiple pathways for activation of platelets. That's okay, but those are the two important ones. So therefore, I don't see, but if you have any data on the use of thrombolytic in acute coronary, I would like to take that.
So nowadays you get many high-strung IT professionals who are savvy with their knowledge, and he gets an ACS, right, and doesn't fall into the high TMA risk score, but he requests you that I want to see what all is happening inside. And in any way, even if it is a low risk, is the cardiologist always justified in doing a cath in such a situation if the patient so specifically asks? Because they want to make sure everything is 100% okay, and I don't want to take a chance.
I am not a strong votary of patients guiding my practice. I would never be, because patients do not have all the information at their disposal, whatever Google doctors or you talk about. So I believe that if you talk to the patient at great length and explain why you are doing or following a particular line of treatment, most of these patients would get convinced. So, but if somebody comes and even puts the gun at my temple and tells me to do an angiography, I will.
Such a moreover,
IT or no IT.
this will not be justifiable under any circumstances. Tomorrow, if something happens purely from angiography, you are trying to justify that you have done the angiography because the patient has demanded it. You will not be able to justify it on the basis of indications. Ultimately, you are putting your neck in the noose yourself. So, legally speaking, no question of being guided by the patient.
You can invasive treatment has finite complication rate. We might be able to decrease that finite complication to very low level, but it's never going to be seen. And therefore, it should not be done even if you are extremely experienced, you might have done thousands of angiography, but you will never be able to justify even one complication if it was avoided. So my suggestion is, unless there is a strong indication for angiography, and we have very clear list of where that issue is. If it is ambiguous, for example, you do not know there is a patient has got an LBB and you do not know how old the LBB is, or there is other non-restricted ECG changes where you are not sure about this condition. Patient has a pulmonary disease and you do not know there is overlap, how much could be the contribution of coronary arteries. Those are different side effects, but only on the basis of a patient demanding, no.
Then CT angiography should be, in such situation, the role of CT coronary angiography.
I think CT angiography has a role. It's a very high sensitivity, low specificity. So in patients, younger patients, where the risk of what we call as a pre-risk stratification, if you use a Bayes theorem, we want that. We believe that the chances of a person getting coronary artery disease are very low, but the symptoms are such that you would still like to rule it out. That is the only indication we are likely to use. Because what is the problem with angiography? Angiography problem is, one is you are taking the catheter to the coronary artery, and second is the dye. So dye in fact remains, and the dye is larger. The amount of dye used in CT angio is much larger than what is used in. So it's also for me invasive procedure, but to rule out in patients with the symptoms are suggesting, but your clinical acumen would tell that the chances of coronary arteries are low. That's the only indication that it is.
Actually, this is a everyday dilemma for cardiologists, that people beyond 60 years of age who have typical symptoms, who have probably dynamic ECG changes, are subjected to CT coronary angiographies, which is probably not correct, because the patient has got classical symptoms, ECG changes. What more do you want? Maybe a troponin is also positive. What more do you want for a diagnosis? So if the person needs a therapeutic intervention, then he should be sent for a proper catheter angiography. Why? Because doing a CT angiography, you are exposing him to X-rays, you are exposing him to the contrast media, not to speak about the price which is involved. Once that CT angio shows correctly or incorrectly a couple of lesions, Then the patient again goes to a catheter angiography, gets exposed to the X-rays again, gets exposed to the contrast media again, and has to pay again, basically. So this is something which should be very, very clear that these are not the patients who should be sent for a CT angiography. They should be sent only for a catheter intervention.
Thank you.
Thank you, sir. Thank you so much.
Thank you so much, sir, for your awakening session. I now request Dr. Puneet Verma to please felicitate Dr. H.K. Bali, the speaker of our last session. I also request Dr. Sudhir Saxena to please accept a small token of our gratitude. Dr. Sachin Pandav, please accept our gratitude. Dr. Anurag Sharma, please accept our gratitude in the form of a small token. Time to proceed, and it's time for an interactive quiz. So now I invite Dr. Karun Mehl and Dr. Rahul Katyar to please take the dais and continue with the interactive quiz session.
I would like to thank Puneet Verma for giving me this opportunity to present a few slides on this forum. I think I'm really grateful that I'm sharing the dais with my teachers, Dr. Bali, Dr. Saxena, Dr. Anurag Sharma, such a dear friend and an elder brother. So, unfortunately, I had a hectic night and a hectic day since morning, so I will not be taking too much of your time. So I will be just discussing a few ECGs. I think it's a presentation more for physicians rather than for my cardiology friends. And so this is just to make a few common clinical scenarios which we see in our routine clinical practice. So how to interpret them and probably how to treat them, and probably we like to have an interaction in between with all of you and with really some good inputs from my seniors as well. So coming on to the first case, like a young female, an 18-year-old girl, during her routine medical examination, she has got this ECG. I'm not really sure of, I think from that far, people can see this ECG.
Can you put the lights on?
It will be quite difficult for all of you to appreciate the ECG abnormality from that far off. Maybe I think, should I explain it? Because it will take time. Maybe anybody who will like to tell me what is this ECG like? Obviously not sir and Dr. Puneet or Dr. Anurag.
What do you want?
If somebody wants to, I'm just presenting a few clinical scenarios. If lights,
can you put the lights
so that
down?
people can have a better look at the projector.
लाइट्स कहाँ हो सकती है सर?
वो वही की हो जाए फ्रंट वाली
ये हो, आई थिंक इससे बेटर नहीं
हाँ नहीं वो पीछे वाली थोड़ा डार्क आ जाए.
Maybe if somebody would like to comment on this ECG. I think maybe Sachin, he's the only physician I can recognize. Yeah. You are very right. So what kind of an AV block this is likely, if you can see? So just again, just a brief that she's a young patient coming to your OPD just for a routine, maybe some viral illness or so. But during her routine examination, you found out that her pulse rate was exceptionally slow. So you ordered an ECG and her ECG looks like this. So this ECG, yeah, this will be much better now. So this ECG, it shows us that this girl is suffering from what we call as a complete heart block, and as she is hardly 18 years of age, so this is what as Sachin has rightly pointed out, say congenital complete heart block. So labeling a young patient, young female especially, with a congenital complete heart block and giving her probably distress for rest of her life. So what should be the management for such a patient? Like I think for most of us, most of the physicians will probably think that if it's a complete heart block, that patient probably should be ordered a PPI. But what about a patient who is so young and a female, probably that she will get married in maybe next couple of years? So what should be the line of approach, or what should be the management for such a patient? If anybody would like to enlighten me.
Do such patients develop a cardiomyopathy later on?
So that is something which only on the long-term follow-up you can say, but large majority of them will not. Large majority. So as I think I have not gone in for the number of things. Like as I pointed out, should we order a PPI for such a patient, and permanent pacemaker for a patient who is suffering from congenital complete heart block? As I have told you, she is asymptomatic. So that basically means she has got a normal LV function, she has got decent functional capacity as her age. So there are no symptom limitation as of now really. So probably PPI is not justified in such a patient. Do we really need Holter for such a patient? Would Holter serve any purpose? Yeah, can be ordered to really see the heart rate variability, but still, as far as the diagnosis is concerned, simple 12-lead ECG has clarified the diagnosis, but Holter can be ordered to really see whether it's a stable rhythm. But the best part about the ECG, if you really see, is that although it's a complete heart block, the escape, it's a narrow QRS. It's quite a narrow QRS, so that shows that as is there in the congenital complete heart block, the takeover in the junction is very high up. So it is likely to be quite a stable rhythm, and the rate is bound to be fairly enough, good enough. In this patient, this is around 45 or so. So even the pulse rate will not drop too much really. So that means basically these patients have quite stable rhythms. And Holter, yes, can be ordered. Like Holter and echo is definitely required to see if there is any underlying cardiomyopathy, any chamber dilatation. That is very important. And probably the most important investigation to order for such a patient would be a stress test or a treadmill test to really see her chronotropic competence. So what is the response during exercise? How her heart rate is during exercise? That will be the clinching factor whether this patient would need a PPI or not. But in large majority of such cases, probably they can just be simply be followed up, and she may not require a permanent pacemaker for at least per decades. So that is something which is very important. I think if any difference of opinion,
how would you like to follow this patient then? It's predominantly by an annual treadmill and an echo?
And maybe probably, I think first and foremost thing will be that would like to make the patient aware that she is suffering from this illness. You can tell her that like as of now you are absolutely asymptomatic, but somewhere down the lane, if you feel like excessive fatigue, you feel like out of breath with minimal activity, you have a history of loss of consciousness or pre-syncope or a syncope is there, we can make the patient aware of these are the symptoms which she can experience because of her illness during her future. So if a patient is intelligent enough, we can make them aware. If she is asymptomatic, as sir is pointing out, we can have a very regular, very methodical annual checkup, which would probably include an echocardiography, Holter, as well as a treadmill. So that is how I would approach such a patient.
Is there any data on the natural history of CCHP which dictates or determines at what stage should you be going in for a permanent pacemaker? Is ventricular dilatation a sufficient evidence, or maybe a decline in the myocardial kinetics over a period of time as the threshold at which level, at which time would you like to intervene?
Yeah, sir, again, although I'm not an electrophysiologist to absolutely answer the query raised by you, but definitely, as we have told out, chamber dilatation, a decrease in the ejection fraction, or the functional capacity limitation, as per my understanding, should be the guiding force which would tell us that probably we should go in for a permanent pacemaker for such a patient. But if maybe Dr. Bali has some other idea, or Dr. Rag, maybe that I'm still.
I think there are guidelines about on Holter if you're getting a RR interval is prolonged, or if you're getting sinus pauses in between.
Yeah.
And if you have dysfunction, as you
Yes,
said,
yes.
fraction less than 35% or so.
Right.
There are definite indications
Right.
for putting in a command pacemaker.
Right.
So if you feel that over a period of time it's becoming less stable, it's not as stable as it was earlier.
Right.
Those can be taken, but Anurag?
Going to high-grade plaque block, or it is
awake heart rate, it's very less than 40, and LV dysfunction. I think these are the and chronotropic incompetence. Patient is not able to collaborate.
Not whatever.
Chronotropic incompetence and high-grade blocks, very low heart rate, awake heart rate less than 40. Not all patients.
What I was asking was, is there any data on congenital complete heart block having been followed without a permanent pacemaker or in a natural? Because if you look at the good old studies of our science, natural histories of these conditions was very systematically studied.
Yeah.
But I'm sorry, I don't recall it.
These patients eventually will need a pacemaker.
Yes, they eventually
will. That all patients is not to
Class
be.
1 or class 2A. The first indications which you are telling are class 1. All patients given a PPI is class 2A.
Or I think maybe class 2.
It's class 2A.
2A.
2A or 2B?
2A. All patients congenital complete heart block given pacemaker class 2A. The other indications which you have told is class 1.
Yeah.
Their mother should be also worked up for F class and
That's very good.
Okay, good.
Go to the next one. Right. So I think again it's more for the EP guys to see for AH and HP interval to really see what is the cause of congenital complete heart block. And so coming on to the second scenario, in a young female, 22 years old female having recurrent palpitations for last 10 odd years. Now she has come to you in trials with the pregnancy of 6 to 8 weeks duration, and now she again has come to you with palpitations, and this is how her ECG looks like. Again, I think it's not a very projective. People can appreciate the ECG or not. I am really sorry. Occur as tachycardia, but yes. So whether it's a VT or it's an SVT with aberrancy, again there are pointers in the history as well, which really points us that young female who is having recurrent palpitations since last 10 odd years, and now she has come to us with this ECG. So let's believe that it's an SVT with aberrancy, and then how do we treat it? And I think we need to keep it in mind that she is pregnant for 6 odd weeks. With a drug of choice for such a patient. Anyone? I think so. I think Dr. Purohit knows everything. Whether we can give adenosine for such a patient or beta block diltiazem will be the better drug of choice for such a. So this is how our ECG looks like after reverted the rhythm to sinus. So it definitely shows us a pre-excitation after the reversion of the tachyarrhythmia to the normal sinus rhythm. It shows us it's a WPW syndrome, as sir has pointed out. So it's a pre-excitation. Right.
And of course, in this antidromic regular tachycardia, not an irregular tachycardia, of course, treatment options with drugs are open. Let's discuss those.
Previous probably continuing something.
No, I think diltiazem is not safe and not recommended in pregnancy.
Sir, injectable diltiazem is not an issue. Not an issue. Not an issue. So we can use calcium channel. Of course, we can use diltiazem as well as we can use metoprolol as well. We can use metoprolol as well. Adenosine, people still have concern. People are not very sure of adenosine, although its half-life is very less. But at times, as sir was pointing out, it really can at times precipitate VT-BF in such patients because it selectively decreases the action potential duration of the accessory pathway. So adenosine is not a very safe drug, and again, again, once they are going in for a pharmacological cardioversion, defibrillator should always be in hand in such a patient, especially because it can really degenerate into a VF.
I think the other differential you can discuss also is healthy origin VTs in structurally normal hearts which respond to calcium channel blockers.
Right.
There is another differential in such a case.
The next slide is the same. So again, it's a WB, very classical. I thought because for physicians, so I had chosen relatively simple slides. Case already I think picked up by Dr. Puneet, a young male, 34-year-old male, not very typical history, but still complains of palpitations in between. You firstly suspect that probably this male might have an underlying CAD. You subjected him to a stress echo, which apparently told that there doesn't seem to be a major issue as far as his probably coronary anatomy is concerned. And on his holter, you find ranzoviti. So probably again a young male with, although I will still say within inverted commas that stress eco-normal, that it excludes underlying obstructive CAD, it may not be very right, but yes for a large audience, probably a stress eco, otherwise in an asymptomatic patient with a structurally normal heart. So that this gentleman is throwing runs of VT in between. So we need to have a full evaluation as far as of a VT in structurally normal hearts is concerned. So and as sir is pointing out, especially if they are like VTs rising from RBOT or LBOT, drugs like beta blockers or even calcium channel blockers, they are the treatment of choice for such patients. And again, I think it's more for EP guys really to, but just for this forum, I thought it would be next very wise slide after an accessory pathway slide.
Polymorphic VTs are not ablatable VTs. It's a polymorphic VT.
Yeah, it's a polymorphic VT. So again, I have not honestly gone in, but we need to rule out any underlying metabolic disturbances in this patient. So you need to see for any hypokalemia.
I don't know, is this more like torsades?
Yeah, it looks more like torsades. So again, he was pointing out it's not a monomorphic VT.
It's not the...
So we need to rule out underlying hypomagnesemia. Pardon?
We are not discussing ablatable VTs. Polymorphic VTs are not ablatable.
But primarily we need to look out for the metabolic disturbances in this guy first, right? So to find out whether it's an underlying hypokalemia or a hypomagnesemia, which will probably push a polymorphic or a TDP type of arrhythmia in such a patient. Again, a patient without any apparent drug history also. And obviously, if we are not able to find out, as Dr. Preet is saying, that probably this is not an arrhythmia which will be ablating. I'm trying to tell you, if this is a rhythm disturbance without any hemodynamic compromise, so maybe drugs can be tried off if there is no metabolic disturbances. But otherwise, then again, probably this patient needs a mapping or might end up needing a PPI.
I think for this audience it is important to say that this type of arrhythmia, you need, once you have excluded the metabolic factors, you need to go into detail of this drug intake very clearly.
Right.
And some of the very common used drugs, like alprazolam and antibiotics are right to do that.
Right.
I feel that once that is ruled out, overdrive dressing is something which can be tried, but I'm not sure whether we need to look for a pacemaker or something. Most of them are self-limiting and they have a treatable cause which can be excluded, but I would like to be better.
So that is, I think, that's a better justification. Try to find out the treatable cause, maybe a drug or maybe a metabolic disturbance which might have pushed such a guy into this sort of rhythm. Again, on an ECG brought to you by a patient that shows a paced rhythm. Again, it was for the physicians only. So the ECG, it shows a big pacing spike before each QRS, so it shows a paced rhythm. So what we need to see in an ECG on an apparent pacing rhythm, if there is a paced rhythm, whether it's a single chamber or a dual chamber pacing, we can see from single or double spike. If there is some sensing or a pacing evidence or a abnormality there, that can be seen. And if one can appreciate P wave before each spike or before every QRS, that to really see whether it's a single or a dual chamber pacing or a single chamber, and if the spikes are so big, what does that imply? So this is what has to be seen on an ECG showing a paced rhythm. Maybe, sir, if anybody wants to add anything over and above this. And next case, that is a 92-year-old male presented to you with difficulty in breathing, and he gives you a history of a PPI done 3 years back. So what is this rhythm looks like? I think all of us can clearly see there are two spikes. So it shows an atrial pacing as well as a ventricular pacing, and there is a definitely broad QRS. So probably that this patient, so we need to evaluate for his LV function. This patient in all probability will have an LV dysfunction, and which is responsible for his symptoms. But otherwise, there seems to be no issue as far as his pacing is concerned. There is a consistent pacing in both atrial and ventricle, and whether it's a biventricular pacing or it's a dual chamber pacing, that one can see. And if it's a dual chamber, it's a biventricular pacing. Obviously, if the QRS can get narrowed down, so that is what we are always trying to achieve with a biventricular pacing for such patients. And 75-year-old male with a history of 2 episodes of syncope, previously has a history of CAD and has a poor ejection fraction of around 25-28%, and this is what his ECG looks like. I think this is the ECG, and this is definitely some ECG abnormality which is already marked on this, which one can easily see. So again, a very clear-cut slide. This shows that this gentleman is having probably recurrent underlying ventricular tachycardia. There are definitely what we call as a fusion beats and capture beats, which really shows that there is an underlying AV dissociation. So this is a VT rhythm this gentleman has a poor LV function and has a recurrent VTs. So this is how the ECG traces below, they are normal without any VT.
So, if you can just clarify to the audience as just briefly treatment modalities and polymorphic VT, what other drugs do we use? Treatment modalities in a monomorphic VT with LV dysfunction, and with normal LV functions. Say an ILVT coming and polymorphic VT coming, what drugs would you use? I mean, just briefly, and a monomorphic LV dysfunction VT.
Any VT and with an LV dysfunction, honestly, and if the rhythm is VT, or if somebody is even not sure whether it's a VT or it's an SVT with epilepsy, I think there are very simple pointers. If a patient has a previous history of an underlying CAD or LV dysfunction, always treat it as a VT. Any broad QRS tachycardia, always treat it as a VT. And first and foremost thing which we need to see for such patients is whether they are hemodynamically stable or there is an hemodynamic compromise. Obviously, if there is an hemodynamic compromise, no role of any drugs, just do the DC cardioversion at the earliest. And like as sir is saying, it's a like VT with an underlying LV dysfunction. If you want to think of drugs, that patient is quite hemodynamically stable. Only drug which I can think of which is available in our armamentarium is an amiodarone or cordron or a beta blocker, maybe an injectable beta blockers which we can think of. Otherwise, a polymorphic VT with an hemodynamic compromise, as we have told, is almost and always it is to be a DC cardioverted. And a monomorphic VT in a structurally normal heart or with a normal LV ejection fraction, one can really think of a beta blockers or a calcium channel blocker or even a class 3 antiarrhythmic like maybe a sotalol or an amiodarone. Those can be thought of. I think if anybody wants to add over and over.
And polymorphic VT would...
Yeah, it will almost always warrant a cardioversion.
So, do try and overdrive pacing in patients with polymorphic VT.
Yes.
Yeah,
you would.
Sir is very right. Sir is very right. I recently had one patient. I told you I had implanted an AHCD on her 4 years back, and now she came. So we did an overdrive pacing. It was a VT for almost 48 hours. But so it just terminated with VT. I terminated. It was a slow VT, so terminated with overdrive pacing. That's very right.
So congenital long VT generally will be better off with beta blockers, and acquired long VT will be better off with overdrive pacing.
Right. So in the last case, like as we have discussed, probably patient had a syncope, now hasn't got an LV dysfunction, then probably the first and foremost thing which we'll go ahead to do is a coronary angiogram for such a patient to really see if there is any treatable cause, so that his LV function can be improved. Otherwise, this gentleman would need a after revascularization, he would probably end up needing a PPI. End up needing an ACD. Next case, that is an 85-year-old lady, had a syncope one episode and comes to you with basic history of difficulty in breathing on exertion and has a normal LVEF on echocardiogram, and her ECG on presentations shows us an AV block that's a second degree, Mobitz type 2 second degree AV block. So I think it's quite clear, and there is a definite PV which was not conducted, and this patient deserves a permanent pacemaker. And so I think so this
go back on that slide.
Only one PV is stopping.
No. This is very clear cut. There are number of. So this is a PV which is conducted. Probably there is another PV as well which is conducted.
If that is a PV, that's a blocked ABC. I don't think that's a non-conductive.
This is a PV.
No, this
there is only one
this
PV
is a
which is
PV.
rich, and that's all.
And rest all are normal. This is only PV.
So you can't call it Mobitz type.
No, see there are.
It's a
See what you see is one drop P wave, but when you look at the other things, the age, the RBBB which is there, and
once we call it advanced AV block, you need to have two consecutive P waves which are missed. That is theoretical definition of advanced AV block.
absolutely, I mean that's.
So in this ECG, you can't say it's Mobitz type 2. In clinical scenario, we are fitting things, we are advising something that's a different issue, but theoretically this is not Mobitz type 2.
My understanding was that this is like 4:3 second degree block. It's a Mobitz type 2.
All PRs are constant, only one thing is missed.
The PQRS ratio is also maintained. So it is just one kV block, very low grade kV block. You can say because of the RBB baseline. Otherwise you can't be told AV dissociation. There is no AV dissociation here.
Definitely. P is conducted. Every P is conducted. It's not an AV dissociation.
One drop. One QRS is not conducted.
It's probably kind of a full maybe a full PR 180, 190 or maybe 200. RBB with the right word tail maybe pointing towards a posterior heavy block with a right bundle. So could be a borderline trifascicular.
The P which is missed is actually a ABC. It's a blocked ABC. It's not a. It's a blocked ABC rather.
Absolutely.
I can't call it a drop also.
We are in agreement on that. It is just that the clinical scenario and the baseline ECG might be suggestive of even a greater sclerodegenerative pathology which may be there.
Right.
Yes, sir.
QT interval of very interesting.
Can you just go back?
Yeah, this is the QT. 523 milliseconds.
Well, the machine may be showing 5. Broadly speaking, sir, if your QT interval is less than 50% of the RR interval, it means that the QT is not significant. This is how, on a spot ECG, you make an assessment. Here, I agree, it's a borderline kind of a QT, but then that QT is we don't know the real scenario of this lady. What are the additional? Is there any electrolyte imbalance, or is there any drug influence on that? And apparently,
Seems to be the first thing to do.
Right. So I think that is very important. That
no, certainly. I mean,
that would be very good. But again, I think last case, that is 62-year-old male with a past history of coronary artery bypass graft and a poor LV function of around 25%, and has a recurrent hospitalizations because of left heart failure. You do his angiogram and you find the grafts are patent, and this is how his ECG looks like. And so I think again, for cardiologists it's an easy pick, but maybe for physicians, again it's a broad QRS and it's an LBB morphology, IVCD going towards LBB, and QRS duration is almost 187 milliseconds. So probably what should be the treatment modality for with an EF of less than 30% and recurrent hospitalizations because of heart failure. And I think even Dr. Bali was pointing out, I think 7 days, 8 days back only, probably we need to have a look at renal arteries of such patients as well, probably which pushes these patients into flash pulmonary edema, because we had a similar patient 2-3 days back, and then probably this is the treatment of choice for such a patient. But yes, again, there may be divergence of opinion. Anybody would like to add?
All right, I just want to say that CRTD is the right way to go about it. But supposing there is a financial issue, which one you will prefer? Would you give him an ICD or would you give him a CRTD?
P, it has to be P.
Yes, of 28%?
Whatever it is.
Yeah, so
not an ICD. ICD has a stronger indication.
No, there are
After
very
the recent
few people
data,
who will
primary
ask to have
prevention
it
has
too
no
short.
stronger.
But whatever
So
life
that
she
is
has, she will
dilated
get
cardiac. You were dealing with a post-ischemic cardiac.
it has to be CRTP. So you might improve his or her ejection fraction significantly, so that she doesn't recover. The patient is not probably falling into the category of a primary prevention, and probably because as patient is having recurrent hospitalization because of heart failure, so then probably CRTP is the answer for such a patient.
see, ischemic cardiomyopathies post CRT, they don't really show a dramatic increase in EFs.
Absolutely.
As much as there is some correction of intraventricular dysynchrony, we accept that.
Absolutely.
There is certainly an improvement in the diastolic properties of the heart,
Right.
which to a large extent is also responsible for control of heart failure episodes.
Absolutely.
But the arrhythmic protection has to be accorded by the defibrillator only.
Right. Ms. Sarva just asking
So without a doubt, it has to be CRTD.
Yeah.
CRTD there is no problem.
Sorry?
The problem is CRTD is not affordable. So you have a choice between CRTP and ICD. What would you pick?
No, certainly between us, I'll go for CRTP.
Yeah, that's what the answer.
That is it.
Certainly go for, because that's the only way you can modulate the myocardial substrate with just an ICD which is doing at that for most times of the
EF of 28%. Post CABG, ischemic, we're dealing with ischemic cardiomyopathy.
Yes.
ICD is a class 1 indication.
It is conditional that the intraventricular episodes of heart failure are not there.
No.
If episodes of heart failure are there and the expected survival is supposed to be less than 6 months. ICD not indicated.
Yes, sir, because in this scenario there is a heart failure patient who is having recurrent admissions because of heart failure.
So what does kill these patients? Does a pulmonary edema kill these patients or does a PTVS
This
kill
patient
them?
pulmonary edema will kill because whenever we look at sudden cardiac death data, it is more in MIH 2 rather than MIH 3 and 4. That's very clear. So we first have to make our
So
MIH 2.
you mean to say that if you did not have a history of pulmonary edema in this patient,
No.
hospitalization?
Now don't increase further complexities in the question. If she does not have
No, no, the issue is all acute LVF, third episode in
yes,
6 months.
she is almost class 3 to class 4. If she is class 2, yes. Stable heart failure, ischemic, class 1 indication, no doubt.
Next.
But he is carrying acute LVF in the past 6 months, 3 admissions.
Yes.
So these are not fictitious patients. So what did you do? You tell us what happened. What was advised and
I
what
think
did
there
you
is an issue with the QRS calculation here by the computer. So I don't think this is 180 milliseconds by any stretch.
Like, sir, it is
Yes, sir, broad.
more than 3.5 small scale.
150
It's
or
definitely around 180 milliseconds. It's not.
So we lodge to
That's a quite. The only thing is because of underlying ICMP, sir is saying the result may
This
not be
patient is
very
having
different.
extensive anterolateral infarct, may not improve with CRT.
That is, sir, you are always taking this. Even if
There
it's
is
an
not
ideal
typical
case,
LBBB. If you see the
Yeah, it is
V6,
not typical.
the V6 is not typical of LBBB.
No, see,
it's an IDC.
ideally what you do is if grafts are patent, you still like to take them up for a rest spec study to see if your posterolateral area is infarcted or is it viable, right? If it is infarcted, there is no point in going in for a CRT. And what Dr. Bali says may carry a greater meaning, just give a simple ICD.
You have to document dysynchrony, whether they have and muscle thickness, in which part.
Sir, as far as dysynchrony is concerned, as there is, I don't feel maybe an EP guy may be able to answer it better.
No, but having said that, there is no guideline
There are no guidelines
which
as
shows
far as
that you have to document a desynchrony.
Sorry?
You have to document desynchrony. There are no guidelines.
Agree.
Guidelines only show EF, function class, no response to medical treatment.
There are recommendations. I don't know whether it's a guideline, but suppose this patient had a narrower QRS, but on your advanced strain imaging, on echocardiography, you found that there is definite dysynchrony, whether it is inter or intraventricular. You would advise a CRT.
No.
Sir,
Yes.
ACCH.
If you look at the React trial,
Yeah.
Exactly.
no response. Even in that subgroup of patients who are documented.
This is for a subset of patients, sir, who are QRS more than 120, between 120 to 135.
Yeah. Like above 150, you don't need anything, honestly. No?
Honestly, then it's a surface ECG.
It's a sufficient
It's surface ECG, your episodes of heart failure, echo is just for corroborating the EF. And of course, if you have done a angio and shown that grafts are fine, or otherwise coronaries are not showing any reversible, nothing treatable, then I think that is where things would go.
I think, like, even
No,
What is your take? What is your take, please?
No, my understanding of
Yes.
the literature, not my take, my understanding of the literature is that there is no guideline, no clinical trial which shows desynchrony, tells you whether you need to do a synchronization or not, echocardiography. There have been large number of trials. Even the subgroup analysis of the React trial did not show benefit when the QRS was narrow, even in the presence of desynchrony. What you need is a QRS prolongation, and the sweet spot is 130 to 150 milliseconds.
Yes.
That is when you will have the maximum response. But if you have a narrow QRS, irrespective of the fact whether you have a desynchrony or not,
yes,
the CRT will not benefit. That's my understanding of the data, but I am ready to learn from it.
No, in what QRS width are you talking? Beyond 150, we are talking about between 120 to, it's a very narrow range, 120 to 135 or 110.
Left side we have a district heart failure of mentioned and the center of breathlessness. This is my
most probably.
That's most probably two factors.
Other differences are also there, like
What are the differentials in this?
as people is 83 years old, it can be lung carcinoma. It's just
It's a very well defined kind of a large point shadow.
yes.
Very clearly demarcated from the rest of the lung margins and carcinoma, I'm not too sure of it. You are the expert, you can tell us.
The most appropriate diagnosis is phantom tumor only. Though age, we can suspect carcinoma also in this age group. If clinical symptoms like breathlessness, swollen legs, so we can make it out that it can be due to congestive heart failure.
Diagnosis excluded.
There is no air bronchogram in this, so either it's a fluid, and if you say malignancy, there is no penetration. It's not. It's a very smooth margin.
Yeah.
So it can be a tumor like mesothelioma or something, but not not CLM.
Yes.
CLM will not have such findings. So either it's a pleural tumor or it's a phantom tumor because of lobar facial effusion. Because height is exactly the same of interlobar effusion.
Yes. So it is phantom tumor. Next case. A patient presented with complaints of sore throat and chest pain in the superior chest radiating to the neck. So we did an X-ray and there is a sign in this X-ray. Can anyone tell? Doctor. So, Dr. Supal. Yes, pneumopericardium. And what is the management for it?
No, how do you straight away come to pneumo?
Sir, there is a
you must explain the radiological features of.
There is a there is rim of air around mediastinum like this, and there is specific sign. There is air below between the heart and diaphragm. So we can directly suspect mediastinum in this case. And management is high flow oxygen in this case also. But sometimes intercostal drainage tube is also inserted because such cases are mostly associated with pneumothorax.
But there is none in this case. There is no pneumothorax.
No pneumothorax. So management is high flow oxygen only in this case.
What will be the causes for pneumonia?
There are several causes like trauma. There can be in such cases can occur in exacerbation of COPD, bronchial asthma. It can also occur in some infections.
Can it be due to any rupture of any subpleural bleb also?
Yes, sir. Yes.
Line of treatment will remain
same.
It will atmospheric oxygen. One.
Yes.
Second, it will be acute presentation. A patient can present as a retrosternal or retrosternal burning also.
Yes.
That will be a presentation. And the previous, that was phantom tumor. We will have a DD of solitary pulmonary nodules will fall in this. But the presentation of this patient is acute. That shows fluid overload. That is why we go towards the phantom tumor.
Yes. And size are also
it is in the level of the horizontal patient and clinical presentation. That differentiates towards the phantom tumor, not any other feature of the solitary pulmonary nodule, that is carcinogenic or anything else.
Now, a patient presents with breathlessness, fever, and pedal edema. Look at the X-ray carefully. Request Dr. Puneet to kindly.
You ask the audience first.
Any volunteer?
So what are the lungs like? What is there's a cardiomegaly with a CT ratio almost, I think, 65%. Well, at the outset, I must first greatly admire and thank two people in this audience who have actually belied all expectations. I mean, with due respects to Dr. Sabru, I know he's been our teacher for such a long time, but I must admire his commitment to the cause. Even at this time, he's with us since morning, non-stop. And thank you so much, ma'am, Dr. Mrs. Ranjit Kaur. I never really thought a chief guest of a medical conference would actually be the first person to arrive in this hall, and probably amongst the last to leave, which leaves me with a lot of sense of awe for a lady of her character, and I don't know how to express myself for the time she has devoted to us for this cause. I mean, I understand I'm sure she must be taking back some useful learning tips from this conference, what she actually started the session with. And had I known that she is such a good speaker, I would have invited her as a faculty to be in this conference rather than as a chief guest. So thank you so much, ma'am, for making it happen for us today. And thank you, Dr. Sabru. It's always an honor to have you, sir, with us. So as we wind up the 5th CME, another year has flown by, and time just seems to fly by. But I feel that we must firmly keep our feet grounded in an endeavor to practice our profession, our medicine, very systematically and ethically for the benefit of our patients and society. This is something we always tend to forget in our day-to-day practice. And I think maybe once we keep doing such conferences, meeting all of you learned people, it encourages us and motivates us to even, carry on with this mission of providing such platforms to share ideas with all you wonderful people. So thank you so much. And ladies, it was a very hectic marriage function going on, and then we got this hall at about 4 o'clock in the morning. So thank you, Amit, for the pain taken to ensure a very smooth conduct of the proceedings. Finally, my sincere gratitude and thanks to my colleagues and from the pharmaceutical and the device industry for having taken pains to participate in this cause, without whose participation also I feel we would not have been able to present to you such a program today. So here's wishing you all good times, healthy lives in the times to come, and hoping to see you next year once again. Thank you so much, and please enjoy your evening.